Cable, are you ready? Okay, great. Good morning. I'd like to call this hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Thursday, February 16th, 2023. The time is 9:32 a.m. and we are holding a hybrid hearing with the government witnesses testifying in person and public witnesses testifying via the Zoom internet platform. This meeting is being broadcast live on cable channel 12 and my YouTube page at CMC Henderson. Today, we will hear public witness and government testimony for two agencies under the Committee on Health: the District of Columbia Department of Healthcare Finance and the Office of the Deputy Mayor for Health and Human Services. Today, we will hear first testimony from public witnesses for healthcare finance and then public witnesses for DMHHS. The Department of Healthcare Finance administers the district's Medicaid program, as well as the state child health insurance program, the Healthcare Alliance, and the Immigrants Children Program. The mission of DHCF is to improve healthcare outcomes by providing access to comprehensive, cost-effective, and quality healthcare services for residents of the District of Columbia. The agency provides healthcare services to more than 320,000 District of Columbia residents, approximately half of all residents. The Office of the Deputy Mayor for Health and Human Services supports the mayor in coordinating a comprehensive system of benefits, goods, and services across multiple agencies to ensure that children, youth, and adults with and without disabilities can live healthy, meaningful, and productive lives. In addition to overseeing operations of the agency within its cluster, DMHHS also leads the Interagency Council on Homelessness, the Age-Friendly DC Strategic Plan implementation, and the CARES program for encampment closures. The committee sent written pre-hearing questions to DHCF and DMHHS, and we will reference those materials today. If anyone would like to see those materials, they can be found on the council website. I don't see any of my colleagues who are here for opening statements, so I'm going to go ahead and move to public witness testimony, as we do have a lengthy list this morning. Before I get started, I want to review the testimony guidelines for public witnesses. Witnesses representing an organization will have 5 minutes to speak, and witnesses testifying on their own behalf will have 3 minutes. We will have a clock that will begin counting down as soon as you begin speaking, and I will let you know when your time has expired. Given the length of today's witness list, we will keep to the clock, so please be mindful of that. All right. For those, well, we'll get to that later. So we're going to call on the first panel of witnesses now. We're going to call 5 at a time. You will need to proactively accept our invitation to be promoted to panelists. So Jacqueline Bowens from the DC Hospital Association, Anita Jenkins, CEO of Howard University Hospital, Blanche McLeod, public witness, Tina Nelson, managing attorney for the Legal Counsel for the Elderly, and Mark Miller, long-term care ombudsman, Office of the DC Long-Term Care Ombudsman. All right, I see Jackie. No, I don't see her. There she is.
Okay, there I am. Can you hear me?
Yep. Yes, ma'am. Go right ahead.
Okay, thank you. Good morning, everybody. Greetings, Chairman Henderson and members of the Committee on Health. My name is Jacqueline Bowens, and I'm the President and CEO of the District of Columbia Hospital Association. As mentioned, I'm joined today by Ms. Anita Jenkins, the CEO of Howard University Hospital, and the DCHA board member. I appreciate the opportunity to present testimony at the Department of Healthcare Finance's 2023 Performance Oversight hearing. For the last 3 years, DCHA members, associates, and colleagues throughout the healthcare and human care systems have been working nonstop on the front lines to meet the needs of our patients, including Medicaid and Alliance beneficiaries. Our hospitals continue to work collaboratively with the Department of Healthcare Finance to ensure services are accessible to residents throughout the city. The district's hospitals and the Department of Healthcare Finance are central partners in ensuring the healthcare needs of the district residents are met. Under the direction of the Deputy Mayor Wayne Turnage and Medicaid Director Melissa Bird, the Department of Healthcare Finance continues adapting to the needs of healthcare residents and making policy changes that allow healthcare providers across the continuum. This is especially crucial at a time when the agency will begin winding down the public health emergency, something they have been preparing for a while to ensure smooth transition. As our members and others across the healthcare system adjust to the new normal, it's clear the two largest problems we continue to face is the impact of delayed care and having the healthcare workforce we need in place to care for individuals throughout the continuum of care. In particular, it is critical that the department continue its work with frontline providers, including home health and assisted living providers, to ensure that reimbursement rates reflect the higher wages needed to recruit and retain staff that allow our patients to be served at facilities and at home. This effort began last year, and the department's hard work will need to continue as we all look to ways to make reimbursement meet the demands of wages and ensure sustainability within the healthcare system. Over the last several years, DCHA and department have worked to improve the transmission of discharge information from the hospital to follow-up providers through CRISP DC. The work being done now with our members, CRISP, and the department is key to ensuring discharge information moves with the patient as quickly as possible. Over the last fiscal year, we've implemented pilot projects to better understand the system challenges that block the flow of information and identify best practices for providers. That work continues with CRISP DC, our hospital, and other providers. Finally, DCHA is focused on ensuring that MCO transition is smooth as we keep the beneficiary at the center of the process. We know that DHCF is holding providers and MCOs accountable to ensure that patients have access no matter where they seek care. The process implemented by DCHF is working and holding both sides accountable. In closing, I want to reiterate that DCHA looks forward to our continued collaboration with the department. Thank you for allowing me to testify today, and I'm happy to answer any questions you may have, and I'll turn it over to Ms. Jenkins.
Thank you, Ms. Bowens. Ms. Jenkins?
Good morning. I continue on. My name is Anita Jenkins. I am the Vice Chair for DC Hospital Association and CEO of Howard University Hospital. I want to take a moment to acknowledge the DC Council for their leadership and foresight, and recognize Deputy Mayor for Health and Human Services and Council Member and Chairperson Ms. Henderson, and the Committee on Health, as well as my colleagues who may be in attendance. I am pleased to be here with President Jackie Bowens to present testimony on our thoughts for healthcare in the District of Columbia. Howard University Hospital has a rich legacy of leadership and service dating back to 1862. Housed and converted barracks, it was initially called Freedmen's Hospital and provided a refuge where formerly enslaved persons and Civil War veterans escaped to receive medical care. And we now are the only teaching hospital located on the campus of a Black university, educating and training more African-American and minority medical students on an annual basis in the country. This contributes to a pipeline of African-American physicians and serving Washington, D.C. area and the nation. Many of these physicians continue to work here in our underserved areas. Today, we continue the mission to meet the healthcare needs of all DC residents. Howard University Hospital is one of 4 level 1 trauma centers in the city. We serve as DC's safety net hospital and a reliable healthcare provider for underserved populations. In fact, 50% of our admissions come from wards 5, 7, and 8. Our physicians have always provided specialty care to patients east of the river, and will always serve our former patients from DC General, the former DC General, and Providence Hospital, which have been shuttered. Howard University Hospital provided over $9 million in charity care in the fiscal year 21 and 22. This investment has been critical in raising the city's healthcare inequities. We are also able to provide this care because of our dedicated staff members, as well as the continued support from the mayor, the Council and Department of Healthcare Finance in funding Medicaid reimbursements, as well as Medicaid disproportionate share hospital payments. However, post-pandemic, one of the biggest challenges we face is the inability to move patients out of the hospital in a safe and timely manner. Our patients prefer not to stay in the hospitals any longer than necessary. Family and friends want to see loved ones go home rapidly, and the hospital's care teams always want their patients safely discharged. But some patients can't leave the hospital even after being medically cleared. Their hospitalizations can be measured in weeks, months, and sometimes years. There are patients with nowhere to go or no one who will accept them. This is a perfect storm that factors keeping them in our hospitals for extraordinary and unnecessary lengths of time, where they no longer need this level of care, but don't have family members or resources or mental or physical capacities to be discharged on their own. When this occurs, hospitals receive no reimbursement for their extended care. On any given day, there are many patients who have been hospitalized over their expected length of stay. These patients are in hospital limbo, stuck in hospitals because there are no facilities who will take them or cannot take them. It can cost thousands of dollars per day per patient. This includes manpower, utilities, food, medicine, and other resources. This is not just a DHCF issue. However, it's an issue we face across payers. I want to thank Deputy Mayor Turnage and his team for meeting with DCHA members and engaging in sessions that will hopefully offer real-world solutions. In particular, the department is committed in working with COMAGIN to reduce approvals for long-term acute care hospitals placements down to 24 hours. This includes a commitment to assist us with hard-to-place individuals who have been in our hospitals for sometimes years. In closing, there are lots of challenges facing healthcare facilities across the country and in the district, but we can say that the Department of Healthcare Finance is a true partner in finding solutions to support us. So thank you so much for listening. We are truly grateful, and I will accept any questions you may have.
Thank you. I don't see Blanche McLeod. So we'll go to Ms. Nelson.
Good morning, Ms. Henderson, Councilman Henderson, thank you. Good morning, Council Member Henderson and members of the Committee on Health. My name is Tina Nelson. I'm a managing attorney with Legal Counsel for the Elderly, and I manage our Economic and Healthcare Security Practice Group. Thank you for allowing me to testify today regarding the performance of healthcare finance. LCE provides free legal services and social work services to low-income residents of the district who are 60 years of age and older, and my practice represents seniors who receive home and community-based services under the ETP waiver program. In 2020, healthcare finance took measures to lessen the impact of the pandemic on beneficiaries receiving personal care aid services under the waiver program, and those measures continued in place through 2022. And we commend healthcare finance for halting actions that would have decreased or terminated PCA service hours during this global pandemic. But there continues to be some problems. Problems continue to exist with the Interi assessment tool used by Liberty in assessing the number of PCA hours that applicants and beneficiaries are awarded at their annual reassessments. The algorithm tool violates beneficiaries' rights under DC and federal law, as it gives no weight to a beneficiary's needs as to instrumental activities of daily living. And this has a particular devastating impact on seniors whose disabling conditions include cognitive diseases such as dementia and Alzheimer's. Home health agencies also continue to have inadequate staffing levels of home health aides available to provide care. Many of the clients we represent don't have informal family supports to cover the hours that home health agencies say they cannot staff, which puts their health in jeopardy. Some HHAs continue to refuse to allow beneficiaries to split their services among multiple agencies. And some HHAs are accepting new beneficiaries knowing they do not have the adequate staff to cover the hours. And this is very problematic. LCE supports an increase in the hourly rate for home health aides, and we believe this will attract more persons to the industry and help address the staffing shortage. We also suggest the healthcare finance mandate that HHAs provide overtime to aides who are willing to work extra hours, and to allow the use of travel nurses, and to relax the DC licensing requirements for aides who work in neighboring Maryland and Virginia. Ultimately, it is as healthcare finances responsibility to ensure that staffing levels are maintained at an adequate level to meet the needs of DC beneficiaries. Otherwise, there could be a potential OMSA violation if beneficiaries are forced to move to nursing homes because healthcare finances inability to provide services in the least restrictive environment. And we all know that there is a shortage of nursing home beds here in the District of Columbia. We urge healthcare finance to reconsider its position that prohibits spouses from serving as personal care aid services under the Services My Way program, because this will also help to address the shortfall of the pool of available aids. As the public health emergency is slated to end in a couple of months, we are concerned about an onslaught of clients who might overwhelm our offices for requests of representation, as well as OAH to conduct fair hearings. So we hope that healthcare finance will continue to work with us on resolving these cases without having them go through a hearing. We also have a few concerns with the DSNP program. We understand from our clients that they're not receiving the same level of care. They're being switched to different case managers without their knowledge. They haven't been informed who their case managers are, and the case managers are not responding to calls. And there are also issues with recertification. And we know that healthcare finance needs to address these issues because there seems to be a lack of cohesiveness and coordination among the various entities of DSNP. But we will continue to offer ourselves, working with healthcare finance and working as well with this committee to find solutions that will positively impact beneficiaries in the District of Columbia. And we continue to offer ourselves as a resource to everyone, including the other stakeholders, to ensure that seniors and other residents of the district who rely upon these Medicaid services continue to receive those services and are able to live independently in their communities. Thank you again for the opportunity to be able to address this committee, and I'm happy to answer any questions that the chairman may have.
Thank you so much. Mr. Miller?
Chair Henderson, good morning. Good to see you again. My name is Mark Miller. I'm the DC Long-Term Care Ombudsman with Legal Counsel for the Elderly, and it's my privilege this morning to speak to you on behalf of the nearly 9,000 district residents that are receiving long-term care services and supports through nursing homes, assisted living, and those that are in the community receiving services in their home under the EPD waiver. As you know, our mission is to help ensure the highest quality of care and quality of life for these individuals who are among our district's most vulnerable citizens. I wanted to mention that DC is one of only 13 ombudsman programs in the country that have authority to serve persons that are receiving services in the community, specifically EPD waiver clients. As you're aware, the EPD waiver program provides critical care and support to these older adults and persons with disabilities that allow them to continue living independently in their own homes. The 67 waiver complaints that we investigated last year in 2022 included provider response to complaints, quality of care concerns, and staffing related issues. In fact, approximately half of the complaints that we investigated on behalf of clients were staffing related. There are two items I want to bring to the committee's attention today. One is the increase in the personal needs allowance for nursing home residents and the continued lack of staffing for EPD waiver beneficiaries. First, the good news, the increase in personal needs allowance for persons in nursing homes. We've testified numerous times in the past years on behalf of Medicaid beneficiaries receiving nursing home care, calling for an increase in the personal needs allowance and also to include a cost of living adjustment in order for it to keep pace with rising costs. The P&A had not been increased in over 20 years. Residents came to us with their stories about the difficulties paying for basic services like cell phones, barber and beauty services, purchasing basic items such as clothing and personal hygiene items, or just simply to buy dinner out once in a while with only $70 a month. As we all know, recent inflationary pressure have added to the cost of these goods and services for everyone, but it is exceptionally regressive for those with little discretionary income. We are extremely pleased to report that as of February 1, the P&A has been increased to $100 a month with an annual COLA. I want to publicly thank Medicaid Director Melissa Bird and members of her team, including Catherine Rogers, Dee Coleman, and Caitlin Brandt for their efforts shepherding this process to fruition and This is going to have a very positive impact on the quality of life for many of these residents. Second, the lack of staffing to serve beneficiaries' assessed needs. As I mentioned, staffing is a frequent complaint that my office receives. Unfortunately, some home health agencies are accepting beneficiaries without the capacity to fully meet their assessed hours of care. A common gap in staffing coverage is evening and weekend hours. We have had several complaints on this issue, including a beneficiary who was assessed for 14 hours, but who has not received weekend coverage for months. It should be noted that the EPD waiver beneficiaries have a nursing home level of care and must receive these services to remain safely in their homes in the community. DHCF has provided guidance on how PCA services can be obtained using more than one agency to provide the services. However, the lack of sufficient staff is still a prevailing and consistent concern for us that we continue to hear. Home health agencies should not be allowed to accept new clients if they cannot adequately staff the clients that they are already serving. The Office of the DC Long-Term Care Ombudsman therefore recommends that home health agencies be required to publicly report data on the total number of EPD waiver clients they serve, the number of EPD waiver clients that they are unable to fully serve, and the number of hours they were unable to staff. This is information prospective consumers need to make the best choice for their situation. It adds transparency to the process and is very similar to what nursing homes are required to do to report staffing information to CMS. And with that, I just want to thank you for the opportunity again to testify, and I'm happy to answer any questions.
Thank you, Mr. Miller. I do have a couple of questions. I want to thank you all for your testimony today. I've recently met, I think, with almost not all of you, but many of you to hear in terms more in depth than what you can provide in your testimony. And I want to appreciate you all for taking that time. Mr. Miller, in that, I want to start with you. I'm sorry, hold on. Ashley, can you put me on a clock so I can keep my own? I recently met with a coalition of long-term care, and we talked about a whole range of issues. But one of the things we did discuss was the personal needs allowance. And frankly, I thought that it is astonishing that we only just got to $100 at the beginning of the month. What are you seeing in other states as it pertains to the PNA?
We're in front of it. We're in front of a lot of states.
We're doing better than many states?
We're doing better than most states. But again, it's relative, right? It's cost of living in certain areas. Certainly services, goods and services in the district are more than perhaps goods and services in mid-Kentucky, for instance. But even in New York, I'd spent time there, they're still at $50 and have been there for about 30 years. 15
or 50?
50.
Wow.
And so we're exceptionally pleased. We really appreciate all the work that the DHCF staff did to get us to this point. It took a number of years, and I realize there's a cost impact for Medicaid in doing this, but it was the right thing to do. And I think building in the COLA will mean we don't have to keep coming back every few years saying we need more.
Do you know what the percentage is for the COLA?
I do. Well, I guess it would be based on whatever the federal cost of living is. I mean, it'd be tied to the federal increase.
Okay. Ms. Nelson, and maybe you can jump in on this conversation just a little bit. And I think actually even Ms. Bowens, you talked about this. There's obviously been a lot of conversation around workforce. We can go from any part of the healthcare infrastructure ecosystem, but one in particular is around home health aides, especially as we have an increasing number of residents who are aging and they want to age in place. Department of Healthcare Finance has a planned wage increase for starting later this year and then for next year. Do you feel like what they have planned is enough to recruit more people to come into this field? Anyone can take it.
I am not aware of the plan that Healthcare Finance has in place to increase the wages to attract more people. I will just say that any increase in wages, I think, will be a help to the problem. Whenever you can go out and you can get a higher wage working as a barista at Starbucks, you're not going to be able to attract the pool of people, the numbers of people that are going to be required to provide these home health services. And as you note, council member, the numbers of individuals in the district who are aging is increasing. And as individuals increase, they actually need more services as opposed to less services. And so whatever Healthcare Finance can do to increase the minimum wage hour, I think will only have a positive impact.
Councilmember Henderson, Chairman Henderson, I guess I would certainly defer to the agencies with respect to what the appropriate costs would be relative to that. And so I think it certainly would be aligned with what the cost reports are for the home health agencies. Certainly in that regard, I'm sure that they would argue that that alignment is the most important thing. So from that respect, I can't speak to exactly what that plan is because that's kind of more in their lane. But certainly I would be looking to, if I were in that space, to ensure that that plan was aligned with the cost reports of those home health agencies. So that would be what I would be looking to.
I would just simply add, I mean, obviously workforce issue impacts the healthcare workforce across the spectrum. Any increase though, there has to be some accountability and transparency for that, as opposed to just simply throwing money at it. Because I've talked to a lot of aides and in different settings, and it's not simply the money; it's other things. It's
yes,
the career ladder, and I think we all
the
know
respect,
that.
all of those.
Exactly. So I think we need to keep that in mind and make sure that any additional money provided, and I'm not saying that these folks shouldn't make more, but we should make sure that it actually flows through to them, and so that there's accountability on the part of, for instance, home health agencies.
Right. Well, thank you all so much for your testimony, and I look forward to continuing to work with you on some of these issues. I think that the more we sort of talk about these pieces, it's all interconnected. And I actually think that it's really great that all of you happen to have been on the panel at the same time, because some people don't realize, like, there might be somebody who's at a hospital who they don't need the level of hospital care, but there's no place for them to discharge to because there's a staffing shortage, and all of these pieces sort of go together. Ms. Nelson, I'll follow up with the Office of Administrative Hearings. We've heard in another hearing in terms of their backlog situation, but
Yes.
I think the alarm you're raising now in terms of what happens at the end of the public health emergency, not just for this, but for Medicaid, but all of these other things where folks are going to be looking to perhaps appeal decisions, we should probably take care of. So thank you all so much. So you'll be put back as a attendee, and then we'll call up the next panel, but thank you again.
Thank you.
Thank you, ma'am. Thank you.
Thank you.
Okay, we're going to call up the next panel. Amber Reiki from the Children's Law Center, Leah Castells from the Children's Law Center, Mark Lavoda from the DC Behavioral Health Association, Rachel Metz, public witness, and Kristen Skeels from DC Greens. I see Blanche Lincoln has arrived. I'm going to let her speak on this panel. Ms. McLeod, you have 3 minutes if you want to come off mute and present your testimony.
Okay, I am so frustrated with the entire Department of Healthcare Finance. I've been fighting battles, and not just me. We as seniors have been dismissed and treated as if we don't have any sense at all. Okay, when it comes down to medical supplies, I want to know why the vendors in DC, businesses in DC, could not supply. My supplies, when I needed pain management, and one, I went to Maryland and they wouldn't give me my skin protector because I didn't have an ostomy, which is not an option because I'm allergic. But when I did finally get them and break down, I had to get into an argument with United Healthcare about medical supplies and was told that they did not have to do business in DC. And I told them, oh, yes, you do. So I broke down and I got my pain skin prep, but it came from Somerset, New Jersey. Most of our supplies are coming from out of state. And from my understanding, because I have called SHIP and everybody else, that's how the contract was. And my pharmacy that I use is 1.4 miles away with everything on the shelf. Same thing that I got from Somerset, New Jersey. Businesses have gone out of business in DC because they're not part of United. Now I fought for 10 months. And so finally I'm getting my supplies, but others are not. I can't go to my dentist because November 21 was when I first sent and called messages to the former chairperson's office as to why was my dentist, who refused to give healthcare finance and social security number, excluded from Medicaid. And she's been a dentist in DC for over 30 years. And she couldn't do Medicaid. Now, the other part that I have is the lack of communication that they have with us, with our health insurance, with all the changes. I started in October when I got the book. Everybody that I called treated me as if I couldn't read. I had no reading comprehension at all, but I can read very well. And I know what the book said, what United was not going to cover. And from United Healthcare to staff at Healthcare Finance, it was the same thing. You have it, you have it. That's not what I said, that it was under Medicaid. They're always ambiguous. They don't send out information. And I even had a face-to-face with a representative from Healthcare Finance when the mayor had her senior celebration for Christmas. And I asked him, why were we not notified of the changes properly? Why was there so much ambiguity? He told me that flyer that United Healthcare sent about the changes from 2022 to 2023 was not meant for DC. Since they are nationwide, it was meant for another part of the country. I looked at him and asked him, what kind of fool did I look like? And then when you call, some of the people there are totally untrained. When I asked a question with like why they changed to transportation and said that we were sent notification, we were not. And I said, when I told her, no, we weren't, she said I was being hostile and transferred me to United. When I called to find out why whoever the contractor was deemed it necessary that all we needed for the disposable nebulizer kit was one mask and one nebulizer kit. And you use one 10 times, which is disposable. I use mine 3 times a day. So whoever you are contracting, these people are totally asinine and they have no interest for the seniors or the disabled in DC. And I've been treated with nothing but disrespect because what I did, I came down there on my walker, my leg immobilizers, and I went to the city administrator's office, the chairman's office, and I had sent an email on November the 4th to the chairman, to the chief of constituent services in Phil Mendelson's office. I have never gotten a response.
Well, Ms. McLeod,
my emails. Okay. I'll finish. But I'm just saying that number one, I have sent emails to every single thing. I have sent email after email after email.
Well, Ms. McLeod,
Sure.
You're over your time, but how about this? Because I have to go on to the other witnesses on this panel. If you could provide, I think we have your contact information from you signing up. So someone from my office will follow up with you to talk more specifically about the issues that you raised. Is that okay? That'll
be just fine. Thank you.
Okay, great. All right, thank you. All right, Amber?
Good morning, Chairperson Henderson. My name is Amber Reiki. I am the lead project lead for A Path Forward at Children's Law Center. Our more than 100 staff work with DC children and families, community partners, and pro bono attorneys toward a future where every child can grow up with a strong foundation of family, health, and education, and live in a world free from poverty, trauma, racism, and other forms of oppression. Thank you for the opportunity to testify today about important issues under the purview of DHCF. At Children's Law Center, nearly all of our clients are Medicaid beneficiaries. The major changes underway in DC's Medicaid structures could potentially improve access to behavioral health services. However, DHCF will need to be especially attentive to various aspects of the transition to managed care organizations to improve rather than worsen access gaps. The recommendations in my testimony draw from last A Path Forward, Transforming the Public Behavioral Health System for Children, Youth, and Their Families in the District of Columbia, which Children's Law Center co-authored with partners, some of whom are here today. This project envisions a working system in the truest sense of the word that not only meets the service demand, but embodies the values of family-centered care, cultural humility, racial equity, and trauma-informed care. My written testimony includes much more detail. First, DHCF must guarantee an adequate network of child-serving behavioral health providers in MCOs. As DHCF integrates behavioral health this year, one fundamental job is ensuring there are enough providers and networks to meet the broad and diverse needs of beneficiaries. Far and away, the biggest obstacle is the shortage of behavioral healthcare professionals in the district participating in public insurance. Federal regulations require that states maintain an adequate network of providers in Medicaid to achieve consumer access to care. Under DC's MCO contracts, the Behavioral Health Services Network must include certain types of providers, and there are some other measures. But we know networks are still functionally inadequate because services remain severely inaccessible. Patients can't find timely appointments, provider waitlists are so long that they close them, and people go without basic care like initial intake appointments, individual and family therapy, autism evaluations, and medication management appointments, especially in certain specializations like psychiatry and grief counseling, or therapists that can communicate in languages other than English. We argue that DHCF could do more in their contracts and oversight. For example, the only place in the MCO contract with timeliness requirements for behavioral health is for the assessment and stabilization of psychiatric crises. The contracts do not dictate the time to less acute behavioral health services, though they do set limits for waits for things like primary care appointments for adults and appointments for diagnosis of non-urgent health conditions, which is 30 days. Network adequacy standards should be tied to accountability mechanisms that are regularly and transparently enforced. We are not aware of any penalties being levied to date, despite recent external reviews documenting inadequacies. And to entice providers to participate in Medicaid at all, DHCF should ensure that credentialing requirements are not too slow, burdensome, or exclusive, and that pay rates are high enough and adjusted for inflation. Our second recommendation today is that DHCF should prioritize collection and sharing of data that improves quality and performance while minimizing the administrative burden on providers. The government should require and enforce MCO reporting on standard quality of care measures. We further recommend the development of a behavioral health surveillance system with DBH that routinely captures data on prevalence, incidence, severity, risk factors, social determinants, functional outcomes, and access to care for behavioral health, ideally with data disaggregated by race, ethnicity, age, and geographic location. A few other issues we include in our written testimony, I'll just mention briefly. We need to address current gaps for DC youth and foster care related to Medicaid enrollment and continuity of care, while also preparing for successfully transitioning this population to MCOs. We should also maintain investment in the Healthy Steps program to support growing families by providing pathways to long-term sustainable funding. And this begins with including Healthy Steps in the ongoing rate study. And finally, we want to see a remedy to recent changes in the respite benefit some of our clients in the HSCSN network are encountering that make that benefit almost impossible to use. In conclusion, access to behavioral health services is essential to our children's well-being and future success. The district is on the path of systemic transformation, which prevents many opportunities to build a stronger network of timely, accessible, and high-quality services. The need is urgent and the moment is right. Thank you for the opportunity to testify today. I welcome any questions you may have.
Thank you. Leah?
Good morning, Chairperson Henderson. My name is Leah Castelas. I'm a policy attorney at the Children's Law Center and a resident of the district. I'm testifying today on behalf of the Children's Law Center. My testimony will focus on DHCF's investments in maternal health. First and foremost, though, I'd like to commend you, Chairperson Henderson. You've been a true champion of this work, and we look forward to your continued attention and advocacy as the chair of the Committee on Health. Additionally, we applaud DHCF for its continued investment in advancing positive outcomes for maternal health in the district. In FY 2022, the district submitted and was approved for 2 state plan amendments targeting maternal health. Additionally, DHCF has stood up a perinatal mental health task force that will provide comprehensive recommendations for improving perinatal mental health in the district. We are excited for and appreciate these advancements. However, we believe continued attention is needed with regard to the implementation of these investments. We are at a critical junction and we cannot afford to slow down. Although still in its infancy, the doula program is struggling to enroll doulas. This could be for a variety of reasons, and we urge this committee to work with DHCF to understand what supports are needed to grow the doula program. We do encourage this committee in partnership with DHCF to explore the reimbursement rates. When the reimbursement rates were released and discussed in the Maternal Health Advisory Group, many providers and doulas shared concerns that current reimbursement rates would not incentivize doulas to enroll in Medicaid. Additionally, DHCF has ended its work with the Maternal Health Advisory Group. We are concerned that during a critical point of time, implementation of the doula benefit, DHCF is no longer receiving input from those executing and utilizing the new services in a structured, consistent way. There is no longer a centralized touch point for this ongoing expansion work. We are grateful for the investment in the Perinatal Mental Health Task Force and for you for helping stand that up. The task force is vital to ensure pregnant and postpartum people and their families have affirming and sustainable support for their behavioral health during the perinatal period and beyond. However, the task force has a very specific directive that does not encompass the implementation of the doula benefit or maternal health more broadly. Overall, we are concerned that after the task force dissolves in October, and if the Maternal Health Advisory Group is not reestablished, there will be no convening of stakeholders regularly with government officials to move forward solutions for maternal health in the district. We hope in partnership, we can find a solution that will continue to engage perinatal health professionals, health service organizations, affected community members, and the government, and allow for collaboration to resolve inequities in maternal health in the district. Thank you for the opportunity to testify. I welcome any questions.
Thank you. Mark Lavota.
Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Lavota. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association advances high-quality whole person care for district residents with mental illness or substance use disorders. Our 31 member organizations annually provide care to over 30,000 district residents, almost all who are Medicaid beneficiaries. With a scheduled transition of community behavioral health services into managed care on October 1st, 2023, the Department of Healthcare Finance has significant work to complete in the next few months. The transition of community behavioral health services into managed care occurs at a precipitous time for the district's healthcare system. Provider organizations, along with the district government's healthcare agencies and managed care organizations, face severe workforce shortages, and managed care contract changes create their own disruptions. The district is making these significant changes, even while it is also subject to changes at the federal level, including restart of Medicaid eligibility determinations and other procedures to unwind the federal COVID public health emergency. Provider organizations and MCOs still lack critical information about the specific conditions under which behavioral health services will be expected to operate beginning October 1st. Official decisions still are not published about enrollment in behavioral health services delivered by DBH certified providers, updates to payment rates and service design, or selection of level of care tools. Even if remaining decisions effective October 1st or earlier are published swiftly, the underlying challenges for provider organizations to succeed in managed care will remain. While DBH and DHCF have announced that there will be bridge policies to support continuity and determine care authorizations, other recent managed care transitions in the district with similar continuing authorization policies have required provider organizations to transmit duplicative authorization documentation for each beneficiary eligible for continuing authorization. And after the bridge period, each of the MCOs will have latitude to reach different care determinations, even under requirements to use the same tools. DBH government witnesses last week testified that provider organizations should expect a change in cash flow from weekly payments by DHCF to monthly payments by MCOs. But those are not the terms of MCO contracts with DHCF. DHCF requires MCOs to pay 90% of so-called clean claims within 30 days and 99% within 90 days. Organizations already operating in managed care, both in district and nationwide, have experienced MCOs meeting the terms of these requirements, not only by timely payment of some claims, but also by alleging that large numbers of claims submitted do not meet the documentation standards to be considered clean claims. The analogy is not learning to budget for a monthly paycheck instead of a weekly paycheck, but instead learning to budget for a monthly paycheck that only pays for 3 or 4 weeks worked, with an additional 10% withheld for up to 2 months, and a requirement to spend time outside previous customary work hours to resubmit proof that all 4 weeks of the month were qualifying work. Even if all claims are eventually paid, the additional cost to fulfill the increased documentation burden, along with the interest costs of seeking extended credit against receivables, will leave cash positions extremely precarious for organizations that are already undercapitalized and operating with extremely slim, and for some services, negative margins. Similar challenges exist with DHCF requirements that MCOs complete provider credentialing within 120 days, which can exacerbate hiring challenges, with staff either unable to onboard or being paid without being eligible to submit bills for qualifying services. DHCF also needs to begin its preparations now for the policies it wants to have in place when the bridge period is complete. DBH and DHCF should agree and publish post-bridge period decisions by September 30th, 2024. One critical outcome of that planning must be establishment of an alternative payment methodology for DBH certified providers, offering a level footing in payment rate setting equivalent with hospitals, skilled nursing facilities, federally qualified health centers, intellectual and developmental disability service providers, and home health agencies, among others. Setting updated Medicaid rates for DBH certified providers is already long overdue, and it would be unacceptable to set updated rates in the next several months only to leave individual behavioral health provider organizations to negotiate directly with MCOs at the end of the bridge period, unlike all of the provider types just mentioned that have APMs in place. APM development must be added to renewal of the 1115 behavioral health transformation waiver, further adjustments to the behavioral health service mix and the Medicaid state plan, accountability modifications for behavioral health outcomes in the managed care quality strategy, and hopefully planning for a Medicaid demonstration of the certified community behavioral health clinic model. Combined with these steps, the transition to managed care could put the district well on its way to overcoming existing inadequacies of the public behavioral health system. Thank you again for the opportunity to testify today. I welcome the opportunity to answer any questions.
Thank you. Rachel?
Good morning, Chair Henderson and members of the Committee on Health. Thank you for the opportunity to address you today. I'm Rachel Metz. I'm the Data and Research Manager at DC Action. First, I want to echo the thanks from earlier for your championship in passing and funding expanded Medicaid coverage for postpartum parents for the first full year after the birth of a child. Knowing that they're guaranteed health insurance gives parents one less thing to worry about as they embark on that critical first year. As you know, that was one of the several changes to Medicaid during the pandemic. And with Congress having now passed the Consolidated Appropriations Act, the landscape is shifting again. So our testimony today focused on 3 of those changes that are coming down the pike that particularly impact children and families. Unwinding the Medicaid continuous coverage requirement, the option to make the expansion of postpartum coverage permanent, and requiring a 12-month continuous coverage for children regardless of income shifts starting next year. On that first one, others have already talked about what a major undertaking it is to unwind the continuous coverage requirement. And ensuring that that goes smoothly is a children's issue. The DC Medicaid enrollment grew by nearly 10,000 children between February 2020 and August 2022, and 3/4 of district children are enrolled in either Medicaid or Healthy Families. So first, we want to thank DHCF for some of the steps that they've taken. They pushed back the timeline, so June 1st is the earliest that anyone could be dropped for Medicaid for recertification issues. They did a lot of work, as well as people in other agencies to implement the district direct system, which means that many Medicaid enrollees will be able to be automatically recertified. And they're working on a communications toolkit that we're looking forward to sharing as soon as it's available. That being said, there are some other questions that we have about what DHCF is doing to make sure that the process goes as smoothly as possible for as many people as possible. The first is what the process will look like for foster care, people who qualify for Medicaid through foster care or adoption assistance, or as former foster care children, rather than based on income. We have a similar question about children with long-term disabilities or complex medical needs. And last but certainly not least, District Direct is an amazing step, and we're wondering what other data sharing agreements are possibilities so that people who are enrolled in other public benefits programs, such as WIC or the Child Care Subsidy Program, can also recertify more smoothly. If that's something that doesn't exist, what steps is DHCF taking to increase the data linkages with other agencies, whether that's part of an early childhood integrated data system or its own thing? Switching to postpartum coverage expansion, as you know, that shift was done based on a temporary federal flexibility, and now it can be permanent. So we would love for that to be permanent. And last but certainly not least, as part of the new federal legislation, starting in 2024, states are required to provide 12 months of continuous Medicaid coverage to children who qualify for Medicaid, even if family income fluctuates. That's really important so that children aren't churning on and off of the program and losing access to care. And we would love to see that implemented as soon as is feasible, because the calendar and the fiscal years don't align. We would love to have that start in fiscal year 2024 if it's something that you need to budget for, and if it's something that doesn't need to be budgeted for, the sooner the better. So that covered a lot very quickly. Thank you for the opportunity and have a great day.
Thank you, Rachel. Kristen?
Hi, good morning, Councilmember Henderson, members of the Committee on Health, and Council staff. My name is Kristen Sukis, and I'm the Health Policy Specialist at DC Greens, a nonprofit that advances health equity by building a just and resilient food system in the district. Our organization administers a produce prescription program that provides qualifying adults and children who are Medicaid recipients with $80 a month to purchase fresh and frozen fruits and vegetables. Produce prescriptions benefit patients by helping to prevent diet-related illnesses and reducing healthcare costs. They also benefit DC's economy by reinvesting produce prescription funds into the local economy. Currently, our program serves over 1,300 adults and 900 children throughout the district. Access to vital food as medicine programming like produce prescriptions through Medicaid has grown substantially over the past 2 years, thanks to the support and investment from DC Healthcare Finance and their produce prescription grant programs. In 2022, with financial support from DHCF, DC Greens was able to expand our program to 3 additional clinics, allowing patients to access produce prescriptions at a total of 17 clinics across all 3 managed care organizations in DC. We were also able to increase the number of Giant locations, our current redemption site, to 5 locations throughout the city. Later this year, we will be expanding the program further to include other major grocers like Safeway and Walmart as we switch to a more scalable program model. Patients love produce prescriptions, healthcare providers love produce prescriptions, and healthcare payers love produce prescriptions for the cost savings and positive health outcomes it generates. Recent research shows that produce prescriptions participation in these programs has led to improved HbA1c levels in individuals with diabetes, improved BMI scores, and lower blood pressure, increased fruit and vegetable consumption, lower depression scores, and decreased hospitalization and emergency room utilization. Preliminary data we have gathered on DC's produce prescription program has shown similar results. 39% of study participants experienced a reduction in their A1C levels, 35% saw a reduction in BMI, 34% of participants saw a reduction in blood pressure, and 75% of patients reported an increase in their fruit and vegetable consumption. In addition to these encouraging health outcomes, the program fed nearly $250 million back into the local economy through the fruit and vegetable purchases. Despite encouraging indicators like these and the growing interest and support for food as medicine initiatives nationwide, current access to produce prescriptions remain quite small relative to the need in our city. A survey by the Capillary Food Bank found that 36% of district residents experienced some level of food insecurity in 2021, but that food insecurity wasn't evenly distributed across the city. Food insecurity rates for those who identified as Hispanic was 55% and 50% among those who identified as Black. By contrast, the prevalence of food insecurity was only 13% among residents who identified as white. We see this disparity even more sharply in health outcomes. There's currently a 17-year difference in life expectancy between residents of Ward 8 and residents of Ward 3. This is due almost entirely to diet-related chronic illnesses such as diabetes and hypertension, 2 of the 10 leading causes of death in our city. To truly increase access to meet the need, DHCF must move beyond grant-based supports and work towards integrating produce prescription programs deeper into Medicaid. Specifically, we recommend that DHCF pursue an 1115 demonstration renewal waiver. The district's behavioral health 1115 waiver expires January 2025, and pursuing a renewal waiver is the best opportunity the district has to redesign our Medicaid managed care system and test innovative strategies for addressing health-related social needs like food insecurity. In addition to pursuing an 1115 renewal waiver, there are a few other policy levers the department could seize to create a Medicaid system that recognizes and responds to the health impacts of food insecurity. DHCF can publish guidance for MCOs to encourage their use of in lieu of services and value-added services flexibilities to increase access to critical nutrition interventions like produce prescriptions. DHCF can also implement value-based purchasing guidance, which they're currently drafting, that encourages MCOs to address health-related social needs in partnership with community-based organizations. Lastly, DHCF should work to enhance food insecurity-related goals and metrics within DC's Medicaid managed care quality strategy, which should also be redrafted soon. At DC Greens, we envision a day where access to nutritious food is part of the overall healthcare system in our city, and we know that DHCF shares that dream. We're excited to work in partnership with the department over the coming years to seize the policy pathways that will help us actualize this goal. Thank you for your time and consideration of this testimony, and I'm open for any questions.
Thank you, Kristen, and thank you to all of the witnesses who testified and who've been consistent voices on behalf of DC residents, whether it be children, whether it be individuals who are in need of the provider care from the Behavioral Health Association, or residents who are facing food deserts and food insecurity. I don't have any specific questions for this panel, but I want to thank you all for your testimony, and we'll be raising some questions to healthcare finance about some of the very issues that you all raised in your testimony. Thank you. Okay, we're going to go on to the next panel of witnesses. Claudia Schlossberg, Ann Parallel, Danetta Clark, Lindsay Niles, and Natasha Corley. As a reminder, you have to affirmatively accept our invitation to be promoted as a panelist. There we go. I see Claudia, so why don't you go ahead and get started?
Sure, thank you. Chairman Henderson, members of the Committee on Health, thank you for the opportunity to testify this morning. I'm Claudia Schlossberg, the interim convener of the DC Coalition on Long-Term Care and chair of the Coalition's Workforce Development Subcommittee. First, as I begin my testimony, I'd like to commend the Department of Healthcare Finance, and particularly the Long-Term Care Administration team headed by Catherine Rogers, and the finance team headed by Angelique Martin for efforts to expand services for those who need long-term services and supports. In the past 2 years alone, we've seen tremendous growth in the availability of Medicaid-funded assisted living residences, new adult day health services, and the district's first program of all-inclusive care for the elderly, which will soon be serving residents in Wards 7 and 8. Notwithstanding these accomplishments, district residents, their families, and providers who serve them still face significant challenges, particularly with respect to accessing care. Today, I will address three. First, the workforce issue. Yesterday, the DC Coalition on Long-Term Care released our 7th survey in 4 years, focusing on direct care workforce issues. We have over 4 years documented, including as late as last month, that home health aides and certified nursing assistants are leaving the workforce in record numbers, and providers are facing unprecedented staffing shortages. These are driving up costs, particularly for overtime, and significantly reducing access to care. As you have heard from witnesses, the workforce shortage is also already affecting the ability of hospitals to safely discharge patients to aftercare. This also drives up costs. The crisis is fueled by the lack of qualified candidates interested in taking or staying in these jobs. And that lack of candidates and the inability to retain staff is directly tied to the low pay of these workers. Entry-level wages for these workers, most of whom work for agencies that depend on Medicaid reimbursement for the majority of their revenue stream, remain at or just above the district's minimum wage of $16.50 an hour. Providers are facing fierce competition from other job sectors that offer much higher pay for less stressful, less demanding jobs with similar or lower entry-level requirements. Recently, PHI International, a well-respected research institute that focuses on the direct care workforce, confirmed that DC is underpaying its direct care workforce. And when compared to other jurisdictions across the country, we ranked dead last on the key measure of wage competitiveness. While DHCF is using some ARPA funds to provide supplemental payments to providers, and this is a very important step, to increase the wage of workers, they are only using funds to increase the average wage of workers to 110% of the minimum wage, which would bring that average wage, not the minimum wage, but the average wage to $18.15 an hour. This is not adequate to attract the thousands of workers that the WIC has documented that we need to meet the current demand, let alone the future needs of a growing aging population. This is why, while we have proposed many strategies to address workforce and improve the quality of these jobs, including lowering the age requirement from 18 to 16 and supporting career ladders, none of these strategies will have any impact unless and until we recognize the value and importance of the workers who are providing the direct care to our most vulnerable residents. This is why we're asking the council to raise the wage rate to $24 an hour, the minimum wage to $24 an hour, an amount that would provide a real living wage to these workers. And we are joined in this request by the Fair Budget Coalition as a matter of economic justice for these workers. Let me quickly turn to two other issues. First, you've already heard this around the assessment process. In order to access long-term care services and supports, somebody applying for Medicaid services must obtain an assessment from Liberty Health. That assessment is supposed to be completed within 5 days. As of last week, Liberty is scheduling assessment requests within the first 2 weeks of April, so 8 weeks out. This is creating significant delays in connecting residents to needed care. We need DHCF to address this issue immediately. I know it's a tough one, but this is truly becoming a barrier and is a barrier to accessing care. The last is the P&A issue, and you heard Mark Miller testify that DHCF recently increased the P&A for nursing home residents from $70 to $100. Yesterday, when we spoke, we talked about the P&A for residents who live in community-based settings, such as adult foster homes and assisted living. That P&A has been $100 since the early 80s. And so we've asked DHCF, and we believe it is important to increase that P&A as well. That is not adequate to meet the needs of someone who's living in the community. And what we've also found that it's also become an impediment to housing people in assisted living who could benefit from assisted living, particularly those coming out of the homeless services housing network. Both the Department of Human Services and the permanent supported housing providers had hoped that assisted living would become a very attractive option for people aging out. I'm sorry, am I out of time?
Yes, ma'am. You're over your time.
I'd say that unfortunately, when people find out that they can only maintain $100 of their own income, they basically stay in shelters or stay unhoused. Thank you very much for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Ian?
Hey there. Good morning, Chairman Henderson. My name is Ian Paragal, and I serve as the Executive Director of the DC Coalition of Disability Service Providers. The DC Coalition currently represents over 50 provider agencies supporting over 2,300 persons with intellectual and developmental disabilities, employing over 4,700 staff. Member organizations provide home and community-based waiver services, as well as intermediate care facility or ICF supports for persons with IDD. On behalf of the provider agencies and those whom they support, we want to recognize the leadership of Medicaid Director Melissa Bird. And in particular, we want to highlight the transparency, engagement, accountability demonstrated by Deputy Director of Finance, Angelique Martin. Ms. Martin and I have had frequent communications throughout this health crisis, probably more frequently than she would like. And she has proven herself to be a candid and concerned leader within DHCF. We have expressed our respective differences regarding the best use of DC's ARPA funds, the funding structures and assumptions utilized by DHCF in developing rates and reimbursements, and the manner and timing of distributions with respect to provider sustainability. But the coalition is deeply appreciative of the efforts made by DHCF to account for the many costs of COVID-19. Let me give you a little history. In 2019, we saw legislatively endorsed increases for direct support professionals. Vacancy rates at that time were about 12% on average. Unfortunately, the 2019 Rate Act remained largely unfunded by the mayor, and turnover and vacancy rates continued to swell, and then COVID struck. During 2020 and 21, vacancy rates exceeded 18%, and now they're at 23%, with some providers reporting vacancies as high as 40%. We would submit that in spite of DHCF's recent efforts, and you asked this question of an initial witness panel, the 117.6% increase, which won't be funded fully until 2014, will not be enough to attract, recruit staff in these demanding jobs and will not have an impact on staff vacancy rates. This is why we're joining the others in supporting a 24 and 24 initiative, $24 an hour in 2024. The current DHCF reimbursement rate, which equals or approximates the living wage, leaves no room for wage growth, none for retention, performance recognition, or overtime expenses. The largest single component of the cost of services allocated to funding are DSP wages and benefits, and the wage factor that they use is the $16.50 per hour. So the anticipated rate, as Claudia indicated, of $18.15 on average remains very close to the minimum wage. In fact, that's a mere $66 in gross weekly upside on average versus a straight minimum wage paycheck. At the end of the day, there's really no economic reason for a job seeker to choose to become a DSP. And without suitable workforce, the district continues to not only eschew the needs of vulnerable population, but it also fails to address the socioeconomic equity arguments surrounding this workforce that others have raised. Complicating this discussion is the fact that staff vacancy rates are at an all-time high. As you've heard from most of the others who's testified today, there is an inadequate number of frontline staff persons. However, unlike other industries, direct support services must be provided. Those supports must be covered by already exhausted staff persons working at an overtime rate. DHCF funding includes no adjustment for any overtime in its funding formula, so those overtime hours are unfunded. Providers need some accommodation or additional funding to account for the overtime generated from these staff vacancy rates, which now result in even higher operational expenses. This is the exact scenario that we testified back in 2018 and why we needed to address wages 5 years ago so we wouldn't find ourselves in this situation now. So our recommendations: first, the DC Coalition has requested the district to consider reallocation of the remaining ARPA resources and that those undeveloped funds be braided into a more meaningful wage factor in order to increase wages, not only for direct support workers, but also for nurses, which remain in short supply in the DD provider world. Second, we encourage DHCF to convene a meeting which describes the planned use of the remaining ARPA funds and address comments from the community on possible reallocations. And thirdly, we recommend that any continuing wage enhancements for frontline staff include allocations for expected continued overtime costs resulting from the vacancy and turnover rates within the industry. On behalf of the DC Coalition of Disability Service Providers, I thank you for the opportunity to provide this testimony, and I welcome any questions.
Thank you. Donetta Clark. Ms. Clark, you are on mute.
Thank you so much. Thank you, Honorable Christina Anderson, and council members on health for this opportunity. It is greatly appreciated, and all of those who have testified before me. I am here to testify on behalf of the family members. I am the Family Council President at the Stoddard Baptist Global Care Washington Center of Aging Services at 2601 18th Street in Washington, D.C. Northeast. This testimony is based upon personal rights violations in accordance with the District of Columbia municipal regulations, federal nursing home reform modernization, and including the nursing home facilities' own rules and regulations. We are also concerned that these residents have been promised and committed with a very quality kind of life here at the nursing home. However, for over 8 years, I have a lengthy summary here, but I'm trying to highlight these important points. Our family members, residents have experienced and complained about these violations with grievances that were reported in writing according to the protocols. These reports in writing have not been addressed in a satisfactory way, if at all. Mostly they have been ignored. The most important thing about this reporting that concerns us is that the surveyor's binder there at this facility has shown no updated filings of grievances or complaints since July 2020. Our family council researched the binder, and these were in 3 binders, no updates. As a result of this, we want to do a disclaimer here before I go any further. We realize there are many hard workers there who are earnest, who have compassionately worked to make sure there's quality care and services for our residents as promised and as is legally their right. We also understand that these workers are complaining about some of the same things. They're frustrated and have left, and some are threatening to leave. So we are concerned that this family council, as we represent today, we are concerned that we are not having the barrier that we've been confronted with there with the administrator, where our complaints and concerns are not heard and are addressed. That creates the following concerns that not only are causing the families to have poor care, but are leading to sometimes fatalities. Our grievances and complaints, as said, are not often acknowledged, and when they are, there are no reflections of corrections or improvements that are long lasting. We have problems with communications there that have been, again, for a long time unaddressed. Complaints about our family members being spoken to in profanity, family members and residents being ignored when they are addressing the staff. A big concern is that of the predominant non-English speaking population who serve there on staff. This is a problem because it is not clearly, it is not our advantage in communicating. It's a gap, it's a barrier, and this sometimes can produce problems in issuing care and services for medicines, and has been a problem. As a result of that, we find that residents' orders, residents' requests are oftentimes neglected, left miscommunicated, or improperly documented. In the absence of the compassionate care being communicated, there are many residents and family members who are experiencing mental, emotional, and physical distress. We're addressing also physician, contractor, and nursing care. There are documentations and observations. A physician having said to patients, residents, when they've complained, oh, nothing's wrong with you. On an occasion, when this was heard, family member addressed the physician. He challenged the family member, blew her off, and hung up the phone. This physician still practices there, and these complaints are ongoing. We also have complaints of a physician having continued, I'm reading over things, I'm sorry, I'm trying to cover everything. We have complaints about extended periods where residents lie in their body waste or are not positioned and repositioned that result in flesh wounds. We are also seeing increased arthritis and suffering from this. There are also instances where the residents are treated, giving care in the solarium dining room where they eat, where there's administering a finger sticking related to diabetes while the resident is eating without sanitizing it. On another occasion, it's been observed where podiatry care was administered over a chair in this same location, the solarium where people eat, with a chair, a bag under the leg, the residue popping in the atmosphere. This was challenged also by a family member and a resident refusing to allow this podiatrist to take care of her, asked this podiatrist to be removed. However, these behaviors continue to be in practice. There is unsanitized material or a lack of enough material. And further, there's the issue of medications being given to patients and left there. An instance was found, happened where medicines were found on 3 occasions. On one day, 3 cups were found, taken to a charge nurse. This was not documented as an incident. Medicines also, residents also complained that medicines
Ms.
are
Clark?
being paid. Yes.
I'm sorry, I let you go over, but you're over your time by almost a minute and 30 seconds. Yep,
I'm so sorry. I missed a lot in this testimony, but I know that you have this written document. We're hoping that in your discovery and investigation of this, that you will help us to find resolution for these residents where there's consistency and compliance to the regulations. Thank you so much for hearing our testimony today.
Thank you. Thank you. Lindsay Niles. Okay, not here. Natasha Corley. Also not here. All right. Well, thank you so much to the public witnesses for your testimony. And thank you to Ian and Claudia. As you mentioned in your comments, we did have a lengthy conversation earlier this week about some of the issues that you raised in your testimony today. Ms. Schlossberg, I just want to clarify. So I think you heard earlier, Mark Miller, who's the long-term care ombudsman, he talked about that the P&A had been increased from 70 to 100, but that is for a different set of individuals than you were talking about, correct?
That's correct. The P&A for nursing home residents was $70, and for those who live in community-based, what are called adult foster homes, which includes assisted living, it was $100. Those $70, $100 amounts have been the level that was established back in the 1980s, I believe, and have never been increased. So this initial $30 increase for nursing home residents is the first time that the P&A has been increased in many, many years. The home and community-based P&A, which is the amount that a resident can keep of their own income when they live in the community, has never been increased. And it is an impediment in terms of getting people housed.
Okay. And just another sort of clarifying point, you and Ian also spoke about home health aides and the need to raise the wages, and in particular around healthcare finances plan to do so. But I think it's important to note that they are only raising the average. They are not raising the minimum. Is that accurate?
Correct.
That's correct.
Okay, I think that's an important distinction, right? Because you could raise the average all day long, but someone who is making the minimum is still going to could be well below that, given the number of individuals who are in the field. So we'll be asking some questions about that as well. Ms. Clark, thank you so much for your testimony. We will review your longer written testimony of all the issues that you raised there. And I'm sure there will be some crossover in some of the things that we raised, but we're going to go on to the next panel. So
Councilmember,
oh, yes.
If I can give you some clarity on that issue on the average piece for a second.
Sure.
Sure. So I think the idea is to be able to create some internal tiers and leave some flexibility for the providers. I just wanted to make sure that there's an understanding that that's why they're using an averaged rate. So we can kind of create these internal tiers to be able to move up to in that field.
Got it. All right.
Okay.
Thank you so much.
Sure.
All right. We'll call the next panel. William Long, Claudia Balog from United Healthcare Workers East, Janet Phoenix, Patricia Quinn, and Ebony Silver. As just a reminder, you have to affirmatively accept the invitation to be elevated. Okay. All right. So William Long is not here, but Claudia, we do see you. So why don't you go ahead and start your testimony?
Thank you, Chairperson Henderson. Thank you for this opportunity to testify. So my name is Claudia Balag. I'm the Assistant Director of Research for 1199 SEIU, representing 400,000 workers up and down the East Coast, with thousands of healthcare workers in hospitals, clinics, and skilled nursing facilities in the District of Columbia. I'm here today testifying on behalf of the district's healthcare workers who are struggling to survive on poverty wages. The shortage of home health aides and CNAs in the district is not new. These jobs have always been characterized by high turnover. The pandemic just exacerbated the problem. So PHI has delved into workforce data, and the projections for the District of Columbia are startling. Between 2020 and 2030, we're going to need over 3,000 new home health aides to enter this field and hundreds of additional CNAs. But when you take into account the normal rates of worker turnover, there's going to be something like 23,000 job openings for CNAs and home health aides during this decade. Our members include CNAs at skilled nursing facilities who often moonlight as home health aides to make ends meet because the wages are too low. We also want to recognize the efforts made by healthcare finance to use ARPA funding to address home health aide wage rates. But again, that progress to an $18.15 average wage for those workers is inadequate. And here's why. So according to a 2019 report of the National Low Income Housing Coalition, the district had the fourth highest housing wage in the country. And this workforce crisis is an equity crisis. I'm going to say it again. More than 87% of direct service workers in the region are people of color. Black or African American women constitute most workers across these care settings, and many in this workforce are immigrants. When you look at direct service workers in the district, nearly 1 in 5 live in poverty, and 63% rely on public assistance. We are asking the CNAs in nursing homes right now to do the impossible. They're caring for far too many residents during a shift, and nursing homes often resort to bringing in workers from much higher cost temporary staffing agency to fill those gaps in care. Well, that impacts the continuity of care for residents, which in turn drives down the quality of their care. So what can be done? Training, yes, direct service workers need additional training that includes dementia care and other high acuity skills, and that training and experience should be compensated. Over the years, our members have experienced changes in their day-to-day work. They're reporting caring for more residents on ventilators, with trachs who need wound care, or who require services in memory units. We strongly support investment in training. And we strongly support initiatives to create career ladders for entry-level healthcare workers. But I want to make one point clear. There is dignity in the caregiving that is provided by home health aides and certified nurse assistants. These jobs should be valued on their own. That's what equity really means. I also want to highlight that quality in nursing facilities includes fully staffed cooks, service workers, housekeepers, activities aides. When bottom line decisions drive healthcare staffing, everyone suffers. Now, the most important part of my testimony right now is on wages. The district must follow the lead of so many jurisdictions across the country who've acknowledged the need for investments in workforce. I'm just going to run down the list of states. There's more detail in my written testimony, but New Jersey, Michigan, Tennessee, New York, Colorado, Louisiana, Florida. There hasn't been a one-size-fits-all approach, but every one of these states has prioritized raising wages to address staffing. Our healthcare system is often viewed in silos. We have hospitals, we have nursing homes, we have home care services, clinics. In fact, these care settings are deeply connected. Hospitals have to be confident that they're discharging patients into settings where they'll thrive. We've heard this testimony earlier today. Skilled nursing facilities and home care agencies are charged with ensuring residents aren't readmitted into hospitals. The system can't function when there's weakness in any of these care settings. For too long, long-term care has been an afterthought in our healthcare system, but families depend upon us to center the needs of our elderly and disabled residents now. I want to thank you. I'll stop there, and I'm happy to answer any questions.
Thank you. Janet Phoenix. Oh, okay. Patricia Quinn.
Hi, good morning, Councilmember Henderson.
Good morning.
I am Patricia Quinn. I'm the Vice President of Policy and Partnerships at the DC Primary Care Association. We appreciate this opportunity to share some perspectives at the oversight hearing for the Department of Healthcare Finance. The Primary Care Association works to build a healthier DC by sustaining community health centers, by transforming DC care delivery, and by advancing racial and health equity. Our collaborators in this work include community health centers serving almost 1 in 4 district residents in every ward of the city. And it includes district government agencies, most especially Department of Healthcare Finance. Our partnership with the Department of Healthcare Finance is a very robust and effective one. We're grateful to the work of DHCF in support of health center sustainability throughout the COVID-19 pandemic and beyond. Their actions on payment models and on telehealth remain central to health centers' ability to meet patient needs, despite unprecedented workforce challenges. From our longstanding alliance to develop the DC Health Information Exchange and ever advance its capabilities, to new collaborations focused on health equity and amplifying beneficiary voice, DHCF is a committed, transparent, and valued partner. As the district further invests in a managed care organization approach, and as the carve-in of new behavioral health services brings new providers into MCO systems, the need for DHCF oversight on MCOs grows. DHCF has the power to hold MCOs accountable to improve the functioning and sustainability of a comprehensive, coordinated system prepared to meet the needs of high-priority district residents. We encourage DHCF to support standardization of processes such as credentialing and prior authorization to reduce provider burden and delays in patient care. We can work together to improve payment and credentialing systems so we can all fully focus on ending persistent, pervasive inequities that drive disparate health and well-being in the district. Without a doubt, DHCF plays a central role in the district's push toward health equity, but health equity will not be achieved through clinical care alone. Recognizing this, DHCF is leading the nation in leveraging CMS dollars to build capacity for robust social needs screening and community referral. DHCF should build upon this work and lean into new opportunities offered by CMS to explicitly address health-related social needs via 1115 demonstration waivers or through the use of in lieu of services options. We fully support this effort and encourage DHCF to pursue funding opportunities. When we address the opportunities to build a health system that has equity as its foundation, we must consider how we invest in the providers serving our highest priority residents. Since at least 2009, providers serving Alliance patients have not had any increase in the MCO per visit payment rate of $95. Our health centers will not hold beneficiary care hostage to negotiate higher payment rates with MCOs. We need support from the council and from DHCF to fund and establish a rate that comes closer to cost and acknowledges changes since 2009. As DCPCA supports health centers and their patients emerging from 3 years of COVID-19 pandemic, we're particularly concerned about the restart of recertification requirements for beneficiaries of Alliance and Medicaid. Since the Alliance program began redeterminations, the number of those insured by the program has declined precipitously. We know ESA has struggled to keep pace with the paperwork to complete recertifications. We appreciate their efforts to increase staffing, but we may need DHCF to halt disenrollment if the backlog cannot be cleared. The exponentially larger Medicaid population begins recertifications this spring. Coverage losses due to to delays could have devastating impact on community health centers and their patients. Additionally, beneficiaries who are no longer eligible for Medicaid will require significant support to find new coverage options through the Alliance or on the Health Benefits Exchange. We will need additional allocation of resources to respond to community enrollment support needs and a transparent view into system capacity and challenges to ensure that district residents can access the health benefits for which they are eligible. This will enable the district to maintain its high rate of health insurance coverage that is an example for the entire country. DCPCA and our member health centers are grateful for the partnership of DHCF Director Wayne Turnage, Senior Deputy Director and Medicaid Director Melissa Bird, Deputy Director of Finance Angelique Martin, and Director of the Healthcare Delivery Management Administration Lisa Truitt, and their dedicated teams. We believe in our collective capacity to build an anti-racist health system that gives every district a fair shot at a full, healthy life, and we stand ready to support the DC Council Committee on Health to engage in that effort. Thank you.
Thank you. Ebony Silver. Okay. She was here, but logged off. So we have a small panel here. Thank you to both of you for your testimony today. Ms. Quinn, I just want to ask for clarification because you were a little muddled at this part when you were talking about, you said something to the effect of no increase on rates since 2009. Can you clarify which rates you were talking about there? I don't have your written testimony.
And I'm sorry if you couldn't hear, but that is the Alliance. So
the Alliance.
Yeah,
okay.
The Alliance rate has, and that's as far back as we could find. It might even be a bit longer than 2009, but it is since 2009 for sure.
Okay. Has that impacted your members' desire and or ability to see Alliance patients?
Absolutely not their desire or ability from the perspective of health centers will serve absolutely everyone who comes into the door regardless of ability to pay, and they are bound strongly to that mission. But it does impact their financial sustainability over time, and the array of services that they might otherwise be able to provide if they were being paid closer to their costs.
Okay. And Claudia, feel free to sort of jump in here on this next question. You know, I too have a little bit of heartburn thinking about what's going to happen this summer because there's a lot of things that are kind of going on at one time, whether it be the MCO transition at the same time that we're going to start redeterminations around Medicaid. And in each of the hearings I've had thus far, truly going in to talk to the government witnesses around what level of coordination is happening, how many conversations are happening. But there is a piece here in terms of the stakeholder conversations. And so, you know, Ms. Quinn, Ms. Bullock, well, Ms. Quinn first, have any of your providers heard from DHCF or around here's the timeline, here's what's going to happen, here's what to do if you get questions from patients? Have you had that communication yet?
Absolutely, in really robust dialogue with DHCF about these range of changes.
Okay.
And you know, it's not for lack of commitment. It you know, just staffing, any major transition that involves moving a lot of people from one MCO to the other, or moving a lot of people through a redetermination process where they perhaps haven't done it ever as a beneficiary. We know from history that these things are complex, that it is the beneficiaries who feel the pain first, and second, it is the providers. And so we just want a lot of transparency about what's happening so that we can take appropriate steps collectively as a system to protect beneficiary access. You know, if that means we have to slow the roll on some of this, then we're going to need to do that, because we cannot have loss of coverage and loss of services and the chaos that can sometimes happen for beneficiaries when that goes on.
Right. I think though a little bit I guess kind of gives me a little bit of hope is that there seems to be a high level of coordination. For example, when I talked to Mila Kaufman at the DC Health Alliance, she says, we will receive a list immediately in terms of individuals who are deemed no longer eligible for Medicaid. We will receive that list and be able to contact those folks immediately to get them enrolled, on the exchange. And so I think obviously you need people to, residents, patients are going to have to be willing to accept those outreach efforts, but there seems to be an understanding of what needs to happen. And luckily it won't all happen at one time.
And I agree. We are all absolutely on the same team on this one. It's really like, well, what happens and DHCF especially, what happens if we're not achieving what we hope to achieve? What are the triggers that have us pull back on those changes so that beneficiaries can keep coverage? And I think, the things that are happening, we feel pretty encouraged in the MCO transition. We've seen some things in this transition from Care First to AmeriGroup that we didn't see before in terms of testing and in terms of sort of waiver of some of the things that impact patient care in a problematic way. So we're also hopeful, but it's a trust but verify situation.
Yes. Okay. Thank you so much again for your time. Ms. Balog, thank you again for making time earlier this week to meet and discuss some of the issues that were raised for your membership.
Thank you. I just wanted to highlight Ebony Silver has been in this hearing the entire time as a guest viewing, and she was in the panel. Her Wi-Fi went out. She is trying to rejoin.
Okay.
She does wish to still testify and speak. Oh, there she is.
I think she just popped up. All right. For those who are watching on TV, it says her audio is connecting. So hold on a second. Ms. Silver, if you could hear me, love to hear your testimony. Yes. Oh, great. Wonderful. All right. You have.
I got booted out. Sorry about that.
Not a problem. You can go ahead and present your testimony.
Okay. Good morning, everybody. Good morning to the chairperson Henderson and members of the Committee of Health on Health. My name is Ebony Silver. I'm a resident of Ward 7, a certified nursing assistant in the district, and I'm a member of 1199 SEIU. I'm here before you today because CNAs like me are exhausted and we cannot live on the poverty wages that we are being paid. I became a CNA because I love to care for people. Because before I became a CNA, I worked as a consumer direct home care health aide, caring for my grandmother. Having worked in both kinds of care settings and someone home and facility, I can say that the work I do right now is more intense. It is my job to ensure that residents are bathed, dressed, fed, and helped with toileting. We are the frontline workers who prevent residents from falling and prevent them from getting bed sores firsthand. Our jobs are very physical because we lift residents. We take important health information about their vital signs. We are crucial to ensuring that residents are cared for when they are sick and recovering. I work on the night shift and stand on my feet for 12 long hours, 3 days a week. Even now, while I'm pregnant, the work is so hard and emotionally and physically. Many of my coworkers are quitting, and this have made staff really short. It made the facility have more short staff. I have nights where I'm caring for as many as 16 residents on the floor by myself. People are leaving this field because we don't make enough money to pay our bills. Currently, my rent is $14.50 a month, yet I only make $18.74 an hour. The only reason I can pay my rent and remain in the district is because my mother, she helps me a lot. With the minimum wage in DC going up to $17 an hour, I understand why my coworkers are leaving, because you can get a job at McDonald's for the same pay. Working so short-staffed, it affects our moral and our own physical health. The district must address the crisis level of short staffing in our skilled nursing facility And I urge you to understand that we can't fill these jobs without investing money in the workers who care for our loved ones. Residents deserve dignity, of proper care, and workers deserve the dignity of a livable wage. Thank you for allowing me this opportunity to testify today.
Thank you, Ms. Silver, for testifying and for your vulnerability and sort of sharing the challenges in your work. We're going to ask Department of Healthcare Finance some questions around some of the workforce challenges that you raised. All right, so thank you all for being here. We're going to go on to the next panel.
Thank you.
Thank you.
Okay, the next panel, Chioma Ora, Sarah Barclay Hoffman, Andrea Alago. I'm sorry, I said that wrong. I did say that wrong, but I hope Andrea will forgive me on that. Fernanda Ruiz and Rachel Udison. Okay, I don't see Chioma. Okay, so we'll go to the next person, Sarah.
Good morning, Chairperson Henderson and members of the committee. My name is Sarah Barclay Hoffman, and I work in community mental health policy at Children's National Hospital and the Early Childhood Innovation Network. Thank you for the opportunity to share testimony. Over the past 3 years, district children and families have faced unprecedented challenges due to the COVID-19 pandemic, RSV surge, flu, and the continued behavioral health crisis. At Children's National, our top priority is the health and wellness of the community we serve. Our providers have been on the front lines meeting the needs of all patients. We are deeply appreciative of DHCF's ongoing support in fiscal years 22 and 23. Throughout this pandemic, we have seen a continued increase in staffing costs due to nursing shortages, overtime, and agency staff costs. We thank the department for their commitment to enhanced financial support in FY22, as this has helped us address increased workforce costs and support retention and recruitment efforts. As DHCF continues to make pivotal decisions that will help determine the ability of a Medicaid managed care system to consistently deliver a full continuum of high quality behavioral health services and timely access for all residents, including children and families, we encourage action on key policy decisions that will be critical for the stability and quality of the community-based behavioral health provider network, upon which Children's National patients and providers heavily rely. Additionally, the current and proposed services in the Medicaid rate study are crucial. The following are a selection of the services we recommend DHCF advancing and ensuring they are included as Medicaid billable services in DC at competitive rates to support an adequate network. Attachment and biobehavioral catch-up and parent-child interaction therapy are two distinct and important evidence-based early childhood interventions. Of note, attachment and biobehavioral catch-up can be delivered by non-licensed individuals. Particularly given the workforce shortage, attachment and biobehavioral catch-up should be considered alongside other services and policies that promote the use of peers and non-traditional behavioral health professionals across settings. To advance integrated care, we support the collaborative care model and Healthy Steps. In particular, Healthy Steps is an evidence-based integrated pediatric primary care program for infants, toddlers, and their families. Data show it is efficacious and can realize significant healthcare savings. As a result, some states are advancing Medicaid financing mechanisms for Healthy Steps. We are appreciative that Healthy Steps continues to be contemplated by DHCF for the Medicaid rate study and recommend including all Healthy Steps components as a Medicaid billable service or services, or advancing Healthy Steps through other coverage options. To bolster the continuum of care, we highlight dialectical behavior therapy and partial hospitalization. As Children's National clinicians anecdotally report an increase in suicidality in local youth and the need for intermediate levels of care, now is the time to incorporate dialectical behavior therapy and partial hospitalization into DC Medicaid. We also call attention to DHCF's focus on the needs of special populations. Perinatal mood and anxiety disorders are the most common pregnancy complication, with some studies showing that almost 40% of new mothers of color experience a perinatal mental health condition, yet there is a dearth of available providers. We are grateful for your leadership, Chairperson Henderson, for including the Perinatal Mental Health Task Force in the FY23 budget. We applaud the swift action and leadership by DHCF to stand up a robust task force. This is an important first step in developing and implementing a comprehensive perinatal mental health strategy with a racial equity lens, including advancing any identified Medicaid changes that are necessary. And finally, autism spectrum disorder, ASD for short, is becoming an increasingly common diagnosis. While ASD can be reliably diagnosed by age 2, families often face challenges accessing evaluations and care. We are appreciative of collaborative outreach and engagement by DHCF leadership and staff to understand the scope of issues and innovative solutions, including options for bolstering workforce capacity. We also appreciate continued implementation of the neurobehavioral health enhancement, which was originally included in the FY22 budget and addresses some of the ASD systems challenges. We are eager for the state plan amendment associated with the enhancement to advance in 2023 and for stakeholders to have the opportunity for review and comment. We thank the department for their continued emphasis on improving the health and well-being of children and families, and look forward to continuing to work with DHCF to further strengthen the behavioral health system. I would be happy to answer any questions.
Thank you. Andrea?
Good morning, Councilmember Henderson and members of the committee. It's good to be with you today. My name is Andrea Gallico. I'm a social worker and a certified perinatal mental health provider at Mary Center in Washington, DC. I've worked as a social worker since 2015 and lived and worked in the district since 2001. I currently do live in Maryland. I became a mom a few years ago at the age of 40 and was totally blindsided by the transition that I really felt unprepared for. And that's made me really passionate about working with the perinatal population. So I oversee the perinatal mental health program at Mary Center, provide clinical services and supervision, training for internal teams, and lead collaborative efforts for our integrated care model as it relates to our perinatal participants. I am an appointee to the Perinatal Mental Health Task Force in DC. And I'd like to thank Councilmember Henderson for her work as a champion for this task force, so we can begin this important work. It is critical, however, that we make an ongoing commitment to perinatal mental health in our region. I'm here today to urge this committee to create a pathway for extended perinatal mental health task force work in DC and ensure ongoing collaboration on this topic. It's well documented that perinatal mood and anxiety disorders are the #1 complication of the perinatal period, and that they affect, the statistics range says 1 in 7, sometimes 1 in 5, but we do hear that within BIPOC communities, the statistic is what Sarah Hoffman just said, of 40%. And if left untreated, perinatal mood and anxiety disorders can result in devastating and life-altering consequences for children, birthing people, and the whole family. So looking at a small snapshot of our perinatal mental health program at Mary Center, if we look at the participants screened using the Edinburgh Postnatal Depression Scale over the last 6 months, so that's August 2022 to January 2023, 23 participants were referred to behavioral health services, and only 6 of those 23, just 26%, were connected to a behavioral health provider during that same month. So that averages out to just 1 person per month that's being referred that's actually getting connected to services. Additionally, 17 of these 23 participants, or 74%, self-identified as speaking Spanish as their primary language. and only 3 or 18% were seen by a behavioral health provider in the month that they were referred. I really want to emphasize what Sarah Hoffman just discussed about possible reimbursement for services through Medicaid that are provided by non-licensed providers as possible supports for prevention or treatment of perinatal mood and anxiety disorders. This would really allow us to do some more in terms of the workforce to support this issue. I believe the limitations we're experiencing at Mary Center and our ability to quickly connect perinatal participants to mental health care are also being experienced at agencies throughout the district. Given these limitations, it's imperative that the Perinatal Mental Health Task Force have enough time to do a comprehensive review of the current landscape of perinatal mental health resources and look at the real needs in our city. The current timeline of an October due date, and I appreciate the extension from August to October, but it still feels unreasonable. And given the delays in appointing members and beginning the task force work, an extension of time and funding is necessary. After the report is published, there will be ongoing implementation tasks that will require ample time and funding to ensure that the task force is able to achieve the ultimate goal of improving perinatal mental health outcomes in the district. The creation of evidence-based universal care pathways for identifying and treating PMADs will require new workflows, workforce development efforts, and other widespread interventions that cannot be accomplished between now and October 2023. It will take long-term collaborative efforts between government agencies, healthcare organizations, nonprofits, and perinatal individuals in the district. I'm asking you to lead the way again by making a broader commitment to perinatal mental health in this year's budget cycle. I urge your committee to consider budgeting for an ongoing task force or steering committee to support the implementation of recommendations from the report, as well as to create a method for tracking outcomes in the district. I was in a meeting earlier this week with some folks in Colorado and Massachusetts. Those are great models for ongoing coalition work around perinatal mood and anxiety disorders. Thanks again for your time today and all your work to improve healthcare outcomes for district residents.
Thank you. Fernanda?
Hi, good morning, Chairwoman Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Fernanda Ruiz, and I am the Home Visiting Director at Mary Center and a district resident from Ward 4. I'm here today to provide testimony regarding Mary Center's implementation of the Nurse-Family Partnership Program and how Medicaid can be leveraged to help sustain and grow these and other evidence-based home visiting programs to better support district birthing persons and their children. Mary Center was founded on ensuring access to high-quality, cultural, humble health services for women and their families. Providing these services for almost 35 years, we have grown as a federally qualified health center with our capacity to provide a robust perinatal and early childhood system. That system, internal and external to Mary Center, includes understanding of a need for a continuum of support of diverse home visiting programs. These programs and services are designed to be participant-centered and respond to families based upon their needs. With the recognition of the medical concerns for pregnant persons, including high blood pressure and cardiovascular concerns, in 2020, Mary Center decided that bringing the NFP program to our continuum of supports would assist in responding to the health risks we were seeing, as well as the social determinants of health impacting a pregnancy and the health of newborns. NFP has over 30 years of research confirming its impact and reducing adverse health outcomes, including a 79% reduction in preterm births, 35 fewer hypertensive disorders during pregnancy, fewer cases of preeclampsia or complications of pregnancy, and increased birth spacing for subsequent births. There are also documented longer-term improvements in child health and development, including a 48% reduction in child abuse and neglect, 56 fewer visits to the ER for accidents and poisoning, 50% reduction in language delays, and 39 fewer injuries among children, among others. To launch NFP in DC with an initial team of 4 specially trained nurse home visitors, Mary Center raised $2.4 million in charitable donations. Thanks to the council, we also received $150,000 in grant funds from DC Health. The program has now been live for 18 months. Since our implementation, we have served 95 mothers across the district 8 wards and are currently working with Martha's Table and other community partners to generate more referrals for women in wards 7 and 8. Attaches a table and data outlining our impact and the importance of this work. Of note is that many of our parenting participants present with a multitude of health,
behavioral health, and social situations that place them and their babies at high risk for adverse health outcomes. And as parenting persons have identified challenges, we have seen tremendous acceptance of and retention in this program. That speaks to the quality of the nurses and recognition of our communities of the value of what is offered in support of each other. Of note, as we're seeing the quality of the work of the nurses and engagement of families that would most benefit from these services, we also see that the vast majority are enrolled in Medicaid or DC Health Alliance. Our NFP program, as our other evidence-based programs working with perinatal participants, is working with the same DC community members to achieve and support improving maternal health outcomes. In more than 40 other states, NFP and other evidence-based home visiting programs are funded through a mix of both private and public dollars. At least 37 states cover evidence-based home visiting programs, including NFP through the Medicaid program, and that list is growing. While rates and payment structures vary depending on the methodology used, we know that leveraging Medicaid dollars to support evidence-based home visiting is cost-effective. For example, based upon our current NFP project program costs, if Medicaid funding was used, the cost per family per month is $187. To sustain our current program and expand capacity for more pregnant persons in Ward 7 and 8, the total cost would be $449,200. Funding NFP and other evidence-based home visiting programs through Medicaid is not only cost-effective, it also promotes better coordination of care and services for pregnant persons and babies who are enrolled in managed care. Thank you for the opportunity to testify today.
Thank you. Rachel?
Hi, good morning, Chairperson Henderson, members of the committee and staff. My name is Rachel Usdan, and I'm testifying today on behalf of Peace for DC. Gun violence continues to plague DC's most underinvested communities and has begun to spread further now, striking fear in all residents. When you peel back the layers and look at the stories and lives of both the shooters and the victims, so many of these incidents are wrapped in layers of trauma. Trauma of hearing gunshots, trauma of losing a classmate or sibling or parent, trauma of seeing a dead body, of structural violence, of state violence. The list can go on and on. While there is nothing as a cure-all, if we can treat these many layers of trauma and help people who suffer PTSD and other byproducts of their trauma, we can break the cycle and drastically reduce violence. In our testimony, we want to highlight one specific recommendation for how the Department of Healthcare Finance can make a difference in helping us heal this trauma. The federal government has, since 2021, been encouraging states to utilize Medicaid funding for hospital-based and community-based violence intervention work. Several states have moved forward to make this happen, including California, Connecticut, Illinois, New Jersey, and I also heard recently Maryland. I spoke at length with individuals in Illinois who helped develop the program that was implemented in that state. They advised that a waiver, which is onerous to accomplish, is not necessarily needed, and that DC can likely move to get a state plan amendment. Each state gets to determine what qualifies for Medicaid, and in this case, the disease would be chronic exposure to gun violence with symptoms including PTSD, substance abuse, etc. We need to think through what ages qualify and ensure we are including children, teens, and families. The state also gets to determine who qualifies to deliver services. And we hope that this will include outreach workers, hospital-based violence intervention workers who have a variety of official job titles, mental health professionals and paraprofessionals, case managers, violence interrupters, life coaches, and so on. Based on the experience in other states that have spearheaded this effort, it's important to be thoughtful about how the roles of who delivers services are defined. For example, we want to make sure that these job descriptions are background friendly. We don't want to disqualify someone for having a criminal history. We don't want to require certifications or degrees that would disqualify otherwise strong providers. This is a really important source of sustainable funding that we urge the district to put into place as ARPA dollars begin to sunset. DC has one of the best Medicaid reimbursement rates, basically $3 added for every dollar that DC puts in for something like this. And if the language is properly written, this funding can really go a long way towards supporting this essential work. Our understanding that there has been at least one initial meeting with the Department of Healthcare Finance, but we have not been involved. And as we understand it, the next steps would involve designing a program and getting it certified. It's a long process, but we urge the government to work with advocates and consult with other states and follow this path as expeditiously as possible so DC can utilize Medicaid funds for violence intervention work. Taking a step back, this is just one component of a much larger, overly complicated, siloed network of government and community-based violence reduction efforts. To achieve better outcomes and really stop the violence, we need clear coordinated leadership and a citywide, unified, evidence-based, community-centered strategy. The best models that have worked in other cities and in the past in DC are the ones that are evidence-based and community-led. We need to build up the skills and capacity of DC's brave community violence intervention workers and empower them to bring about the peace that we also desperately want. It's called community violence intervention, not government violence intervention. And we need government funded solutions, not government delivered solutions. It's going to take a change in the way we think about it and a shift in the model, system change, but this will help stop the spread of this disease and build a healthy, peaceful city. Thank you for listening to my testimony.
Thank you. I think Rachel has to go for a meeting. So thank you, Rachel, for your testimony, and we'll follow up with you at another time because I know you have to run. We've added Lindsay Niles to this panel. Just as a reminder to folks, if you are in the attendee room to be promoted, your name has to be right so that we can see it and know that you are the right person. So Ms. Niles.
Good morning, Chairperson Henderson. My name is Lindsay Niles, and I'm a managing attorney at Disability Rights DC at University Legal Services. DRDC appreciates the opportunity to testify regarding the performance of DHCF. DRDC is the designated protection and advocacy program for people with disabilities in DC. Under our federal mandate, we advocate on behalf of hundreds of citizens with disabilities each year to promote their rights to live in the community and be free from harm. DRDC is a member of the DC Coalition on Long-Term Care and joins them and our colleagues who previously testified in calling for the district to establish a living wage of $24 an hour for the direct care workforce. The focus of my testimony is on three areas. First, DHCF's performance in preparing for the Medicaid unwinding process. Second, DHCF's ongoing plans to transition to a fully managed care program. And third, DHCF's addition of housing supportive services to the district's array of Medicaid services. May also refer to my written testimony, which addresses these areas in detail. On April 1st, DHCF will begin the process of redetermining Medicaid eligibility, which is commonly referred to as the unwinding process. DRDC requested from DHCF its plan to provide an accessible unwinding process for people with disabilities. An accessible process is critical to help minimize wrongful Medicaid eligibility denials. My written testimony describes the key elements of an accessible renewal process. We appreciate DHCF has stated it will consider our recommendations on how to make the renewal process accessible, but to date, we have not seen a meaningful plan from DHCF to ensure accessibility. Instead of DHCF conducting enhanced outreach directly to this population, DHCF plans to rely on providers and stakeholders to conduct outreach and help beneficiaries in the renewal process. This approach is troubling because providers such as EPD waiver case managers do not have DHCF's expertise to shepherd beneficiaries through the complicated renewal process. Moreover, many beneficiaries do not have a case manager to help them gather and submit information needed to renew. We also urge DHCF to extract and publicly report renewal outcome data on how many people with disabilities lose coverage, broken down by reason, including procedural denials. We appreciate that DHCF plans to add additional information in its renewal notices on ways in which a beneficiary can receive accommodations in the renewal process. Although important, that step alone is not meaningful unless DHCF also monitors that notices are sent in accessible formats and that the requested accommodations are provided by trained staff. We ask DC Council to monitor how DHCF will ensure the process is accessible to people with disabilities. DRDC is also concerned about the change from fee-for-service Medicaid to a fully managed care system. Specifically, we are concerned about how the MCO's capitated system could chip away at the community-based service system, resulting in service cuts or delays in receiving critical services. Accordingly, we urge DHCF to ensure that capitated rates are sufficient to meet the level of need for such services, such as EPD waiver and IDD waiver services, community support, and ACT services. If the capitated rates are not adequate, MCOs may be incentivized to reduce the number of authorized home health aid service hours or limit the intensity of mental health services a consumer receives to save money. DHCF also needs a robust accountability system to ensure that services are not improperly reduced or terminated and that conflict-free case management is maintained under the EPD waiver. Finally, DRDC strongly supports the addition of housing supported services or HSS to the array of Medicaid services to benefit individuals who are chronically homeless. However, we urge DHCF to expand the eligibility criteria to be inclusive of other unhoused residents with disabilities in the community and people segregated in institutions like nursing facilities and psychiatric hospitals who seek to transition to the community. This choice to unnecessarily limit access to HSS leaves far too many unhoused district residents struggling to receive the support they need to navigate the district's cumbersome housing process. Many of our clients are Medicaid beneficiaries who are unhoused or housing unstable and need assistance in maintaining permanent, safe, and supportive affordable housing, but they do not qualify under the narrow criteria for HSS. In fiscal year 23, the district projects that it will have a cost savings associated with HSS of over $35 million. But expanding the HSS eligibility criteria to include these populations, it will allow the district to reinvest more local dollars in housing vouchers and other housing resources. Consistent with federal guidance and the broader approach of 5 other states that provide HSS, expanding this Medicaid authority would also align the district's efforts to end chronic homelessness and comply with the integration mandate of the Americans with Disabilities Act. Thank you again for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Thank you to this panel of witnesses. I do have a couple of questions just for some clarification. Ms. Nels, I'll actually start with you. I've had this running joke from all of my hearings around having a running list of acronyms. So HSS, Housing Support Services?
Housing Supportive Services, yes.
Okay, is that different than permanent supportive housing?
So housing supportive services are actually provide housing navigation assistance to people who are unhoused and experiencing homelessness so that they can apply for housing, and it also helps maintain individuals in housing. So recently, it's become a Medicaid authorized service, a state plan authorized service. And so the district has limited the eligibility criteria to people who are experiencing homelessness and eligible for permanent supportive housing. What we are urging DHCF to do, as many other states have, is to expand the eligibility criteria so other unhoused district residents can get that housing navigation support and support to maintain housing, like individuals who receive mental health services in the community, people that are stuck in nursing facilities and want to transition to the community, and folks in psychiatric facilities that need transition assistance to get to the community.
Okay, thank you. Thank you for that clarification.
Of course.
And we'll ask about that. Ms. Hoffman, in your testimony, you mentioned attachment and biobehavioral catch-up. Can you explain what that is?
Yeah, it's a early childhood intervention. It's a dyadic approach, so it works with both the parent or caregiver and the child. Can be from infancy through age 4, and particularly focused on caregivers and children who have had adversity, traumatic experiences, and there may be is concern or at risk for disruption in that attachment, and having a secure attachment relationship, which is really critical. Having those responsive interactions between the caregiver and the child, that nurturing parenting, and it's a strengths-based intervention where the coach, as I noted, does not have to be a clinician. They do go through a rigorous training and certification process, but it's a 10-week session, and they coach the parent in terms of those interactions, that nurturing relationship. Happy to get you more information.
Yes, that would be great. Especially, I think, because you said that this isn't a licensed position.
It can.
I mean, it can be.
Right, but it doesn't have to. And so, yes, we'd be happy. It's come out of the University of Delaware. It has a significant research and evidence base, and happy to provide more information on that.
Yeah, that'd be great. I had a long meeting yesterday with DC Health on licensing. So I know we can certify, register, and license just about anything. And we do a lot, 72 different professions. So if you could follow up with us on more information on that, that'd be great. Ms. Alago, I think, am I saying it right? Alago? Agalico. There we go. Agalico. Yeah. Thank you so much for your testimony. I will say this. I obviously have some questions for healthcare finance in terms of their maternal health work. When we put a sunset on the perinatal mental health task force, in our minds at the time, the maternal health advisory group would have been continuing. So there would have been the report, and then that would have passed along to the advisory group to continue work. Especially since it seems as though folks in the community really enjoyed that work that was coming out of healthcare finance around maternal health, and the opportunity to periodically come together to talk about how do we strengthen, how do we improve, and all of those different types of things. And so I think somebody else talked earlier around, I think it was Leah from Children's Law Center, about the reimbursement rates and those kinds of things. So I'm going to ask healthcare finance about the decision to dissolve the group or not have them meet, because I think it was the intention of ours that, okay, we'll do this small set aside to just focus on perinatal mental health, but we will always have the maternal advisory group. And frankly, so long as the District of Columbia has the issues that we have in terms of maternal health outcomes in this city, somebody within the health cluster should be having a constant conversation about how we improve, and not just an annual summit, but something that is going on regularly with providers. So we'll ask about that.
That's great.
Thank you. Ms. Ruiz, we met and talked a little bit about the nurse family partnership, and also talked with Ms. Schlossberg about that, even though she was here today on the long-term care coalition. And we have some questions for healthcare finance in terms of that expansion. I know anytime we talk about spas, it probably gives the Medicaid team at healthcare finance a little bit of heartburn because it's such a process, but I think that this is super important. So thank you all of the public witnesses for your testimony. I'm 1 minute over my time, and I'm trying to be mindful. So thank you so much. We're going to go to the next panel. I'm going to call the next group. Chioma Aurora will put you on the next panel. And in fact, we're just going to call everyone who is remaining on the witness list for Department of Healthcare Finance. So that will be Stephen Gordon, Sally White, Clayton Brightwell, Veronica Sharp, Samara Washington, and Faye Shoshana. Just to give folks a roadmap of what we are going to do, we're going to do this next panel, and then we're going to take a 10-minute break because we have been here for a bit, and then we're going to come back and then we'll do DMHHS. So we're going to do the next panel, take a break, and then come back. Okay. Dr. Gordon, I see you here. If you want to go ahead and present your testimony. There you are.
Hello.
Good morning.
Good morning. Thank you so much
I'm so sorry. I'm so sorry, Dr. Gordon. Well, go ahead. Well, Chioma, if you don't mind, you'll go next.
Okay, great. Thank you so much, Chairman Henderson and members of the Committee on Health. My name is Dr. Stephen Gordon. I'm the founder and CEO of Edenbridge Health, and we are opening and operating the district's first ever program of all-inclusive care for the elderly, PACE, serving elderly residents of Wards 7 and 8 east of the Anacostia River. We are thrilled to announce that we are now taking referrals for this critically needed program. As there are significant federal and Medicare and district Medicaid program requirements for PACE, we've been working closely with the staff from the Department of Healthcare Finance. And I can say without reservation that the staff have been exceptional partners in this process. Especially want to acknowledge the leadership and support of Catherine Rogers, Director of Long-Term Care Administration, and Jacqueline Gold, who's the PACE coordinator. We look forward to taking you on a tour of the center, Chairperson Henderson, and welcome other members of the Committee on Health as soon as your calendars allow. That said, we are eager for DHCF to employ a process that will ensure timely completion of the level of care assessments so that individuals who desperately need PACE and other services can enroll as soon as possible. PACE is specifically designed to meet the needs of older adults with low incomes who are unable to care for themselves and might otherwise require nursing home care. The goal is to allow seniors to age in place in their own communities, living the best life possible. But we face a critical hurdle that can make this impossible for us to serve those who need it most. There's a significant backlog of potential participants waiting for required in-home assessments, but by the Department of Healthcare Finance contractor, Liberty, to determine the level of care for each participant interested in our program. These assessments are supposed to be completed within 5 days of referral, but due to understandable staffing shortages, Liberty is now scheduling assessments for mid to late April at the earliest. We are very grateful that Liberty has prioritized our applicants, but as referrals pick up with the level of care assessments renewals beginning in April, the backlog is likely going to continue to grow rapidly. This will affect our ability to enroll district residents in PACE in a timely manner. This backlog affects all district residents seeking long-term care and supports. Delaying care to older DC residents with fragile health conditions means that needs will go unaddressed and social isolation is unabated. In addition, it risks that people are going to end up unnecessarily in the hospital and potentially end up in nursing homes at the cost of the district. In the last 3 weeks, since we've gotten our final approval, we've received 189 inquiries about possible enrollment. 44 of those are prospective enrollees, meaning that we believe they meet level of care, Medicaid and Medicare status, and have expressed interest in joining the program. Of those 44, 40 of those require a level of care assessment before enrolling. We anticipate the list of potential participants who need level of care assessment will grow by as many as 20 people per week or more as we continue to identify those most in need. At the rate at which Liberty can operate now, and even with the eventual influx of new employees they're trying to hire and train, there's no way that they can clear the growing backlog and keep up with the volume of assessments and reassessments needed by Edenbridge PACE and many other providers. We urge DHCF to employ all tactics available to alleviate the backlog and mitigate the possibility of it reoccurring. We have a number of suggestions about how to resolve this problem. The first is to allow the resumption of assessments conducted through remote, web-based, or telephonic means as provided through the public health emergency. DHCF should still be able to operate under the temporary authority granted due to the public health emergency until May 11th, when the PHE will officially end. The second is to enter into an emergency contract with a second and possibly a third company to provide these level of care assessments. Our third suggestion is to deploy all qualified staff within the Department of Healthcare Finance and the Department of Aging and Community Living to conduct the assessments. And our fourth and probably preferred option is to amend the assessment process to allow PACE staff to conduct the in-person assessments and submit the assessments and their information to Liberty for them to score and make level of care determination. Just to note, there's a precedent for this change, as 21 of the 32 states that have PACE currently allow for PACE programs to lead the level of care assessment process, including our neighbors in Maryland and states like California and New Jersey, just to name a few. In these states, PACE programs use state-approved tools to gather information for level of care. PACE programs submit the completed tool to the state agency or agency charged with reviewing, scoring, and approving or denying level of care. PACE may also submit additional information regarding the individual's functional and cognitive abilities as support material, and the state agency notifies the PACE program of approval or denial. You can see in Appendix A in my written testimony for more details about how this process would work. We are eager to support DHCF in any way we can to move forward with these changes. We are concerned that if solutions are not employed immediately, the backlog of assessments puts the sustainability of Edenbridge PACE at Skyland in jeopardy. We have been fully staffed and ready to provide services for several months, and we are very grateful to DHCF staff for the push to assess our first enrollees, but this will be an ongoing challenge for PACE and many other service providers. We will not be able to sustain our program if we cannot enroll participants in a timely manner every month going forward. District residents and service providers advocated to bring PACE to this community for more than 20 years, and we are incredibly honored and grateful to be the first PACE provider in the District of Columbia. We have an amazing program in place and we are ready to go. We are eager to help in any way we can to fix the assessment issue and deeply appreciate your attention to this matter. Thank you so much for the opportunity to testify. Welcome any questions.
Thank you. Chioma?
Hey. Thank you. Thank you so much for that, Councilmember Christina Henderson. As a current member of the Medical Care Advisory Council for the Department of Healthcare Finance, I would like to connect the dots of the political determinants of health to some of the other boards and commissions that I sit on that enlighten my level of understanding that I want to introduce for consideration. For your awareness, some of the other boards that I currently serve on are the Family Support Council of the DC Department on Disability Services and the Coordinating Council for School-Based Mental Health out of the DC Department on Behavioral Health. I've previously served as a member of DCPS's Early Childhood Policy Council, the local school advisory team at Tacoma Elementary School, and I served on DCPS's Chancellor Antoine Wilson's Parent Cabinet representing Ward 4. Through the years of public service in these capacities, I have grown a greater appreciation of the interconnectedness of the systems that compose of the systems of care. Getting back to the political determinants of health, there is an increase in crime that correlates to the rising cost of food and unaffordability of housing. And most critically, yet underscored, health services, especially health services for vulnerable populations dependent on Medicaid and Medicare, have also taken a serious hit in the past few years. There is much discussion of the healthcare workers crisis, and yet not enough discussion in the reduced quality of healthcare services. Because my work focuses on children, youth, and their families, especially those with disabilities, this testimony speaks to this population in a way that I hope enlightens the adult and elderly care connections to similar issues. One key lesson of working steadily at the intersection of healthcare and education through services on the before-mentioned boards and commissions is the performance indicators for the positive development in both capacities are very much connected to poverty, disability, housing status, and access to transportation. They are primary and primal needs that as they continue to go unmet will cost us more in the future if the proper healthcare investments are not made. I fully support the strengthening of connections in systems functions for school health, especially as it relates to school-based mental health, yet feel that as health services in general become more accessible during the working hours for DC public and public charter schools, there are opportunities to create more well systems connected to these other systems impacting the political determinants of health. We must take a deep dive into how and why certain services are invested in without much consideration to their effectiveness, and how and why other services are not invested in at all. This includes investments in a peer workforce, which is a recommended practice by both U.S. Department of Health and Human Services, as well as the U.S. Department of Education. Also connecting the dots to how healthcare dollars can be used to address social needs that are barriers to healthcare and a quality of life. For example, there are recreational services that have therapeutic benefits in which Medicaid dollars could be invested in beyond the therapeutic recreation center, because that is not accessible to all constituents who need inclusion in the public and private recreational offerings of the city. Also, with many issues facing transportation during the school day and also through Medicaid funded transportation service, particularly for eligible children and families with disabilities, I would think that it is a no-brainer that having a joint health and education hearing to get to the bottom of the transportation crisis and how to resolve them with better financial investments, which should include DHCF dollars. Another key lessons through the years in service have taught me that the health.
You're over your time.
Oh.
Well, I'll ask some questions. I'll ask some questions.
Sure.
Okay?
The rest of my testimony is written and I have submitted them in writing. Thank you.
Okay. Thank you. Sally White.
Good morning, Chairperson Henderson and members of the committee. My name is Sally White. I'm working with the exciting new Edenbridge PACE program of all-inclusive care for the elderly at Skyland. PACE is designed to meet the needs of adults age 55 and older with low incomes who would qualify for nursing home care, but who want very much to remain in their own homes, in their own communities, living the best life possible. As the PACE provider, Edenbridge is responsible for providing all the services that each participant needs, including routine medical care, specialized care, therapies, assistance with activities of daily living, medications, socialization, transportation, and even hospital care when needed. It's the job of the interdisciplinary PACE team to seamlessly integrate Medicare and Medicaid benefits and ensure that everyone in their care receives superior medical management and the care and support that allows them to live as well as possible in their own homes while providing respite and other support to often exhausted family caregivers. For PACE participants who are eligible for both Medicaid and Medicare, there's no charge to the participant or the family members. All PACE programs are housed within a PACE center, which serves as the hub of activity, including an active day program that offers seniors the opportunity for socialization, health management, meals, and much more. We are extremely pleased that the beautiful new Edenbridge PACE Center is located at the Skyland Town Center in Ward 7. It's hard to really imagine the impact that PACE will have on the individuals and families the program will serve. Imagine Mrs. B, an older widow languishing in her home. Perhaps she walks with a walker, has high blood pressure and diabetes. She used to be vibrant and active, participating in one of the senior wellness centers, but no more. Now her days are spent at home alone. Imagine now the same woman picked up every morning by the PACE bus, the driver helping get her coat on and maneuver down her front steps. When she arrives at the center, she's greeted warmly by staff and served a hot breakfast while enjoying the company of friends she's made at the program. Afterwards, she visits the therapy room to do physical therapy to lower her risk of falling. The medical staff then check her health status with special attention to her diabetes, which is now under control for the first time in many years. She then enjoys a hot lunch and an afternoon of activities. When she heads home on the PACE bus, the laundry that staff have washed for her while she's been at the center goes home with her. Once at home, an aide helps Mrs. B with her dinner and preparations for bedtime. This is but one simplified scenario of a PACE participant who benefits tremendously from the program. There will be hundreds more, many with significantly more advanced and challenging health conditions who desperately need this service. You heard from Dr. Gordon about the serious assessment backlog issue faced by PACE and other programs. So I want to briefly address another issue, the workforce issues, in testimony by Claudia Schlossberg and others, to increase the number of direct care workers by lowering the age requirement from 18 to 16, establishing training programs, and much more. Perhaps most importantly, by raising the minimum wage of direct care workers across all settings to $24 an hour, a real living wage for these workers. Thank you for the opportunity to testify before you today and for your attention to the needs of older adults in the District of Columbia.
Thank you. Clayton Brightwell.
Hello, good morning. I'm Clayton Brightwell. I work for Party of Life Care, the management company that oversees operations for Livingston Place Assisted Living located at 4656 Livingston Road Southeast in Washington, D.C. Winstina Williams and I would like to highlight three of the following topics. First, I would like to thank the Department of Healthcare Finance for their efforts they are making to create a new rate methodology for the current and daily assisted living rate. The continued funding for Medicaid assisted living is significantly important to our seniors in our district. This allows assisted living operators to provide continued services to our seniors. Secondly, I would like to encourage the continued improvement of the eligibility and enrollment process with the emphasis on the need to streamline and automate processes and ensure providers have visibility into systems and the ability to assist with applications for Medicaid and the EPD waiver and complete recertifications for the beneficiaries in the district. For example, if Mr. John Doe is currently living within the community and needs assistance with applying to the EPD waiver program, the many assisted living communities here in the district have the ability to help Mr. John Doe, as well as other seniors in the district that need assistance. In closing, I would like to request the increase of the personal needs allowance for our seniors. It is urgent, the need to increase these funds. $100 does not go far with the rising cost of services and goods. Cell phone plans alone can cost up to $100. Buying clothes, occasional entertainment, holiday fun, and paying for medications. It's impossible to have $100 to carry them through a month. We implore DHCF to increase the P&A so our seniors can have the sense of financial capability. Thank you for allowing me to testify today, and I welcome any questions.
Thank you, Clayton. Veronica Sharp. Veronica, if you are speaking, you are muted. There you are.
There we go. Okay.
There you are.
Okay. Good morning, Chairperson Henderson and members of the Committee on Health. My name is Veronica Sharp, and I am the president of the District of Columbia Healthcare Association, which represents all of the district's licensed nursing facilities and several assisted living communities and the nearly 3,000 district residents to whom they provide care. But first off, I'd like to say that we have a healthy and robust relationship with DHCF, and we applaud them for their hard work and transparency. The long-term care community is facing serious and unprecedented issues following the COVID-19 pandemic. One of the most serious issues is the lack of direct care workers and nursing staff. We have always had a nursing shortage, but the pandemic has made staffing a monumental problem. I sit on several workforce task forces, including the Mayor's Healthcare Workforce Task Force, and I recognize that there are many issues to the staffing challenges we face. But perhaps the biggest challenge is the inability to pay a true living wage. Since the end of the pandemic, private industry has increased wages for entry-level jobs that require less training than what is required to be a CNA. Potential employees have made the choice of working for more money and having a less taxing job or undertaking the hard, intimate work of being a direct caregiver. It is time to recognize the importance of the work that these individuals do. I apologize. That these individuals do, and set rates for providers that recognize that wages need to be increased to at least $24 per hour. Providers have been paying overtime, referral bonuses, and shift bonuses, and despite these efforts, they sometimes still have to refuse admissions because they don't have the required 4.1 nursing hours per patient day to care for them. Since the announcement of the date of the end of the PHE, which results in the end of the add-on payments to SNF and AL providers, DCHCA has put together a task force to calculate the funding that will be needed to stabilize the industry once the additional funding has ended. It may be determined that the 20% is the correct amount, or we might find that a different amount is needed. DCHCA members recognize that the agency has taken steps to improve the eligibility process, but this is still a serious problem and results in untimely payment of claims. The MCO lack of prompt payment also ties up funding for members and causes additional financial strains above the ever-increasing costs of goods and services. I want to thank Melissa Bird for helping a member recently and for her continued attention to this matter. Another issue that has recently been raised is the lack of long-term care service and supports for the Alliance beneficiaries. An Alliance member enrolled in an MCO may enter skilled facility and will have benefits for 90 days. After those 90 days are over, the facility is not paid for providing services and cannot discharge the resident because of this DC 6-108 law that sets parameters for safe discharges. I have begun conversations with department staff, hoping to have a change in that coverage policy. DCHCA and its members understand and respect the difficult task that the department has been charged with and the remarkable job that they have done. We thank Deputy Mayor Turnage, Melissa Bird, Angelique Martin, Catherine Rogers, and their staff for ongoing efforts, and we applaud their many successes. Thank you for your leadership on this committee and the opportunity to testify. I will answer any questions.
Thank you. Samara Washington.
Good morning, Chairperson Henderson and council members. My name is Dr. Samaria Washington. I am the chair of the DCHCA and Regional Director of Operations for Bridgepoint Healthcare. Today, I am speaking as a healthcare professional. I would like to recognize the Department of Healthcare Finance for the incredible job they have done. A particular note of thanks to Deputy Mayor Turnage, Melissa Bird, Angelique Martin, and their staff for their ongoing efforts to make improvements and their subsequent successes. We appreciate the 20% add-on. However, we understand that it will come to an end with the end of the public health care emergency. While the PHE may be ending, the increased expenses for operators has not and likely will not for the foreseeable future. Operators are struggling even with the 20% add-on. We continue to experience unprecedented costs associated with caring for our residents, to include hiring and retaining adequate staff to care for some of the most vulnerable residents in the District of Columbia. While the COVID-19 pandemic appears to be somewhat under control, we must deal with the aftermath of what the pandemic has done to our workforce and the health of our seniors. The nursing facilities in the District of Columbia will suffer severe financial stress if the 20% add-ons are rescinded at this time and additional funding is not identified, even above and beyond the 20%. Some of the line items driving this financial crisis are extraordinary increases in labor costs, increased expenses, and decreases in revenue. We have always competed with acute care hospitals, but now we must compete with Amazon, Target, Uber, Lyft, et cetera, for our frontline staff. We work diligently to control extra shift bonuses and other incentives, but find that we must continue them in order to attract and retain staff. Despite our best efforts, it is still not enough. Supply and utility costs have also continued to rise due to inflation. And if rising expenses were not enough, we have also been hit with decreases in revenue due to increasing infections, for example, CRS and COVID-19, which can limit our bed availability, staffing challenges, and delays in payment from managed care organizations, and delays from other payers processing claims and approvals. We humbly ask that you consider maintaining, if not increasing, funding for skilled nursing facilities in the nation's capital. We're thankful for the efforts of the leadership in the district and their work to try to help our industry prior to and throughout the pandemic. We are eager to continue the good work we do in partnership with the District of Columbia. Thank you for your leadership and the opportunity to testify. I'll take any questions if you have any.
Thank you. Faye?
Good afternoon, Chairperson Henderson, members of the Committee on Health. My name is Faye Shoshana. I am Chief Financial Officer for Health Consulting Services, representing 4 skilled nursing facilities in the district: Deanwood Rehabilitation and Wellness Center, Serenity Rehabilitation and Health Center, Inspire Rehabilitation and Health Center, and Unique Rehabilitation and Health Center. In 2022, these facilities collectively served 1,465 residents, 89% of whom are Medicaid beneficiaries. Geographically, the buildings span the district from northwest to northeast to southeast, wards 2, 6, 7, and 8, serving a diverse range of residents with complex social and clinical needs. Having supported DC skilled nursing facilities in various capacities since 2010, I feel gratitude to have the opportunity to be part of serving the residents of the district. I would like to acknowledge the government of the District of Columbia, specifically the Department of Healthcare Finance, for the unwavering support of the district's skilled nursing facilities and the residents that call the skilled nursing facilities their home. Department of Healthcare Finance is an agency that understands the needs of the population we serve, both the acuity and the complexity, who have been true partners to the skilled nursing facilities. Department of Healthcare Finance anticipated the financial impact of COVID-19 pandemic on skilled nursing facilities in an almost prophetic manner. They empowered us to do what it takes to care for our residents by the 20% increase in rates. I clearly remember being moved to tears by Angelique Martin's empathy, intelligence, and understanding of the residents' specific needs while COVID-19 reared its ugly head and stretched us thin. The responsibility shouldered by those caring for this most vulnerable population is often overwhelming, and I cannot overstate the value in feeling understood and supported. I would like to recognize Melissa Bird for her personal attention to every need raised. In 2022, Melissa's attention ameliorated the eligibility process, decreasing barriers towards eligibility approval. Since first quarter 2020, the facilities have struggled with staffing, particularly nursing staffing. We have lost an untold number of employees, and vacancies are difficult to fill. The crisis is deep, and it is painful. The realities of the role of direct nursing care, therapy, housekeeping, maintenance, dietary, and security do not allow for the remote flexibilities that other industries can offer, and the workforce's willingness to accept the labor-intense work that skilled nursing facilities require has diminished. Facilities have embraced the challenge, employing an arsenal of strategies. leveraging technology, hiring dedicated recruiters, and implementing bonus and incentive programs targeting both recruitment and retention. However, as basic economics of supply and demand requires, the overarching and most crucial step in addressing this challenge has been pay rate increases. Our greatest concern is the well-being of our residents, and we are keenly aware of the potential impact our staffing challenges and the challenges the nursing home industry as a whole is facing can have on our residents. Over the past 3 years, we have implemented a series of wage scale increases affecting facility staff at all levels and positions. These initiatives were separate from and above DC mandated minimum wage increases. We have relied on Department of Healthcare Finance's enhanced Medicaid rates to fund today's industry standard pay rates to attract and retain the skilled staff needed to care for our residents. With the oncoming sunset of the enhanced Medicaid rates following the end of the public health emergency, the financial and operational future of the facilities beyond July 2023 is precarious and frankly frightening. At this time, facilities are projecting significant and unsustainable operating losses. Facility leadership have heard from our employees of their struggles with today's rising costs. These struggles are driving them to higher paying jobs outside of healthcare, despite the fact that their hearts were devoted to resident care. Our employees need to be taken care of to be good caregivers. We recognize that working as a service provider is a critical but not easy job. Decreasing employee pay is impossible. With no holds barred, employees will resign. Labor market conditions are such that employees will pursue other opportunities available to them. Staffing is already extremely tight. Facilities are staffed by a smaller number of staff members working overtime at levels 5 times what they were before the public health emergency. Not having the staff required to care for our residents is morally and legally unfathomable. We appreciate the impact of a stable workforce and the benefits of continuity of care for our residents. When agency staff have been used, the rates increase up to 250% and are catastrophic financially. As facilities redouble efforts and provided high quality resident care in 2023, our skilled nursing facilities respectfully request the committee takes action to ensure that the current enhanced Medicaid rates be maintained so that facilities can competitively recruit, retain, and sufficiently staff to provide the care the residents deserve while paying fair living wages to all employees. I thank you for the opportunity to testify today.
Thank you. And just so you know, Mr. Shauna, we could not see you. So I don't know if you had attended to have your camera on, but you have the little slidey thing that's blocking or not, but I just wanted to let you know that. Thank you to all of the witnesses who testified here today about a variety of issues I think that a lot of folks have already raised. Ms. Aurora, I wanted to go back to you in terms of, I think you were speaking about using Medicaid or increasing the Medicaid reimbursement to help deal with the OSSI transportation issue. Do you want to expand upon that?
Yeah, sure. And it's Dr.
I'm so sorry.
No
Apologies.
worries. Political scientist, not medical doctor, but still all the same.
Still, hey, I want to give you your props.
Yeah, I think that, and that's just a drop in the bucket, right? Like there are many things in which this emergence between health and education has to offer that's promising, especially, of course, transportation being such a critical problem. These can be remedied with better investments and better coordination, which would require investments. I know that when I say that, I'm recommending peer workforce, I do recognize that even caregivers and peers and those with lived experience have barriers entering the workforce as well. I'm not saying it's a one-stop shop, but system navigation, transportation, specific with transportation. I know that's a key issue that you're looking at, especially with the amendment that you brought up around how students with disabilities can be transported to OST. I mean, these are things that for those who receive HSCSN or any Medicaid service can be eligible for transportation as well. Now, are those transportation services working optimally? No, they're working also not as optimally as OSSI DOT. I mean, whatever that indicates in terms of the value of children with disabilities, that's another statement. But where the solution comes in, I think, is looking at where the funding comes in for transportation services to and from doctor's appointments, other therapeutic services, and student transportation, and where can maybe the resources be combined to create a new pathway, an avenue for transportation services. What can it look like to even increase the technology? I know one thing that is missing is that knowing what's happening when it's happening. If your student is being transported from north to south of the city, the parent, with all of the Uber technology there is, have no knowledge. That would reduce anxiety by, I think, decimals, just by being able to see that, in addition to being able to work with an entrepreneurial base of caregivers, which I am in community with, which I did note at the end of my testimony that I wasn't able to share, but I did know, I am openly inviting you, all members of the committee and city council, to join in a co-learning space with a caregiver political education boot camp that we are administering to come up with innovative solutions to our own problems that we see as we navigate through the carceral logic of different systems, especially in including healthcare. I mean, there are so many things in just my relationship with caregivers, solutions that they know about, that they think of, where are the investments to bring those ideas into fruition, into implementation status.
Okay. Thank you. We'll follow up on that. Mr. Brightwell, I appreciate you being here, and I think you raised, again, an excellent point around the P&A, being that $100 has to not cover just, cell phone and clothes, but also if you have a copay for medications, that it has to cover that as well. What are you hearing from residents when they realize that this is all they have?
So working within the community, it stresses them. They don't understand how they can live off of $100. Just the cost alone, with the cell phone, medications, personal needs, soap, other items that they may need. It's very hard to live off of $100. They struggle, being out in the community, and people that are interested in assisted living, once they find out they're only receiving $100, they really struggle with making that decision to enter a community or enter an assisted living and, kind of improve their health environment. And so it's been a struggle.
Yeah, I definitely can understand that. Thank you for being here. Ms. Sharp, I just wanted to ask one quick follow-up in terms of, you said you were a member of the mayor's workforce healthcare task force. You all started meeting last year?
We did, and we ended in September. And I know that there is a draft report coming out fairly soon, but it's not ready yet.
Don't worry, I'm gonna add that to my list for the city administrator, because I gave him like a list of 6 things that people have said is in draft form that we haven't seen yet. Okay. Great. We'll follow up on that front. Thank you to all the other witnesses on this panel for your testimony, and for everyone who testified on healthcare finance. As I stated, to try to do some expectation setting at the beginning of this panel, we are going to take a 10-minute break, and then we're going to come back and do the public witnesses for Deputy Mayor for Health and Human Services. So thank you again to everyone, and we will be back shortly. Thank you. Okay, we are back. Apologies for the extended length there. Trying to work on a technology issue on our end. We will continue now with the public witnesses for the Deputy Mayor for Health and Human Services. I'll call up the first panel of witnesses. Anna Griffith, Sheila White, Wesley Thomas, Rachel Ellison, and Robert Warren. Just as a reminder, you have to affirmatively accept our invitation for you to be elevated as a panelist. Okay, I see Anna, so we'll go ahead and start with you. Go ahead.
Thank you so much. Good morning, Chairperson Henderson and members of the committee. My name is Anna Griffith, and I work as a bilingual mental health therapist at Mary Center. I'm here today to share about the barriers to recertification for Alliance and the human cost of the current complex and lengthy process, as well as negative consequences for participants' physical and mental health. The current process is too long and too complex, and I hope that addressing these issues could facilitate participants' continuity of care and ability to access necessary services. I'm grateful that DC recognizes the importance of healthcare for all DC residents, regardless of the ability to pay or immigration status. I am proud to be a DC native and also a mental health therapist here, and I applaud the Council for its efforts to reduce the burden to Alliance participants in the application and recertification process, such as the elimination of the 6-month recertification and the in-person renewal requirement. However, much work remains to be done. While supporting my clients, I learned about the complex 68-page application and the lengthy 45 business day waiting period. I understand that some participants have been waiting since September for their recertification and to resume insurance coverage. Many of my clients with Alliance coverage have had issues such as language barriers, limited education and literacy, transportation, and increased mental health challenges. They choose between working, seeking food or housing, often delaying medical care, or working on and following up on their applications. I'd like to speak about one of my clients, Mrs. A, to illustrate these challenges and costs of the current situation. I'm supporting her in therapy to process multiple incidents of traumatic grief, anxiety, and depression. Despite her risk factors and challenges, she demonstrates strengths such as consistent attendance, motivation, managing her physical health, support from family, and the bilingual health access program at Mary Center. Even with these strengths and resources, she's experienced heightened mental health symptoms while navigating the system to recertify. After her insurance lapsed, she hesitated to continue services with me based on her fear of being unable to pay out of pocket. With the help from DBH, I obtained a 90-day interim coverage for her behavioral health services. Even so, she canceled some of her appointments and delayed other medical care for the first time during our treatment. My client often struggles with asking for help, cannot read or write, struggles with technology, and only speaks Spanish. I provided information to facilitate seeking the necessary documents, and I've worked closely with her, her family, and the BHAP staff. This process was even more confusing when our MCO contacted her, although her insurance status had not changed. This week, she received a letter stating that her insurance was approved. However, she can not access care still since the Medicaid portal shows it's inactive. Despite her patience and gratitude for support, she found the process overwhelming and often spoke of the process while anxiously crying. She is not my only client who is struggling with the recertification process. I know she is one of many affected DC residents. The current system is too complicated, and waiting 45 business days or much longer after submitting paperwork is too long. As a mental health therapist and social worker, I felt ethically compelled to learn about the recertification process and found it surprisingly confusing, difficult, and onerous. Other patients do not have such support. I'd like to offer the following recommendations. Please clarify the Clarify in the participants' preferred language about when their insurance will expire, the necessary steps to avoid losing coverage, and how to resume coverage. Clarifying and simplifying the process. The 68-page application is too long. Fully staff in order to decrease the processing time for recertification applications. The current 45 business days harms the health and well-being of the affected individuals and families. Provide improvements and accessibility features to the enrollment website. I understand that participants are going in person to submit their documentation and application because the website is so challenging. Finally, I would ask that improvements be made in general to the experience of seeking multilingual support at the EACAC, including reducing waiting times and providing support to understand the process and help with completing the application and understanding the necessary documents. In conclusion, I would like to reiterate my gratitude for the Council's support for immigrants and the DC Health Alliance Insurance. The service facilitates community members seeking.
I'm so sorry, you're
over.
over your
That's
time.
okay. Thank you.
We'll just have
I didn't
to,
see the timer. Go ahead.
no problem. We have to keep it moving here. Sheila White. Okay, not here. Wesley Thomas. All right. If either of these individuals are here but are under another name, you need to rename yourself so that we know that you're here. But I do see Ms. Ellison. Want to go ahead?
Hello, good afternoon, Chairperson Henderson and members of the committee. My name is Rochelle Ellison, and I come from the chronic homeless population 14 years ago and was able to receive all the resources I needed to jump over a lot of hurdles. Today, I am the Senior Mentor Advisor of PFFC and the Fellow at Miriam's Kitchen and a DBA Certified Peer Specialist. And I'm just coming on here to advocate that the resources that I was able to receive when I was in the chronic homeless population was plentiful, quick, fast. I got housed within 9 days. I got SNAP benefits and I got Medicaid in an expedient amount of time. And today I'm a professional advocate who advocates for those that are still our unhoused neighbors. And it is the time limit is taking so long for them to receive housing, SNAP benefits, as someone else was saying, the Medicaid. And I'm just on here to advocate because I just feel like they should have the same resources and the expedient amount of time that I was able to have them in order to elevate to the positions that I'm in today. You know, I was given housing in 9 days through a collaborative Pathways to Housing DC. I got mentally baseline. It gave me the foundation I needed to make a decision because I had co-occurring disorders, to not want to use drugs any longer. So now I'm going on 9 years clean and sober. And I chose this field because I still lived experience that I have in this field and the population that I come from. And I'm so passionate about others coming in behind me, having those same resources available to them that are not expedient as they were when I came in off the streets of the nation's capital. I live here in Washington, DC. I've been able to jump over hurdles, and now I live in Adams Morgan, you know, and it's just that the turnaround times for the LRSP vouchers, not having the staff available. And my recommendation is using certified peer specialists such as myself that are HMI certified, HIPAA certified, you know, because we're so passionate about helping the process and removing some of that red tape. We have the connections that we need. So I'm just very grateful for this opportunity to testify today. On behalf of Miriam Kitchen and PFFC, housing is a human right. I'm on the Way Home Steering Committee for the Way Home campaign. And we believe that every human being deserves a home and the wraparound services that they need to be a better version of themselves. And I thank you for the opportunity to testify. Thank you.
Thank you. Robert Warren.
Thank you, Councilmember Henderson, for this opportunity to testify for you today. My name is Robert Warren. I am a lifelong DC resident, one of the founding members of the organization People Fairness Coalition, one of the current co-directors, and in our organization, we're one of the first organizations to actually sign on to the Way Home campaign. That campaign is a campaign to end chronic homelessness in the District of Columbia. And a lot of those folks that we serve and and advocate for, like Ms. Ellison just said, are folks who are currently unhoused and experiencing what we call housing instability here in District of Columbia. And me first, I just really like to just acknowledge just the folks who testified before me, specifically in your last hearing, and just the amazing work that so many people are doing, and so many people have done during this public health emergency, and just the work you've done, Councilmember, and Councilmember Grasso before you, and the help you guys gave us in making sure that folks who are unhoused are not being discriminated against in the District of Columbia. So we have what you call now the Human Rights Enhancement Act, where folks who are experiencing housing instability are now part of protected class. And being part of that protected class and acknowledging some of the past disparities that we've seen, saying we have our office on racial equity. We have the mayor's office on racial equity. We have the council's office on racial equity. And we're starting to see all these inequities that have been occurring with communities for a long period of time, specifically, that have been brought to light during this public health emergency. And, my comments, I really just wanted to comment on the fact that I was actually at the McPherson Park closing yesterday. And the reason why that park closed is, the mayor and the deputy mayor on health and human services decided that that park was a danger to not only to the residents living there, but also to the surrounding communities. And my whole thing was I'm not for encampments in DC. I don't advocate for them, even being a homeless advocate, but I believe that there was an agreement made with the Park Service in the city that we would, house those folks, saying through this public health emergency until the end of hypothermia season, and would allow service providers and providers to come in and communicate and with individuals about how they can get the services they need. And I think the failure for me, the failure that I've seen is just breakdown of the system, specifically where, we've, like I said, we've done so much, but we still point out so many inequities and that, places that we need to improve on and connecting, individuals to services that are experiencing housing instability is a big piece to that because housing is healthcare. And I think we have shown that housing people for DC taxpayers is cheaper than keeping them unhoused. And
Mr. Warren.
yeah, just to wrap it up, I would just ask you, Councilmember Henderson, please look at Homeward DC 2.0, and it calls for forming a commission to look at housing in the District of Columbia as a human rights, and for us to all come together and really have that conversation about, what should be the public policy when it comes to individuals over the age of 55 years of age in the District of Columbia, long-term resident, and their access to housing. Thank you for the chance to testify.
Thank you. Thank you to the witnesses on this panel. I just have a couple of follow-up questions. Ms. Griffith, you spoke about the Alliance recertification process, which has already started and is underway. Do you know what the notification looks like? And by notification, I mean the notice that you need to either recertify or you may face a termination. Is it only sent via mail? Do you receive it via email? Is it only in English? Can you expand upon that?
Or, I mean, so my understanding is that there were things that were mailed out, notifications. My understanding, there was not anything besides one letter. And as you can imagine, there are a lot of challenges with that if people face housing instability, if they move, if the letter comes in English, even though the stated preferred language is something else. For the clients that have lost insurance, I only found out a week before, sometimes less. And I think a lot of people are really only finding out when they call to make medical appointments.
Oh, that they are no longer covered.
Right.
Interesting.
And it's possible they lost coverage months ago. I think, I'm sure you have more questions, so I'll let you speak, but it is astounding the issues that I've encountered.
No, this is helpful. In a strange way of the Alliance going first. We can learn upon the lessons and the failures of what's going on with this population when we have to do a larger group later this year with Medicaid. And so that's been one of the things is around like, how do we communicate to people? Are we doing multiple communications to folks so that they know? And so that, as you're saying, the first time someone's learning that they're no longer covered is not when they're trying to schedule an appointment.
Right.
But I have some questions for healthcare finance on the recertification process for the Alliance. And we'll certainly ask about the length of time that it's taking, because I heard that in your testimony in terms of the long.
Yeah, my understanding, sorry to interrupt, my coworker puts numbers for people that they specifically helped to recertify, and of people that have already submitted all of their applications. It includes people that are still inactive since they submitted the application in September, October, November, December. We're in February, so that's many months without insurance.
Right. Okay.
And that's like best case scenario, right? After they've already figured out all the documents and navigated the system.
Excuse me. We'll certainly dig into that to kind of figure out what's happening there. Ms. Ellison and Mr. Warren, thank you so much for your testimony. Ms. Ellison, I appreciate you sharing your story. And, I think what you shared in terms of the length of time versus what we know is the length of time today, not just for all the various components that are kind of like overlapped, whether it be what's happening at DHS, what's happening with DCHA, what's happening with all, sort of the voucher process. So I have some questions on that as well. So thank you all so much for your testimony. I don't see any of my colleagues here. So we're going to go on to the next panel, but thank you for being here.
Thank you so much for the opportunity to testify.
Thank you.
Yeah. Okay, so we're going to go to the next panel. Yona Bromberg-Gaber, Homer Thomas from the Washington Academy Preschool, Jesse Rabinowitz, Reginald Black, and Kelly Andre. I hope I'm saying that last name right. If I'm not, please correct me. Okay. And as a reminder for those who are coming in, to be elevated as panelists, you do need to affirmatively accept our invitation. We see you, Yona. Just give us a minute. Okay, we're going to get started. Yona, there you are.
Ready?
Yep.
Good afternoon. Thanks for allowing me to testify. I'm sure that lots of people today will be talking about the encampment eviction at McPherson Square yesterday. I think it's important to understand that's really the results of a long-term DMHHS strategy of displacement and prioritizing these evictions over actual help. In August of 2021, National Park Service evicted about 20 people from the Gompers and Burke Parks on Mass Ave. At the time, DMHHS claimed they were doing active outreach and had exhausted all efforts to ameliorate concerns. While residents and communities members knew that to be false, I was able to finally follow up with FOIA requests. Emails from that June and July showed that DMHHS intentionally withheld an approved porta potty from the site, despite human waste being the primary concern. Further, there is evidence that they met directly at the end of July with NPS to specifically develop false language that NPS could use to justify the eviction, while they were publicly saying that they were working on get people housed. In fact, the emails documented the big to-do it took to get staff to actually visit the site one single time in July. There were no responsive documents indicating DMHHS was reaching out to DHS to facilitate housing, was working with pathways to reduce harm, or really doing any work besides asking NPS to evict. After the eviction, they relied solely on pathways workers casually asking and tracking in order to track people who had been evicted. This was despite weeks of warnings beforehand about the disconnections to services that were provided. We know some of the people living in the park at that time waited more than a year afterwards before actually getting housing. We don't know the full impact on whether that everyone has actually gotten housing since then because there is no tracking. We also need to note the prioritization of funding. DMHHS explains that the care program funding wasn't some specific budget, but was just borrowing staff and resources from other departments. What gives them the right to make that prioritization decision over the council's own budget priorities? Why are DPW workers, DDOT workers, DHS and DBH workers forced to handle something that is very clearly not furthering the missions of their jobs? It is a culture of disregard, and it is clear that DMHHS does not provide any value to our unhoused residents. Therefore, I request that the council directly remove encampments from DMHHS purview and further move to ban encampment evictions. You have failed to fix this housing crisis with DCHA, with the Housing Production Trust Fund. And now that we are punishing people year after year for suffering from that failure is abhorrent. I hope that you actually take action this year to fix that and to prevent these evictions, or we will continue to have these awful traumatic confrontations. On a separate note, I also wanted to validate the observation from the previous panel about signing up for recertification for Medicaid. I have, in my other work, encountered a lot of people who are receiving certificate letters that they are decertified and have lost already their insurance before ever receiving a notice that they needed to recertify. They never received that notice. And so I wanted to validate that that is something I am also seeing a lot. Thank you for letting me testify.
Thank you. Homer Thomas. Okay, not here. All right, Jesse.
Good, I guess, afternoon, Councilmember Henderson. Thanks for the opportunity to testify. My name is Jesse and I work at Miriam's Kitchen, where we work to end chronic homelessness. I want to paint a picture of a DC that I think we all want to live in. It's a state where nobody experiences homelessness, nobody lives in crowded shelters, encampments are not commonplace. Everyone has the housing that meets their needs. We don't evict people from encampments because we have funded housing at the level needed to end homelessness. We've reduced drug overdoses by funding safe consumption sites and harm reduction centers. People can address their underlying medical conditions from the safety of their own home. Nobody dies while living outside. We've met the Bowser's goal for ending homelessness. Let's contrast that to yesterday. At the request of the deputy mayor, the National Park Service forcibly evicted over 50 of our neighbors and arrested 2 unhoused veterans who were doing their best to survive. This was cruel, harmful, and avoidable. McPherson, where people have been sleeping for decades, is notable for its size and because DC directly asked the federal government to evict our neighbors. Contrary to the rhetoric of the Bowser administration, people in McPherson report staying there because they felt safe, because there was light, and because there was a community. But it is also part of an ongoing pattern of encampment evictions happening often twice a week all across DC. Just last week, DMHHS evicted 3 encampments. On Valentine's Day, DMHS evicted 2 encampments with less than 24 hours notice. This is notable as many encampment evictions are now immediate dispositions, which circumvent DC's problematic and established encampment protocol. Yesterday, a vigilante also decided to evict an encampment on their own. Evicting encampments has become DC's primary response to homelessness. None of this ends homelessness. Other people are going to talk about why encampment evictions are harmful. I'm going to talk about why DMHHS constant encampment evictions prevents DC from achieving the vision I laid out earlier, one where we have ended homelessness. Many people who experience homelessness do not trust the government has their best interest. Who can blame them? For many folks living outside, they often see the government only when officials show up to throw away their tent or bulldoze their friend. A huge part of connecting people with housing is building trust. That often takes months and starts with things like socks or a cup of coffee. Often case managers bridge this divide in trust between clients and the government while working to connect them with housing. When the government steps in and closes an encampment, the trust resets to less than zero. Progress made is not only lost, but set back even further. This helps no one. Ending homelessness takes lots of hard work by case managers, clients, and other parties. When DC announces a large-scale encampment eviction, especially 2 months ahead of schedule, entire teams of people must drop what they were doing and swing into crisis mode. Instead of taking clients to view apartments, out workers spend time mitigating harm. They shift their focus to one area instead of their entire territory. The government prioritizes encampment response, thereby shifting resources away from implementing vouchers that will end homelessness. Encampment residents must plan where to move next instead of spending their time working with case managers to find housing and supportive services. Yesterday, we saw that when the government wants to, they can move quickly when they want something bad enough. DMHHS coordinated multiple DC and federal agencies to evict our neighbors. When there is urgency, where is that urgency when it comes to addressing case management services, an issue which advocates and DHS have raised for 18 months? In fact, the National Housing Justice Collaborative offered free guidance to help DC develop a plan to quickly move through the voucher backlog. DMHS declined this request. Instead of marshaling DC and national brilliance and collective resources to implement the housing that it already has funded, DC seems more interested in turning DC into a no-tent zone. Had the focus on the past 18 months been on addressing staffing and not evicting encampments, we would be closer to our goal of ending homelessness. When people are evicted, as Yona shared, they're moved from encampment to encampment. Encampment clearings without housing push people around. Often you will hear the claim that people were offered shelter. If every person staying in an encampment went to shelter tonight, the system would implode. There are simply not enough beds. Moreover, the beds that do exist are in crowded shelters with strict rules that curb autonomy and limit human behavior. Most people living in encampments have tried shelter. It didn't work for them. The Pet Hotel program has shown that another form of shelter is possible. People who often decline crowded shelter jumped at the opportunity to have their own room. However, this program is coming to an end. This is misguided. Instead of returning to antiquated shelter system, DC must build non-congregate shelters and dignified shelters to reduce the barriers to access. DC, for the first time, has the resources needed to significantly reduce homelessness for single adults. We are the envy of other states, but these vouchers remain stalled. Less than 20% of permanent supportive housing vouchers for single adults funded locally in FY 22 and 23 have been used. That means nearly 2,000 people could be living in housing that meets their needs, but are instead living outside in shelter because DC can't get its act together. I'll testify at other hearings about the solutions to these issues, but it's notable that instead of actually fixing the system and improving interagency collaboration, DMHHS remains focused on evicting encampments. His team pulls together providers, DBH, DHS, and DOH, not to end homelessness, but to displace people. DC must ensure that encampment evictions are extremely rare, brief, and non-recurring, not the weekly and recurring trauma that they are. The same should be true. DC must decide if we want to continually displace encampments or double down on implementing what we actually know ends homelessness, housing. We cannot do both.
Thank you, Jesse. I have some questions later. Mr. Black?
Hello, can you hear me?
Yes, sir.
All righty. Good afternoon, Councilmember Henderson, members of the committee, and District of Columbia residents. My name is Reginald Black. I'm a native Washingtonian, Ward 4 resident, and I am the Housing Advocacy Director for Serve Your City Ward 6 Mutual Aid, and I'm here to testify to the performance of the Deputy Mayor of Health and Human Services. DMHHS is currently an integral partner in the fight to combat homelessness, and the last 3 to 4 years have been unprecedented. We've overcome a global pandemic, racial overtones and strife, and the District of Columbia has advanced racial equity in its language, and it is safe to say we have yet to really put these words into use. Our organization has been serving personal protective equipment like toilet paper, hand sanitizer, masks, etc. These items are integral to helping survive in this unprecedented time. Throughout our engagements, we have witnessed engagement after engagement, i.e. cleanups. Some were teased to be full engagements only to be called off when members of the community stepped up to assist neighbors. Our organization was present when residents were removed from McPherson Park in the height of hypothermia. Just to note, Deputy Mayor Turnish's public political heat should not fall on his fellow cabinet members, namely the Interagency Council on Homeless Director and the Department of Human Services Director. His office is by law compelled to the ICH. Deputy Mayor Turnish, I don't see you at meetings. Right now, DMHHS is essential to our work to flatten the curve of housing instability, and it's time we compel the Deputy Mayor's office to equity and to follow national and local protocol to protect our neighbors. In 2020, the ICH conducted an internal racial equity audit. You should ask Deputy Mayor Turnage, has DMHHS engaged with ICH to conduct its internal audit? It did not participate in the previous one, and I will send documents that speak to that as part of the record. How can we can say that we are committed to racial equity, but how if our public entities refuse to participate? How can we really say we are an inclusive city when we choose to exclude employees, consumers, and partners by choice when given the chance to have a voice? Thank you for the opportunity to testify, and I'm happy to answer any questions you may have.
Thank you. Kelly?
Yes, thank you so much for the opportunity to testify today. My name is Kelly Andre. I'm the Executive Director at Georgetown Ministry Center, which is a drop-in center and street outreach program that serves chronically homeless individuals in DC. GMC serves over 800 unique individuals each year who are experiencing homelessness in our city. A majority of the guests that GMC serves sleeps outside, under bridges, on benches and doorways and in encampments. I'm particularly concerned with the treatment of encampment residents on city land and DMHHS's encouragement of the National Park Service to enforce no camping zones on national parks. I do not believe that anyone wants encampments to exist in our city, but the solution is not closing encampments. The solution is housing and supportive services. Encampments are a visible symptom of the poverty and lack of affordable housing in our city. Closing encampments and enforcing no camping zones under the pretenses of safety does not make people safer or end their homelessness. It just displaces residents, causes trauma, and moves safety concerns to a new location. Closing encampments is counterproductive to the agency's stated goals. It's costly and harmful to DC residents. When you close encampments, you are criminalizing being homelessness. A study in New York found that crime complaints from surrounding communities does not decrease in the 30 days following an encampment clearing. Though the former encampment residents experience an increased risk of arrest and physical assault following those closings. Closing encampments contribute to drug overdoses and erodes prevention framework and harm reduction measures that are created by service providers. The city is downright hostile toward unsheltered individuals, which pushes people into more dangerous and isolated environments. It contributes to stigma and the perception that these residents are throwaway people. People internalize that message. We work with 2 guests currently who literally wear trash bags and disguise themselves as piles of trash because they think they are less likely to be displaced as bags of trash than they are as unsheltered humans. Constantly treating people like physical trash that you don't want to be seen does not inspire hope for them to participate in the support systems that have been created. As a result, they get tagged as service resistant or unwilling to accept help. But when the system constantly fails them, they're continually falling through the cracks. Why should they trust us? You build trust and engagement by being consistent. And when you continue to enclose encampments and throw away their sparse belongings that they've collected for survival, you undermine that work being done by the direct service providers. Closing encampments is harmful and counterproductive. They create unnecessary costs to DC. They perpetuate the message that unsheltered individuals don't matter, and they cause harm to carefully constructed communities of support for these individuals. The real solution to homelessness is to house people, and that's where the money should be spent. Thank you.
Thank you, Kelly. And thank you to all of the witnesses on this panel. Jesse, you kind of mentioned in your testimony, well, I was looking at the last 20 seconds that you were like, I don't have time to talk about solutions. You said you'll do that with the other committee, but in the interest of, I don't know how many other hearings might be going on the day that DHS is doing their hearings. So there are a couple of different things, right? So one thing that has come up is workforce. Now, as part of the workforce under that umbrella has been, we can't get licensed people. I've heard things about the exam. But really, when I look at it, are we not focused on salary as a recruitment tool? Because like, if I look at like Mary Center, I just go on their website right now, you know, they're looking for a social worker or, you know, licensed independent social workers or licensed clinical social workers. Their starting salaries are at 68. If I go to, say, Pathways site, their starting salary is 50. So how do we, I don't want to have us sort of go down one horse sort of chasing as like, this is going to, if we do this, then it will fix it. It's sort of like we're playing a little bit of whack-a-mole here.
Yes, and we're playing a game of whack-a-mole also by displacing encampments from one place to another. But I agree with you that this is a salary question, though the work of doing homeless services is really hard. People don't want to make $50,000 for, you know, traumatic, hard work. People with a licensure could work at Miriam's Kitchen making $50,000 a year with the same degree requirement, go to DHS making $80,000 to $100,000 a year. We need to pay people more. I think that is true and continues to be true.
Okay. I see you shaking your head, Kelly. I don't know if you want to weigh in here.
I agree with Jesse's comments that, yeah, it is a salary issue amongst other things. And that comes from reimbursement rates that folks have as amongst many other factors.
Okay. Well, I will be digging, at least for the part that I can handle on this committee in terms of like the Board of Social Work. We have a hearing with them on the 28th. Board of Social Work, Board of Psychology, and a couple other boards, but those are the two ones that I think are kind of critical here around some of these things. Mr. Black, I wanted to follow up on your testimony around ICH. You talked about an internal audit. Is that currently going on right now? Oh, you're on mute.
So my understanding is that the government agencies that didn't participate the first time would have a chance to participate after. But we haven't seen anything that is looking at the different questions all of the agencies and their consumers were asked in terms of like consumer voice, some of what was spoken by some of the colleagues on the panels of how the employees are being treated. Do they feel like their agency is equitable towards the clients that they serve, these types of things? We haven't seen that. And this entire audit was internally conducted by the ICH as a whole. And so the Deputy Mayor's Office is one of those agencies by HSRA designated to the ICH, and that agency did not participate at all. I will send you my written testimony that shows the consultant who was in on that. He identified each and every agency that had yet to participate. And so we need to make sure that that those kinds of things happen. And on that note, I just think it's very unfair when there are questions for his office that the ICH director or DHS director have to answer questions that's directed at his office. I think they get undue political heat for that, and it's just not fair. And if we're talking about equity, the form that we have ICH right now with a staff full of, you know, women of colors, especially, they should not be getting heat in the form of white males who may agree with ending homelessness. That should not happen. The deputy mayor should have been present to directly take, you know, this challenge because he is over the Health and Human Services cluster.
Okay. Thank you all. Thank you all for your testimony. And if we don't have your testimony, please make sure you submit it to us so that we can have that for the record. And we'll have some questions on all of these things for the deputy mayor when we get there. We're going to get to the next panel. We are moving along. I want to say I appreciate everyone thus far who's kept to their time. I just want to make sure that everyone can be heard. Barbara Alas, Again, apologies if I am saying your last name incorrectly. Leah Bartleys, Natasha Corley, Lily Milwit, and Ann Stoudemire. Staudenmayer. Again, for those who are joining us, who have just been called to join this panel, you have to affirmatively accept our invitation to be elevated. Barbara, do we have Barbara? Okay. Barbara, we've sent you a panelist invitation, and I see you in the attendee room. If you could just accept that. Okay, we'll keep trying. She might have stepped away. Is Leah here? No, Leah. Okay. Natasha. Okay. All right, I see Lily, so we're gonna go with you.
Thanks. Can you hear me?
Yes.
Great. All right. Good afternoon, Councilmember Henderson. Thank you for the opportunity to testify at today's performance oversight hearing for DMHHS. My name is Lily Milwit, and I'm a resident of Ward 1. I'm also the Housing Not Handcuffs attorney at the National Homelessness Law Center, where I work with advocates, organizers, and attorneys around the country to identify policies and practices that criminalize homelessness and try and use the power of the law to replace those policies and practices with approaches that prioritize housing over handcuffs and prioritize dignity and humanity for all people experiencing homelessness. Though headquartered in Washington, D.C., our organization is national in focus. We typically engage with local advocates when criminalization policies and practices become so egregious as to demand national attention. It is in this capacity that we have been made aware of the policy failures of the Deputy Mayor's office and the repeated and routine encampment evictions around the city. I actually originally drafted this testimony last week, focusing on urging the Deputy Mayor's office to reconsider its planned eviction in McPherson Square unless and until that office could make good on its promise and obligation to connect all unsheltered residents to accessible housing. I drafted that version of my testimony in hopes that the Deputy Mayor's office and the National Park Service would heed the advice of hundreds of local and national advocates urging the local and federal government to pause the expedited encampment eviction at least until its original scheduled time in April and respond to the reasonable requests of unsheltered DC residents to be connected to housing and resources before being forcibly displaced. Instead, I rewrote my testimony yesterday evening after I, along with those advocates and many of the folks testifying here today, spent most of yesterday bearing witness to the forced eviction and displacement of unsheltered residents who called McPherson Square home. Many of whom were living in McPherson Square only after having been displaced multiple times over the course of the last 18 months from encampment communities around the city. Many of whom were waiting on local government officials to fulfill their promises of housing. Many of whom have active complaints about the DC shelter system and are awaiting responses to those complaints. Most of whom had no idea where they would sleep last night, and all of whom thought they had until April to work with service providers and outreach workers on their housing plans. We watched as those residents surrounded by armed National Park Service police were evicted and threatened with arrest. We watched as their survival materials, including tents, blankets, furniture items, supplies, and vital documents, were arbitrarily deemed invaluable and destroyed. We watched as service providers and outreach workers, many of whom have been in McPherson Square every day over the last weeks and months, providing resources and forming relationships with unsheltered residents, were denied entry into the park to help. One person who did not stand with us to watch yesterday's events unfold was Deputy Mayor Turnage. As NPS carried out his office's orders to clear the park 2 months ahead of schedule, as advocates and media demanded accountability for the policy failures that led us to this point, and as unsheltered residents sought answers and solutions, the Deputy Mayor was nowhere to be found. This should not have been surprising to those of us who know that while the Deputy Mayor's office cited an inability to provide services and outreach to the residents of McPherson Square as justification for expediting the eviction, DMHHS did not have a presence in McPherson Square during the days, weeks, and months leading up to yesterday. Instead, it has been the local activists and advocates, most of whom volunteer their time and many of whom themselves have lived experience of unsheltered homelessness in the district, have had to take on the work of providing basic necessities to residents of McPherson Square and attempting to connect them to housing and further services. As previously mentioned, many of those residents were living in McPherson Square only after having been displaced, in many cases multiple times, from encampment communities across the city. These evictions, like yesterday, have been carried out at the behest of the Deputy Mayor's office and local government. In citing the large number of residents at McPherson Square for the reason that the Deputy Mayor's office cannot provide services and housing, the office is skirting its administrative and moral obligations by blaming problems and challenges that they themselves have created. This is particularly reprehensible when we know that DC has adequate funds and supply to connect its unsheltered residents to housing. Continued displacement without housing is not because of a lack of resources or solutions, it is because of a lack of political will. I have a lot more information in my written testimony about how all of these policies and encampment evictions violate federal policy, including policies promulgated by USICH, the Department of Justice, and the Centers for Disease Control as recently as last month when the USICH released its federal strategic plan to prevent and end homelessness, routinely clearing encampment sites and then clearing the new ones that crop up as a result of original clearing seems to be DC's sole response to addressing homelessness and rising housing insecurity. This out of sight, out of mind approach has never worked in the past. It is governed against by the federal government and by the DMHHS's own policies. And while out of sight may mean out of mind for DMHHS, it does not mean out of mind for those of us who will continue to demand more and better from the Deputy Mayor's office and continue to hold him accountable for the policy failures that exacerbate and prolong homelessness in our community. Thank you.
Thank you. Anne?
Can you hear me?
Yes, we can.
Great. All right. Thank you. Thank you, Councilmember Henderson. My name is Anne Marie Staudenmeyer. I am senior counsel at Washington Legal Clinic, where I've been an attorney for 26 years. My testimony today concerns DMHHS's role in overseeing the eviction and displacement of hundreds of unsheltered residents from public spaces over the past few years. It bears repeating that these practices are traumatic, counterproductive, and a huge waste of government resources. I'm disheartened when I come before you today because we and other advocates have testified multiple times before this committee. And yet, Deputy Mayor Turnage has only become more emboldened in destroying our unsheltered neighbors' homes. Despite vociferous opposition from advocates and government officials alike, no one in an oversight capacity has ever taken steps to rein them in. We really hope that changes with your leadership of this committee. I've been monitoring encampment evictions for more than 20 years under multiple administrations. Sadly, the tenure of Deputy Mayor Turnage stands out as the most mismanaged, cruel, and harmful campaign to rid the city of visible evidence of homelessness that I have ever witnessed. If Deputy Mayor Turnage's past oversight performances are any guide, his testimony will fail to address the fact that the rate of unsheltered homelessness has increased during his tenure. He will focus instead on the relatively few encampment residents who have been matched to housing. He will also try to paint his critics as being uninformed and hysterical, which is what he said last year, while trying to hide the fact that his policies clearly have worsened the problem of street homelessness. You've heard ad nauseum about DMHHS's role in expediting the McPherson Square clearing. What's most troubling about that clearing is that DMHHS themselves did virtually no outreach until 2 weeks ago when they started performative measures like sending so-called service buses to the encampment that many of the residents did not trust for good reason because it was the first time they'd seen people from DMHHS. And then they claimed that the residents weren't willing to engage with them. The rationale that they used to justify this expedited clearing was rampant violent crime that was unsafe to everyone there. That's been disputed by both residents of McPherson who I've spoken with, outreach workers, and I can tell you personally that I have been to that encampment several times and have never once felt unsafe. It's far more dangerous to force 50 or 60 people out of their only homes during hypothermia season without any connection to housing. Deputy Mayor Turnage has blamed the bottleneck in housing matches for the fact that there were so many people left unhoused yesterday. He acknowledged that only 15 out of the 70 people there had been matched to housing. The irony is that the blame for this lies with DHS, an agency he oversees, and its refusal to match anyone to housing due to lack of case managers, which is not a prerequisite to being housed. DHS's unconscionable underuse of housing funds authorized by this council is the real reason so few McPherson residents have been offered housing, not a refusal to engage. Prematurely evicting them guarantees it'll be much harder to house them in the future. I was at the clearing of McPherson yesterday as well, along with hundreds of other advocates, outreach workers, government officials, and bystanders. We watched in horror as the park police, under the orders of DMHHS, literally destroyed every single tent and personal belonging left in that park, despite promising to store those items. Deputy Mayor Turnage didn't bother to show up at the expedited clearing that he had personally ordered, but his team ignored all of our calls to save the personal items that clearly belonged to people. It was a shameful spectacle, and it should be an embarrassment to the entire DC government. This is just one example of the overreach by DMHHS that uses massive government funds and numbers of employees to clear single people out of encampments. All the encampments Jesse mentioned had 1 or 2 people in them, and yet there's at least 10 government employees at every single one of those clearings. Yesterday, I watched 20 government employees sitting in government trucks, eating popcorn or just looking at their phones, being paid by our taxpayer funds to watch what was happening in the park instead of actually doing their real jobs. As you know, the vast majority of the McPherson residents have been displaced from other encampments. It proves that encampment clearings don't solve homelessness. If Deputy Mayor Turnage's methods worked, we would see a reduction in the numbers of street homeless instead of an increase, which is what happened over the last couple of years. The legal clinic doesn't want to see anybody living on the streets, nor does anybody else. If DMHHS spent the vast amounts it spends destroying encampments on improving its shelters and connecting people to housing, we wouldn't be in the position that we're in. And we ask that you, as in your oversight capacity, hold Deputy Mayor Turnage to upholding those principles that will actually end rather than hide homelessness. Thank you.
Thank you. Before I ask any questions, I still see Barbara Elias. You are an attendee. You're supposed to be on this panel. We've sent you a request to be elevated. And I just want to give you an opportunity to accept that and present your testimony. Okay, well, we'll keep trying. Lillian and thank you so much for your testimony and for your continued advocacy. Yeah, before even I was chairing this committee, I've been to hearings where you all have presented testimony on a variety of things. And so definitely appreciate your attendance here today. I don't have any specific questions per se, but do know that we'll be bringing up questions regarding encampments to the deputy mayor when he is before us. So thank you so much for being here today. And please make sure that we get your written testimony. I think Lily, you said you rewrote yours last night, so I'm not sure if you submitted it yet, but please make sure you send it over.
Thank
All right.
you. I sent mine last night.
Thank you, everyone.
Thanks.
And we're going to go to the next panel. Matthew Gannon, Jenna Israel, Daniel Michelson Horowitz, Jamila White, and Tamika Spellman. Okay. Matthew, I see you. If you want to go ahead and present your testimony.
Good afternoon. Thank you for the opportunity to testify today. My name is Matt Gannon, and I am a Marshall Scholar studying solutions to end homelessness at the University of Manchester in England. I attended Gonzaga College High School right by the Capitol building, and I've worked closely with people experiencing homelessness in DC for several years now. especially through my work with Street Sense Media. And today I'm testifying as a public witness. In 2020, ahead of the callous eviction of unhoused residents of Franklin Park, I spoke to a 60-year-old man named George who had been experiencing homelessness in DC for 40 years. His hands shaking, he asked, "Where are we going to go? Where are we going to wind up? You kick us out of this park and you're going to disperse us to where? At least here there's a certain degree of safety." 6 days later, the city bulldozed the tents of unhoused individuals living in that community, and the $21 million park renovation for which they were displaced could have funded 1,200 housing vouchers. Yesterday, dozens of unhoused people living in the encampment in McPherson Square were cruelly evicted by the National Park Service at the urging of the DC government 2 months earlier than planned during hypothermia season. Despite research demonstrating that encampment clearings harm the long-term health of displaced inhabitants, DC and MPS have conducted over 530 sweeps since 2015. Officials often tout these evictions as a blunt means of coercing people experiencing homelessness to seek assistance at emergency shelters. These facilities are near capacity, and because of restrictive policies and poor conditions, are not always the best option for unhoused individuals. Furthermore, despite promises to connect residents to permanent accommodation, many are consistently left without housing after such sweeps. Moreover, the cost of encampment clearings is exorbitant. The more than $132,000 spent on iterative raisings of an encampment under Whitehurst Freeway in 2015 could have gone a long way in permanently housing its 40 residents. These inhumane, ineffective encampment evictions prolong homelessness. Unhoused people are more than 3 times likely to die prematurely than the general public. The stakes, therefore, are life itself. The government should house people, not push them out of parks and out of mind. I urge this body to cease these heartless and harmful encampment evictions.
Thank you. Jenna?
Good afternoon, council member. My name is Jenna Israel, and I'm a tenant in Ward 1. I'm also a DC community organizer at Jews United for Justice, a community of thousands of Jews and allies committed to advancing social, racial, and economic justice in DC. JUFJ is a member of the Way Home campaign as well. My testimony today will address the violence that the Deputy Mayor of Health and Human Services encourages and perpetrates in the form of encampment evictions. Yesterday, I joined our partners at the Way Home campaign to bear witness to the violence of the encampment eviction at McPherson Square. The Jewish people deeply understand the importance of bearing witness to atrocities against the most vulnerable. We understand the responsibility to remember, document, and most importantly, speak truth to power about the brutality so it never happens again. And yesterday was brutal, it was violent, and it was inhumane. 2 encampment residents who wanted to be able to remain in the place where they lived were arrested yesterday, forcing them into a carceral system that will only make it more difficult for them to access housing and other resources in the future. Even those who weren't arrested, as many witnesses have testified today, experienced real harm as they were torn away from resources like caseworkers and mutual aid, and from the community they built in the encampment. And just like any other eviction, the displacement on its own is painful. Displacement is traumatizing, whether it's due to eviction, gentrification, or other reasons. Encampment evictions are particularly violent and dehumanizing. Yesterday, I watched encampment residents pick through their belongings and decide what to take with them, for many of them to an unknown destination, not to housing or shelter, and what to leave behind. Then I watched National Park Service workers shovel people's remaining belongings and their tents, their homes, into garbage trucks as if it was trash. It's heartbreaking to see people forced out of their homes and not even be treated as people in the process. While this particular eviction was carried out by the National Park Service, the district government bears the primary responsibility for this and many other encampment evictions. First, the mayoral administration's policies have failed to address our current housing crisis. The reason that so many of our neighbors are sleeping outside is because housing in DC is simply too expensive, and because affordable housing programs have not been implemented or funded appropriately. Thousands of housing vouchers remain unused. Thousands of public housing units are vacant and unlivable. The Housing Production Trust Fund is used to line the pockets of developers who fail to build the needed, deeply affordable housing that the HPTF was meant to create. Second, the mayor and deputy mayor choose over and over again to devote resources, time, and effort to violent and unnecessary encampment evictions, instead of using those resources, time, and effort to actually support their unhoused constituents. The DC government has a moral duty to meet the needs of DC residents, whether or not those residents are homeowners or campaign donors. Third, the council has failed our unhoused neighbors by neglecting to rein in the administration through oversight or through legislation. In December 2021, the majority of the council voted down legislation that would have taken a step toward ending the inhumanity of encampment evictions. Since then, many encampment residents have been evicted, and many unhoused people have died without the dignity of a roof over their heads. The council failed to bear witness to the atrocity, failed to speak truth to power, and time again has failed to use its own power to protect the lives and well-being of some of its most vulnerable constituents. JUFJ looks forward to the committee's plans to end encampment evictions in DC and to take actions that actually meet the health and safety needs of DC's unhoused residents. Let's build the DC we all want and deserve, a DC where we choose care over violence and support over criminalization. Thank you for the opportunity to testify.
Thank you, Jenna. Daniel?
Thank you. Chairperson Henderson and members of the committee. My name is Daniel Michelson Horowitz. I am a proud 15-year resident of DC, 8-year resident of Ward 1, and a member of the Jews United for Justice Housing Security Working Group. I'm appearing today to express deep concern with how the DMHHS has performed for DC residents, especially by clearing encampments in the district and declaring no camping zones. I am disappointed and angered that we are here just one day after the encampment at McPherson Square was cleared at the behest of the deputy mayor in the middle of hypothermia season, displacing and traumatizing dozens of residents. My Jewish values command me to speak out today. As the Torah teaches, sheltering the unhoused is a mandatory form of tzedakah or charity in order to ensure that all our neighbors live with dignity and safety. I believe these values are universal, actionable, and attainable, and I am deeply ashamed of how our city has treated its unhoused residents. Just a few weeks ago, I was out on a cold and wet night in January volunteering for the Point in Time Count, an annual survey of homeless individuals. I talked to 2 DC residents deep in the forest of Rock Creek Park who had been living under a bridge for 3 years. Their stories still resonate with me and motivate me to speak out. Clearing encampments before our neighbors are provided with housing solutions is dangerous and dehumanizing to those experiencing homelessness, contrary to public health and housing best practices, and does not address the root causes of homelessness in our city or prevent its increase. People experiencing homelessness are not statistics. They are our neighbors, friends, family, and colleagues, and they deserve to be treated as we ourselves would like to be treated. Anything less is a violation of our moral principles as a city, of my Jewish values, and of the best advice of experts and advocates in the fields of housing policy and public health. I ask the council to demand that the DMHHS stop all encampment clearings immediately and until all residents of encampments are connected with safe, permanent housing. Pushing residents out of encampments will not lead to an improvement in their lives unless a viable alternative with supportive services is in place to receive them. Instead, they will be pushed further into the shadows, deprived of their possessions and basic human dignity, and into living conditions that make them more vulnerable to COVID, other medical issues, violence or abuse, and even death on the streets. Furthermore, I ask DMHHS to stop the creation of any and all future no camping zones and repeal policies that criminalize homelessness or poverty. Such policies push people experiencing homelessness deeper into desperation, sow distrust between government agencies and the people they intend to serve, and turn neighbors against each other. Homelessness has its root in decades of systematic racism, neglect of affordable and public housing, and the rampant gentrification that has brought young, white, and affluent residents like myself to the district. We need to confront, not ignore the effect of these policies and our collective responsibility to end and remedy them. Just yesterday, 2 unhoused residents of McPherson Square were arrested, a shameful act that does nothing to solve their housing or other needs. There is an alternative path forward, and while it takes more resources in the short term, it will save resources in the long term, It will make our city more livable for its lowest income residents and make us prouder to call ourselves Washingtonians. Instead of clearing encampments, the DMHHS and the entire resources of the DC government should be leveraged to work to end homelessness for all who need housing, not just residents of specific encampments that local wealthy residents and businesses want to make disappear. Instead of punishing people for living in tents and bulldozing them and their possessions, we should ensure that all encampments are provided with portable toilets and sanitation stations, and reform the emergency shelter system to remove barriers that people living outside have identified as standing in the way of entering shelter. I'm struck that the deputy mayor took the initiative to request that the National Park Service move up its planned clearing of McPherson Square from the spring into the dead of winter, with just a few weeks for residents and social service providers to prepare. I cannot think of a better example of needless cruelty. I call on you to hold the deputy mayor accountable and prevent such an injustice from being repeated. Thank you for your time today. I welcome any questions.
Thank you. I don't see Jamila White. Okay, and I don't see Tamika as well. All right, if they come, we'll certainly add them on after the fact. Thank you to this panel for being here and for your testimony. Matthew, I especially want to give a shout out to you. You're in Manchester now?
Yes. Yeah.
Okay, so you are managing the time change as well to be here and provide some insight into things. So thank you so much for being here. Jenna and Daniel, thank you so much as well. I don't have any particular questions for you all, but I appreciate your testimony. If you haven't submitted your written testimony to the committee, please make sure we have that for the record. Awesome. All right, we're going to go to the next panel. Abigail Goldner Morris, Christian Carter, Kate Coventry, Eric Colchamaro. Eric, you're gonna have to tell me if I said that incorrectly. I probably did. And Dean Brenner. Okay. As a reminder, to be promoted as a panelist, you have to affirmatively accept our invitation. I see Abigail on my screen. So Abigail, why don't you go ahead and get started?
Thank you. My name is Abigail, and I am the Housing Services Coordinator at HIPS, a nonprofit that has been serving the residents of DC since 1993. I would like to speak today about false statements that Mr. Turnage made in writing to residents and volunteers at the McPherson Square encampment, and how those false statements directly impeded my and my colleagues' ability to serve the residents of McPherson Square prior to its untimely closure yesterday. In an email from February 1st, Mr. Turnage claimed, and I quote, "All residents at the site who are found to be eligible for housing will be placed in a hotel or bridge housing until they can be matched to an apartment." Let me be clear. This statement is false. I frequently make referrals to bridge housing. I can only complete those referrals for individuals who are matched to a housing resource, not for the dozens at McPherson and hundreds in DC who are eligible for, but not yet matched to a housing resource. I realize the difference between those who are eligible and those who are matched may seem small, but it is not. Trust is at the core of the work that my colleagues and I do, and Mr. Turnage promising all eligible residents would be offered bridge housing when he knows this to be false deeply damages the trust that my clients feel, not just towards the DC government, DHS, and DMHHS, but towards all social service providers, because we had to be the ones to tell them that they would not be receiving the services promised to them by Mr. Turnage. Because of this, I kindly requested that Mr. Turnage reach out to anyone who had been misinformed, especially residents at the park, and clarify that while DHS would try to expedite matches, which they did, only those who were matched would be offered bridge housing. Mr. Turnage's response to this request was to continue to lie and repeat his false claims, rudely dismissing me and telling me that I was confused. Let me be clear again, I am not confused. Mr. Turnage is lying repeatedly and insistently that he will provide housing resources that will not be offered, even after his own colleagues provided him with the correct information. I understand that housing in DC is extremely complex. There is nuance in the language that is used, and deciding at the last minute to close encampments only adds to that confusion, distrust, and chaos. I had hoped that Mr. Turnage, as a public servant, would be able to realize how his statements were misleading and would want to correct them. Instead, he doubled down on his lies, refused to admit he had misspoken, even after I implored him to correct his statements. His false statements and the unnecessary closing of McPherson led to residents into chaos, not knowing what their options were, not knowing who to trust, and not knowing where they would sleep or how they would connect with their social service providers and support networks. The residents at McPherson deserve better. They deserve a deputy mayor of Health and Human Services who, at the very least, will not lie to them. I had hoped to be able to come here today and spend my time as others have, presenting evidence that encampment clearings make providing homeless services more challenging, that they are not an effective way to end homelessness, and that they are an act of state-sanctioned violence against some of the most marginalized members of our communities. But instead, I have to come here and beg Mr. Turnage to stop making claims he knows to be false. It deeply damages our ability to provide services to a group of people who are about to be violently, and now have been, violently evicted from their homes with no choice but to hope they can find a new corner of this city to sleep in until Mr. Turnage, DMHHS, and DHS decide to actually address the housing crisis in DC. Encampment clearings are state-sanctioned violence. They do not end homelessness. And having Mr. Turnage repeatedly lie that he will offer housing services that will never come is a PR stunt to make his office look better at the expense of the physical safety of the residents of McPherson. His lies and refusals to make amends have made him a disgrace to the DC government and the title of public servant. I would be happy to answer any questions or provide any of the reference materials to this committee. Thank you.
Thank you. Christian Carter? Yeah, no, Christian. Kate?
Hi, Councilmember.
Hi, how are you?
Good, thanks. Chairperson Henderson, thanks for the opportunity to testify today. My name is Kate Coventry. I'm the Deputy Director of Legislative Strategy at the DC Fiscal Policy Institute. DCFPI is a nonprofit that shapes racially just tax, budget, and policy decisions by centering Black and Brown communities in our research and analysis, community partnerships, and advocacy efforts to advance an anti-racist, equitable future. DCFPI thanks Mayor Bowser and the council for fully funding the permanent supportive housing asks made by the Way Home campaign, the campaign to end chronic homelessness in the FY 2023 budget. Combined with funding in the FY 2022 budget, these investments will dramatically improve the lives of 2,800 individuals experiencing homelessness. However, the mayor's administration is undermining these improvements by continuing the policies of encampment eviction and creation of no camping zones. With these new resources, the district should focus on what works. Housing first, without timelines that are unreasonable and without threats of displacement. DCFPI is here today to ask the district to end encampment clearings and no camping zones and address shortcomings in the shelter system that lead to encampments. We are also asking the council to request a detailed budget on encampment clearings from DMHHS to improve transparency and adequate evaluation of clearings. Prior to 2015, the district did not clear encampments except in rare circumstances for health and safety. This was in keeping with national best practice and research. The U.S. Interagency Council on Homelessness argues that encampment clearings are not an appropriate solution or strategy, accomplishes nothing towards the goal of linking people to permanent housing opportunities, and can make it difficult to provide such lasting solutions for people who've been sleeping and living in encampments. USACH also maintains that clearing encampments can undermine the goal of moving individuals into housing, as it can interrupt relationships with outreach workers, create distrust, making it less likely that an individual will accept an offer of housing. The U.S. Department of Housing and Urban Development finds that continuous sweeps cause encampment residents to focus on meeting short-term needs, unsettling the stability needed to engage in planning needed to move into housing. Additionally, outreach workers reported to HUD that residents lose ID, legal documents, and medications. In a survey, health providers reported that insurance companies will often not replace this lost medication or will only do so after extensive advocacy. As a result, patients go without medication for extended periods of time, up to months for some. Healthcare providers also reported that it leads to the loss of critical mobility equipment, such as walkers. It makes it difficult to find patients for follow-up care. Encampment clearings may also result in long-term traumatic, psychological, and emotional harm for individuals who are not moved into housing. For all these reasons, the district should end all encampment clearings. If the district is not willing to do this outright, it should very least do it through the end of the public health emergency. The CDC recommends that if housing is not available, government should allow people to continue to live in encampments. Most do not receive housing and end up being displaced and moved to another encampment. And the U.S. Park Service acknowledged that some of the problems at McPherson were caused by the individuals moving there after the Scott Circle encampment was cleared and the area was fenced off. So the district should address shortcomings in the shelter system that lead to encampments. Encampments are no one's first choice for housing. As described in a HUD report on encampments, decisions about where to stay represent pragmatic choices about the best alternatives. Encampments form in response to the absence of other desirable options for shelter. While the district has made some strides in improving, much is left to do. There's several shortcomings identified to HUD, particularly that DC shelters lead to separation from partners, family members, or friends if people are not of the same gender. DC shelters do not allow pets, and DC shelters restrict the number of belongings to just 2 bags. Imagine only having 2 bags to store all the things that you need for your life. HUD also identified other shortcomings, including personal safety, safety of belongings, worry about exposures to germs and disease. So I'm here to ask the council to ask the Deputy Mayor of Health and Human Services to report on the encampment clearing budget. This has not been done since 2017. We request that this budget include both total costs per encampment clearing since 2020 and the number of individuals cleared at each encampment. Understanding the cost is critical to evaluating encampment clearings, especially as costs are generally high. One national study from HUD found a huge range in the cost of clearing encampments from $1,080 to $6,208 per person, not including the cost of housing for these individuals. In just one quarter in FY 2016, DMHHS spent $172,000 for one small encampment clearing. Absent transparency, council input, and a specific budget for this program, we are concerned that funding this could be expensive and in turn cause other budget shortfalls. Thank you for the opportunity to testify.
Thank you. Eric?
Hi, council member. And I just want to say, as someone who recently worked with an organization for folks experiencing homelessness, it's not part of my job description now, but me too, to the testimony that we've heard today and the importance of that work. I also want to take a moment before we get started to say thanks to your staff, council member. I've gotten to know Marcia a little bit, and Ashley. They've been really tremendous in helping to communicate the Alzheimer's Association's policy priorities. So thank you so much for, and thank you so much, and thank you to your team around you, who's just wonderful. Here today for the performance oversight hearing for the Deputy Mayor, of course, and will be followed by Dean Brenner, Alzheimer's Association advocate, board member, and just an important voice for those in our community. And here at the performance oversight hearing to talk about oversight. That's why we have this hearing. And I want to focus my testimony today specifically on legislation that was enacted called the Dementia Training for Direct Care Workers Act. Dementia itself is a collection of symptoms related to cognitive decline due to biological changes in the brain. Alzheimer's is the most common cause of dementia. In the district, 9,000 people over age 65 live with Alzheimer's, and many more are living with the disease undiagnosed. Care is challenging and costly. 95% of individuals with dementia have other chronic conditions, and the cost to Medicaid for their care is $122 million and growing. Direct care workers, like certified nursing assistants and home health aides and others who work at long-term care facilities, are necessary because over time, people with Alzheimer's lose the ability to speak, increasing the challenge for caregivers. Despite this, care workers can lack sufficient dementia-specific knowledge to provide effective support to people living with dementia. The district realized that, and this committee passed legislation called the Dementia Training for Direct Care Workers Support Act Amendment in 2020 to require dementia training for at least 8 hours for a staff member whose work includes extensive contact. That was also funded by the district. So we have passed a law The mayor has signed it into law. It has gone into congressional review and it has been funded. Yet the performance oversight that the deputy mayor, I think, is supposed to provide did not happen. The Alzheimer's Association communicated, I don't want to go into depths of email, but let's just say the Alzheimer's Association communicated with leadership at DC Health numerous times after the law was passed, after the funding was allocated, and the agency did not implement the law, did not issue regulations, did not move forward. So we'll come again this year. The agency has informed us they'd like us to ask for another $170,000 to implement this law again. But when we look to performance oversight, when we look to the role of the deputy mayor, it would be nice to not have to be here today talking about this bill. Want to close with this. I am grateful, and the Alzheimer's Association is grateful to the career civil servants at DC Health, the people who worked tireless hours during COVID across the organization. We are grateful for the director of dementia services, the dementia services coordinator at DC Health. We are grateful to the wonderful team there. But I would rather not be here today talking about the performance oversight of the deputy mayor. I would rather not be in a case where we have passed a law, we have enacted a law, it has gone through congressional review, we have communicated with the agency, and the process didn't work. So I thank you for your time. I thank the career staff during COVID who have done such marvelous things. But I ask for your help and your continued partnership in the oversight of the agency. Thank you.
Thank you, Eric. Dean Brenner.
Good afternoon, Chairwoman Henderson. My name is Dean Brenner and I live in Ward 3. I'm testifying today on behalf of the approximately 10,000 DC residents living with Alzheimer's and the over 14,000 family members struggling to take care of them. For reasons that scientists cannot explain, Alzheimer's disproportionately affects women, African Americans, and Hispanics, and the fiscal cost of Alzheimer's is astronomical, $126 million in DC Medicaid costs alone in 2020. In DC, in the past few years, we've begun to make significant progress with the DC government, working as partners in addressing the public health crisis that Alzheimer's is causing in DC. But there are 4 pieces of important unfinished business, which I urge this committee, the deputy mayor, DC Health, and DHCF to address quickly. First, all 50 states have an Alzheimer's plan, but DC's plan expired in 2019. Developing a new DC Alzheimer's plan is one of our dementia services coordinator's most significant statutory duties. The law passed in 2019 requires the dementia services coordinator to update the DC plan. There's been extensive community outreach to many stakeholders, including myself, to allow us to give input for a new DC Alzheimer's plan. But as we sit here today, DC Health has not released a new plan. So DC has gone without an Alzheimer's plan for 4 years now, as again, the cost of Alzheimer's continues to grow as Alzheimer's has become more and more prevalent in DC. So it's really time for DC Health to issue a new updated Alzheimer's plan. Second, as Eric Colchimero just testified, in 2020, the council passed the Dementia Training for Direct Care Workers Act, which is a national model to require dementia training for all direct care workers. But the 2020 law has not yet been implemented because the Health Regulation and Licensing Administration has not adopted the regulations that the law requires it to adopt. As Mr. Colchimero said, last year's budget included $170,000 for this purpose, but those funds weren't spent. It's essential that that funding be included in this year's budget and that HRLA quickly adopt the necessary regulations to carry out the law passed 3 years ago so that DC's direct care workforce receives the necessary training to provide quality care to all the DC residents living with Alzheimer's. Third, While DC Health has created a very good new website, brainhealth.dc.gov, showing all the available services and supports in DC for people living with Alzheimer's, there's been no public outreach to promote this new website. Almost no one knows about this new website. Last year, the council approved $250,000 for a culturally competent Alzheimer's public awareness initiative, which would have promoted the new website. Unfortunately, again, this initiative has not yet gotten underway. DC residents with Alzheimer's and their families need help, but they don't know where to find it. That was the situation that I found myself in when I was struggling to care for my mom who lived with Alzheimer's. A public awareness initiative for Alzheimer's in DC needs to begin as soon as possible. Finally, I'd like to talk a bit about the issue that you heard something about this morning, the shortage of direct care workers in DC because their pay is so grossly inadequate. This is a special issue affecting people in DC living with Alzheimer's because we know that the need for direct care workers, we need more and more home health care workers. It saves DC money if people can age in their home. Most people want to do that, but we need to pay these home health care workers a decent living wage so people are incentivized to go into that profession. Raising their pay to a minimum living wage of $24 per hour, providing that it will rise with inflation, is crucial to ensure a sufficient workforce to serve people all over DC with Alzheimer's. Finally, I'd like to thank the DC Health employees and all other DC government employees for their tireless work during the COVID public health emergency. Thank you, Chairperson Henderson, and I would welcome your questions.
Thank you, Mr. Brenner, and thank you to this panel of witnesses for your testimony. For Eric and Dean, we've met to talk a little bit about the various issues facing the Alzheimer's community and those who are caregivers of those. But more specifically, I can ask and will ask about the follow up on the dementia training in terms of what's happening there and what's not. And then, of course, we'll talk to DC Health at the beginning of March around their plans for a new plan. Double play on words there. Kate and Abigail, thank you so much for your testimony and for being here. I want to ask you both a similar question as I asked a couple of panels ago around, and I'm sure you will also, you probably will testify at both DHS or DCHA, but in terms of like where the logjam is, or in terms of your assessment, like what's going wrong here? We had historic investments in terms of vouchers, and yet we still aren't able to make the connections as quickly as possible.
I would have loved to be able to speak to this more in my testimony because I do have a lot of thoughts on it. I think one of the things that is the most disheartening about McPherson in particular is that the folks at that encampment, I've known some of them since they were evicted from the Hay Street Bridge encampment before the pandemic even started. I've known them from Burke and Gompers. I've known them from Thomas Circle, from NJNO, from L&M Street encampments, right? Like these are the same people and the same programs. Many of them were in the CARES pilot program. Many of them have vouchers that they have had in their name since March of 2022 that they cannot access because of delays at DHS. And it is that being added to encampment clearings, being added to this like absolute lies being told from the director or the deputy mayor of Health and Human Services that are just making people have no faith that when I say, yes, you have a voucher, yes, you've had it since March of 2022, no, you can't move into housing yet. Like, of course, they don't want to engage with that kind of thing. And yet they are, like, they are still coming back and trying to engage with services and they can't. And I think the big problem lays in, DHS not having people be able to use these vouchers that are sitting there, right? Like, and that goes back to what Jesse was talking about with, case management spots and underpaying outreach workers and case management and all of these things. But it goes from these like big, huge systemic things to like the very, small level of like people just don't trust what they're being told because it keeps changing because people are being told lies.
Yeah. Well, I mean, Kate, to sort of build off of that, is this the wrong model? The idea that in order for you to access your voucher, you need a case manager first? Because I think that like in good faith, when the system works efficiently, you want that to be a part of it, right? You don't want someone to just be in an apartment and not be connected to services.
So I found out yesterday at the McPherson Square clearing that some national organizations had offered their staff as like a temporary solution, right? So people would have a temporary case manager and then they would move to their permanent case manager. I don't know what the city responded to that, and it was the first I heard of it, but I think that's a great idea. I think the moments after someone moves into housing are really stressful if you've been on the street for a long time. So we really don't want to move people in without that support. The first few months are usually the hardest. I'll just flag one thing about money where we're in sort of this unknown space, because we're now billing Medicaid for services. And the idea is that will allow staff to be paid more, but we actually haven't, like the providers haven't gone through the process long enough to actually know how much money they're going to have, because Medicaid will only pay if you do the visit, and some clients refuse visits, right? Or there's a timing problem and, you know, they meet with you on the 1st of the month rather than the 31st of the month. So, you know, I have not suggested that. I usually don't suggest things here that I have not told the agencies myself, but I had an idea during this hearing when I was hearing you talk about wages that maybe part of it could be like, what if we gave providers just this year, like a boost to see, you know, to let them raise wages and then let the Medicaid implementation happen and then see if they need that boost moving forward.
Okay.
Because you're right that like, we're not going to compete with people for $50,000.
Yeah. Okay. Kate, can we follow up offline around that conversation that you had? I don't want to put who that organization is out on blast here.
Sure.
Yeah. Okay. So thank you to everyone for testifying. I've kept myself on a clock, so I want to be mindful of my own clock. So thank you again. If we don't have your written testimony, please make sure you provide it. And I appreciate you being here. We're going to go to our final panel of public witnesses. Can't believe we made it. Sort of. Not there yet. And then again, so I'm going to call up these folks and then I'll give some expectation setting. Now I have a Robert Warren on my list, but I believe Mr. Warren, you might have already testified. So I'm not sure if you are a duplicate. We didn't want to delete you because Robert Warren could be a very common name. So if you are a new Robert Warren, please accept our invitation. But if you are not a new Robert Warren, thank you for your testimony earlier today. Ariel Levinson Waldman, Shane Sullivan, and Umi Elmoso. Okay, while we are trying to get those situated, I just want to give some expectation setting. So after we finish this panel, we are going to take a 30-minute break and then we'll come back and have the government witnesses. We're doing that for a couple of reasons. One, we're still having tech issues in the hearing room, but two, to give Director Turnage and his staff an opportunity to come upstairs or over. I'm not entirely sure where they are, but basically to come here for the hearing. So we're going to give them a little bit of travel time so they can get set up for that. Okay, I don't see Robert Warren, so I'm going to assume that was the same Robert Warren from before. So Ariel, you are here, and so why don't you go ahead and present your testimony.
Thank you, Councilmember Henderson, and thank you for your leadership on this committee. We've not gotten to meet in person because of the pandemic, but I'm just grateful for all you are doing for DC residents and look forward to that endemic moment where we'll get to say hello. But meanwhile, nice to see you virtually, and thanks for holding this hearing. I'm going to change gears a little bit from a lot of the topic of today's discussion. I want to say two things. One, I've known Wayne Turnage for well over a decade, and we partnered closely when I was in the DC government. And on the issues that we've been working on over the last several years together, which relates to my second point, which is want to lift up the issue of medical debt. Director Turnage and his team have been outstanding. And so my message today is to lift up their outstanding work in this space, and also lift up the importance of medical debt and a great opportunity that the mayor and the council have to address the crisis of medical debt for DC residents in coming months. An estimated 90,000 residents have medical debt, and DC households of color, we're talking about 300% more likely than our white residents to have medical debt. Medical debt is impairing DC residents' credit reports, financial futures, and directly worsens health outcomes by causing folks with medical debt to often not seek care or to seek less medical care than their health warrants. Our Black and Brown residents, our disabled residents are particularly and disparately impacted by medical debt. The Urban Institute data shows us that compared to DC white residents, DC residents of color are 3 times more likely to have medical debt and collections. For those with the debt and collections, have nearly $100 more median debt and collections, and are 5 times more likely not to have any health insurance coverage, separate and apart from the many folks who do have coverage but are underinsured. A recent National Disabilities Institute study talks about how folks with disabilities are equally likely to have insurance, but more likely to have those past due medical bills and more likely to forego medical care because of costs. And these are community members that are at most risk of bad health outcomes when they're not able to get the necessary medical care. We'll put all this into the written record. The last thing I'll just highlight is that a very recent Kaiser News study went around the country and saw that 2/3 of the hospitals report patients who have an outstanding bill to the credit rating agencies. And so that's putting residents' credit scores at risk. And there we're talking about long-term financial future impact, getting rental housing or getting an apartment, certainly a mortgage, ability to buy a car, and 1 out of every 3 jobs in the district requires a background check with a credit report. In addition, that same study tells us that 1 in 5 hospitals self-identify as having denied regular non-emergency care to people on the basis of outstanding medical debt. There's a great opportunity as a government in using American Rescue Plan dollars to make an investment and become a market player. And instead of debt collecting against residents, as happens now, to purchase medical debt and forgive it and get it off the credit reports. And I want to commend Director Turnage and the mayor and his team for lifting this idea off of the academic journals, putting it into the conversation in a really exciting and meaningful way as we build out in the FY24 budget and policy directions. So I'll pause there and thank you again. I'm happy to answer any questions.
Thank you. Umi? If you're speaking, you're on mute. I can't, and we can't hear you. Still on mute. There you
Hello?
are. Yes.
Thank you. Good afternoon.
Good afternoon.
Yes, thank you. My name is Umi Elamosha, and I was one of many yesterday evicted from McPherson Park, and it was a very painful whole day process. I want you to know, Councilmember Henderson, that Wayne Turnage is a liar. On October 26, 2022, the National Park Service posted that they would close the park to us living there in April, and that they had contacted Mr. Turnage's office for intensive social services engagement. I want you to know, Ms. Henderson, it never happened. My community, on our own and with the assistance of multiple volunteers, Ward 2 Mutual Aid, Feed the People Mutual Aid, Remora House, Food Not Bomb, Stop the Sweeps, they would help us. to email Mr. Turnage, to email Jamal Weldon, to send tweets. He was not responsive. Finally, Jamal Weldon said on December 13th, he would have a housing fair where multiple agencies would come and there would be intensive social services engagement. There would be multiple people there to help us complete the SPDAT, sign up for health insurance, certify for the first time or recertify your EBT, get a lifeline telephone so you have a way to stay in contact with your caseworker, see healthcare if you have that need, whether it's mental or physical. The forecast on December 13th was snow, so Mr. Weldon canceled. He said he would come on the third week of January. He didn't come. There was never any social services engagement. And then we find out that all the while they're telling us, we're coming to help you, we're coming to help you. Mr. Turnage was secretly planning subterfuge and telling NPS, get those squatters out, they're incorrigible. And it's very frustrating because he's telling you all and telling the public that we are service resistant, we're all drug addicts, alcoholic, prostitutes, the park is unsafe, my staff cannot come there. Ms. Henderson, these are lies. Yes, there are problems in the park, just as there's problems in society. We don't throw away society, so why are you throwing away those of us who are unhoused? I repeatedly reached out to Mr. Turnage and Mr. Weldon for assistance, and it never came. Pathways is the contractor who was supposed to help us in the park. Pathways sent one caseworker for over 70 people, and Jen did try her best, but every time she would come, the queue would reach all the way down to the Veteran Administration building. She could only do so much on her phone to do the SPDAT, and it died. If you are saying that there's intensive social services engagement, you would have multiple people on the ground helping us, and that never happened. Even in the past 2 weeks, when all of this press came out about the park being closed early and multiple people came to the park, it still was not intensive social services engagement. I talked to the people who came. It was NBI, it was Canara, it was City Block. These are core service agencies. Once you already have health insurance, then you go to them and they'll provide you with counseling or therapy, a psychiatrist. Where was Wayne Turnage? Where was people from DBH? Where were people to help us complete the SPDAT? This park now, everyone there is displaced all over Washington, D.C., Ms. Henderson. We don't have phones. How do you stay connected to your caseworker to tell her where you are when you don't have a telephone to call her? When we were together in the park, those of us who had phones would let others use them. When Remora House, when Food Not Bombs, when Stop the Sweeps, when More to Mutual Aid, when the Howard University social work students came, they would let us use their phones to make these phone calls. Now that everyone is dispersed, it will be that much harder to keep in contact because you have to first figure out where your client is, figure out how to keep in contact with them. These are the things that is caused by the ineptitude of Wayne Turnage and HHS. And I have tweeted him and we have emailed him multiple times to tell him what is going on, where are you, why are you not here? His reply is of arrogance. And he just wants to keep you all saying that we're service resistant. And that is not true, Ms. Henderson. I want you to hold him accountable and ask him, why was he telling NPS, kick them out, but not sending people into the park to actually help us? You can do a FOIA request for our phone calls to him, for our emails to him, for our tweets to him. We tried over the months to get help. It was he who did not provide it. I am very upset about this narrative that everybody in the park is an alcoholic, a drug addict, a prostitute. I am none of those things, and I take personal offense to being labeled that way. Please hold him accountable. Why is he not doing the job that he's being paid very well to do with taxpayers' money? Instead, he's inflicting harm over and over and over again. The park was full of people who had been evicted from Thomas Circle, Logan Circle, Gompers, Mount Vernon, Union Station, K Street, L Street, M Street, New Jersey, and O. That's how the encampment grew to be so large. The last thing I want to say is that we had a meeting with NPS, and Mr. Reinhold himself said in November that, yes, the amount of people living there was large, but it's relatively peaceful. So I want you to know that what changed between November and December was Turnage. He closed Scott Circle where there had been lots of trouble. Those people from Scott Circle moved into moved into McPherson, and then things deteriorated quickly. Wayne Turnage knew who the perpetrators were, as did NPS. Instead of moving to corral them, arrest them, dismantle their tents, take them out, stop the drug dealing, he let it fester so he could use that as an excuse to shut it all down and displace all of us. That is violence, and it's so painful that he was working against us. And I'm so upset. And I really hope you will hold his feet to the fire to ask him, why is he telling you all I'm trying? Ms. Henderson, I'm telling you, he did not try. He has let me down. He has let down every person in that park. And it's going to be that much harder to get us housed because now we feel like they're just lying to us. They keep saying, I'm here to help you, but they never come. And then they just come and tell you, get out. You're worthless. You don't belong.
Thank you so much for your testimony. I didn't want to cut you off because I wanted to give you an opportunity to say your piece and to testify in terms of your full experience. We had a number of witnesses today, I think, who were testifying on behalf of other folks, and you are experiencing this firsthand. So I want to say thank you for being here and for your testimony and for some of the information that you provided.
Put this up now. How do I do that? Thank you so much, council member.
Thank you. I don't know if you have to, I don't see any of my colleagues here. So I've been holding on to see if somebody was going to join us for this hearing.
No, I can hang around. I tried to talk to you last week. I met Ashley. She was very kind, but you weren't available. So I'll try to come by again.
Okay, let's do that because I would like to talk to you more directly in terms of your experience and how we can do better. Because I feel like for us as a government, sometimes we create solutions that we think will work, but don't necessarily match the lived experience of how people are actually on the receiving end of these services and things. Ariel, thank you so much for being here and for your testimony. Medical debt, student loan debt, and like all of the debts. I think as you highlight in your testimony can certainly have an impact in terms of the ability for folks to, even as you mentioned, even getting a job, because that can be part of your background check report that shows with a prospective employer. But we've been joined by Councilmember Zachary Parker, who's a member of this committee and a Ward 5 council member. I'm going to stop my time and I'll give Councilmember Parker an opportunity to ask any questions if he does. And we're down to the final two folks, but I don't know if you wanted to say anything in particular at this time.
Thank you, Chairwoman Henderson. I caught most of the last testimony. What was the young lady's name that testified?
Umi Alamosha.
Umi. I just wanted to also echo my regrets, and I can't speak for the committee as a whole, but I can say for myself that I certainly take to heart your feedback and your experience and want to look into it. And regret that your experience was less than you deserved. And so just also wanted to extend my sympathies and regrets, and also wanted you to know that we will follow up on it. Thank you. Thank you. That's it for now, Chairwoman.
Okay. Thank you, Umi, and to Ariel, and to all of the public witnesses, not just who spoke about the Office of the Deputy Mayor for Health and Human Services, but who also presented testimony on the Department of Healthcare Finance. We're going to get into all of it in just a little bit here. So as I said earlier, we're going to take a 30-minute break to allow us to stand up, stretch, all those different things, because we've been here since 9:30. And then also for Director Turnage and his team to make their way over to the Wilson Building. So this hearing will resume at 3 o'clock. Thank you so much, and we will be back. All right, good afternoon. We are reassembled here. We are in room 412. We do still have some, Councilmember Parker is joining us via Zoom. And we are going to hear from the government witnesses today. So we have Deputy Mayor Wayne Turnage, who is the Deputy Mayor for the Health and Human Services Cluster, as well as the Director of the Department of Healthcare Finance. Before you begin, Director, it's a new rule for the council that everyone has to be sworn in. And so, but you might have more people than just yourself who is testifying. So I would ask this of everybody who may speak to raise their right hand. Yeah, now and forever. Yep. And so we can see this. Do you swear or affirm under the penalty of law that the testimony you're about to provide to the DC Council and this committee is the truth, the whole truth, and nothing but the truth? All right, great. Deputy Mayor, please begin. You have to turn on your mic.
Thank you, Madam Chairwoman. And at this time, I would like to turn your attention to the work of the Office of the Deputy Mayor for Health and Human Services. I am joined at the table by my Chief of Staff, Kiana Creighton, my Deputy Chief of Staff, Jamal Weldon, who's on the other end, and right next to me on my right, Brian Harrison, our Policy Director. In addition to these staff, I am supported by a wonderful ground crew whose expertise covers a vast range of human services issues, and some of those staff are behind me. I have submitted detailed testimony discussing the performance of the Deputy Mayor's Office, which covers the considerable work of our encampment response team, the work and next steps of age-friendly DC, and of course, the amazing work that we are conducting on the new hospital. But before submitting to the committee's questions, I would like to briefly comment on my office's role in managing encampments. As you heard this morning, much of the work in our office that draws public scrutiny relates to the efforts of my encampment team and the plight of persons who are trapped in the abyss of homelessness. Indeed, we sit for this hearing in the aftermath of yesterday's closure of the encampment at McPherson Square, which was initiated at my request and apparently invited national attention. I recognize, as well as anyone, that the descent into homelessness is without question a terrifying journey, unimaginable to most Americans. But on any given night in the district, it is a horrific reality for the estimated 325 residents that we have counted who live unhoused and unsheltered in the District of Columbia. With unyielding and pernicious consistency, the devastating phenomena of homelessness often erodes their physical health, self-esteem, and sometimes their mental stability. They are indeed caught in a vice-like grip. This is why my office works daily to ensure that these sites operate in a manner that protects the health and public safety of those who reside in the encampments. However, when the city can no longer be certain of the residents' safety, or when the encampments are operated in a way that violates the court-approved city administrator's protocol, we often must close the sites. When this is necessary, we make every effort to connect the impacted residents to housing services, as we did with the closure of McPherson Square. No human being should be forced to live on the streets of this city, and no human being should have to endure the conditions that I have witnessed personally in encampments that we have been forced to close, including those at McPherson Square. To do nothing in the face of those disturbing images would be an abdication by the city of its moral responsibility to govern for all of its residents, especially the most vulnerable of those among us. The argument that the proliferation of tenant encampments is somehow correlated with a thoughtless and morally compromised administration is an easy, intellectually lazy, and unconvincing smear. Moreover, the tacit suggestion that some advocates are morally superior to government officials because they fight to preserve the right of persons to live in large encampments, even those suffused with significant safety and health risks, is both curious and shockingly devoid of any logic with which I'm familiar. So at this time, Madam Chair, we are prepared to receive your questions about all of our work, and certainly the work that we do around the encampment process.
Thank you, Deputy Mayor. We're gonna do 15-minute rounds. Is that okay with you, Councilmember Parker? All right, and I also see Councilmember Pinto, who's here as well. Hopefully I do longer rounds in hopes that it can ensure for a more fulsome conversation, although they will get shorter as we go on here. I want to start in talking about some of the encampment work of your office. So first, a question that I asked to the city administrator earlier this week when I was at his hearing. When will the 1-year care pilot report be released? In your responses, you said that you submitted it to the mayor for review in late FY 2022, which was about 5 months ago. This is a crown jewel-ish of the work that you all have been doing. When do we get an update on whether or not it worked?
Well, I can tell you that it worked. And I can also tell you why there's been a delay in releasing it. And we have a slide that speaks to or tests to the fact that it did work that I'm more than willing to discuss. At the time that we completed the care project, and I don't know if you have the slides up. At the time that we completed the care project, it was roughly in the late spring, right around the early summer. And we worked with DHS to fashion some recommendations because we were very pleased with the outcomes. We worked with DHS to fashion some recommendations to replicate the success of the care project citywide for the balance of the encampments in the city. That, okay, how could we ensure that we could repeat the success of care citywide? And in doing that, we spoke to DHS because they said there's a reality that we didn't confront with care, and that is you have, as of today, over 1,400 people who are in shelter. Many of those folks some of them have been matched to vouchers. Many of them have been waiting many, many months for housing. So the question was, how do we move forward with care in an expedited fashion? And at the same time, respect the fact that you have many folks in shelter who have been waiting for this very opportunity. And you have to acknowledge, and we had to acknowledge in our discussions with DHS, that some of the people who benefited from care, may have been homeless in the district for only a short period of time compared to people who have been in shelters for months. So we had that issue to deal with, and we fashioned recommendations around doing both, giving both the residents in shelter and the residents in encampments equal treatment as we move forward. Then we had the acknowledgement and the concern expressed by DHS that because there were 800 people, at least 800, with vouchers who've been matched to vouchers, but who have not been able to be placed because of, among a number of reasons, probably principally the dearth of case managers, that there's a bubble in the system now. And so the recommendations that we put in the draft report for the mayor did not reflect that bubble. And so until we can figure out with DHS how we can address the 800 people who are sitting with vouchers but no housing, the wise thinking said it's best not to move forward with an expedited approach to just housing people who were living in encampments. And so that is why you don't see a report released, because the mayor is not likely to release a report that says all these great things about what we did with no recommendations. So we have to figure out how we address that fact and create some alignment with people who live in encampments and persons who are unhoused and living in shelters. Now, but in terms of the performance of the program, I don't think there's any question but for the fact that it was very successful. And the slide that's up on the screen gives you a summary of what we found after
these numbers are relevant as of what date?
The day we ended the care was a late spring, was it May? Sometime in May of last year.
No, I know, but I'm saying you say, so for instance, on the slide, it says there's one resident who's in bridge housing.
Yes.
Is that as of today?
No, this is at the time.
Point in time. Okay.
This is a point in time table. It shows that there were 139 people that we had on the by name list. I mean, people who were identified at these 4 encampments. that we try to reach out to and engage. 80% of them engage with us. One of the questions we addressed during the pilot, one of the specific written tests that we made of ourselves is, will we get high engagement for people who are living in encampment if we approach them with the opportunity to engage in housing? 80% did. Of those who engaged, 91% were placed in either a leased apartment or bridge housing. And so if you look at the total success rate, by looking at including those who didn't engage, the success rate was still 73%. We think that is very, very impressive.
So this has been, I mean, at this point, we're 6 months along. How are these individuals doing? Because that's how I view it, success. Success is not just having the apartment on that one day, but can you get through in terms of, you know, did you get the benefits that you needed? Are you able to survive and thrive in that home and not just have it be, you know, a roof over your head?
Yes, no, I would certainly agree. But I would also add that when you've been on the street for a while, the first step of getting you in a place that represents a decent home is a success.
Yes, I'm not saying that part, but if of those 100 people,
that's a very good question.
30 of them are now no longer in those apartments for whatever reason, we should know that.
Oh, absolutely. And we don't have precise data, but we can certainly get it. I've asked Jamal on a number of occasions how our placements were doing, and the results on an anecdotal basis is the majority of them are still very much in the units that they were placed.
So who's responsible for tracking those individuals?
Who does that? Is that care? Is that Pathways? That would be all. Speak to turn your mic.
Yes, Councilmember, that would be Pathways and Miriam's Kitchen. Those are the two outreach providers that were assisting us with this program.
Okay, is it possible that you could provide the committee and speaking with those teams? I think it would be nice to have an update in terms of that. So I'm going to go through, obviously we heard a lot today about McPherson Square. We're going to get there. But if I go to your website, there were several other cleanups and engagements that happened already in the month of February that I want to talk about, as well as the ones that happened in FY22. So in the chart that you provided in your pre-hearing responses to the committee for encampment closures on district properties for FY22 and 23 to date, it shows that 94 residents accepted engagement, and of those, only 84 residents were matched to a housing resource. What is the status of the 10 residents that accepted engagement but have not yet been paired with a housing resource?
That is also additional data that we can prepare and submit to the council as soon as possible. I will have to refer back to our outreach providers to get those updated numbers.
Okay. I mean, I have a similar question. You said of the 142 residents removed from encampments, were these unique individuals, or are we seeing some overlap because residents move from one encampment to the other?
We'll just provide some clarity for any of the district-related properties or district-governed properties where an encampment closure took place. This was not specific to the residents present, but to the health and safety concerns that were present at those particular sites or locations at that time. That's why that was addressed and executed accordingly.
Yes, let me clarify my question. When you talk about the number of residents who have been moved in the chart, in the data you all provided, I think you say 142. My question is, are those unique individuals, i.e. just me, just Ona, not me showing up at 3 sites in your count? Does that make sense?
These are the non-duplicate. Yeah, this is non-duplicate. These are residents that resided at those locations for a substantial number of months at that particular time.
Okay.
Yes.
Okay, so February 2nd, there was a full cleanup of 8th and Rhode Island. How many residents was that?
There was 1 resident at that location.
And was that person connected with a housing resource?
That person or that resident, unfortunately, has refused all service engagement. They still reside at their location, as that was a full cleanup and not a site closure.
Okay. 14th and U Street.
Yes.
How many people?
There was 1 resident present at that location.
And that was a full cleanup, not a closure. So
to provide clarity, that was actually scheduled for a full cleanup as well as a site closure. That particular encampment resided at the tail end of that wide median space, which is the
historical space within that particular part of the community. It impacted the traffic patterns, which is why we are prohibiting that resident from being able to encamp. There were a number of items that would fall into the street and would cause traffic issues and safety concerns. Currently, that resident has moved further up that block and was assisted by several community partners.
Okay, but are we conducting engagement in terms of services and matching to a housing resource?
That is correct. Community Connections, who provides outstanding outreach in that particular catchment area, continues to attempt outreach and service engagement for that resident.
Okay. How long does a SPDAT assessment take?
In order to complete with the resident?
Yes. I know that's not technical. I mean, it kind of is in your wheelhouse, but it's not. But I'm curious, like, if I am filling out that assessment form, how long is it going to take for DHS to say, yes, you have a housing resource match?
So I know that in terms of completing it, it depends upon the information that's provided by the resident. In terms of the time frame for understanding when a resident is approved for a match, that normally is communicated within 1 to 2 weeks after the SPDAT assessment is communicated, or excuse me, is completed.
Okay.
Mhm.
That's going to be relevant in a minute here. Okay. Logan Circle, site closure, how many people?
Logan Circle, there were only 2 residents that were still residing at Logan Circle.
Okay. And what happened with those individuals?
Those residents unfortunately continue to refuse services. They are still in the catchment area, so there's still active outreach engagement and attempts for those particular residents, but they no longer reside at Logan Circle.
So when someone refuses, do we ask why?
We ask what barriers are present, or
Right.
if there's any way that we can break through those barriers or offer any other pertinent services that may benefit them at that time. Sometimes that information is forthcoming, sometimes it is not.
Okay. 111 Massachusetts Ave.
111 Massachusetts Avenue, that was a full cleanup as well as intense rodent abatement, which will be something that will be ongoing at that particular location. Resides on the corner of New Jersey Avenue and Massachusetts Avenue. That was not a site closure at that particular time. The residents present, which there were about 7 to 9 residents that were present at that location, they continue to be engaging with us. There were some, I believe about 4, that were connected to housing resources, and the additional 5 are currently engaging and in process.
Okay. So let's talk about McPherson Square. Deputy Mayor, somebody asked me yesterday, when did you find out about the move up? And I had to say, when I read about it in the news, like everyone else, which was strange because you and I had had conversations prior to that happening, but this never came up. And even more so, I'm sure you heard some of the public witness testimony in terms of the last witness who testified, who was a resident there, who said, you know, there had been promises made in terms of engagement in November and December, and then all of a sudden, now it's closure. It's not talking about necessarily the outreach and assessment. What changed?
Okay.
And why didn't we communicate the reasons why?
It's a fair question. And I think if you listen to the chronology of events that occurred, it will be self-evident as to why things played out the way they did. When we ended the care pallet in late spring, early summer, around about that time, the National Park Service informed us that they were going to shut down all of their, all federal land, all their parks to future encampments. And they said McPherson would be closed in October.
Of 22.
Of 22.
Okay.
And we said at the time, slow down. Because we had knowledge after speaking with DHS of the bubble in the housing system, the housing placement process. We knew that the care pallet recommendations could not go forward until we figure out how to address that. So we said, can you give us some more time? Because we right now cannot accommodate the residents in McPherson. They said, fine, we'll give you to April. I think they came up with a mid-April date. Now, each week, I meet with my staff, the encampment team of Jamal, and we meet with the attorney and Kiana and myself on Mondays. and we discussed the report that Jamal just gave you and what's on the table as we move forward. Jamal began to report that the encampment at McPherson was beginning to grow. At the time that MPS made their initial announcement, I don't know if there were 20 people in there. Jamal began to report that his encampment is getting larger. And so as we got into the winter months, it grew even larger. At the same time, MPS have been getting complaints about, frankly, public safety issues and crime. So MPS used undercover agents to go in and be amongst the encampment, and they ended up arresting, 30-some people. I forgot over the time period, because they always use undercover operations when there's a concern about people going into the encampment and exploiting people who are homeless. So after December, I made several trips to the site, and it was large, and there was some disorder. And then there was a woman she had urine dumped over her head. And on one of our calls, we came to the conclusion that we couldn't manage the site, that we couldn't protect the residents in the site, nor could we protect the residents who were passing through. And so I asked in a phone call to NPS, could you expedite it? And this was early January. And I said, could you expedite it to February 1? They said, we'd have to look at our investigative data, and then we'll get back with you. They said they would get back with us in a week. It took about a week and a half. And they came back and said, this is mid-January, maybe a little bit after mid-January, that based on their investigative data and based on our concerns about size, they would agree to move the data, but not to February 1, but to February 15. And so I instructed Jamal and my team to begin the process of letting folks know that this site will close, and we need to do as much as we can to get as many services as possible to the residents who were living at the site. So it was not discussed prior to December or in November, not because of some nefarious plan to close the camp and not give anybody services, which I heard expressed this morning, which is just ludicrous. It wasn't because we weren't planning on closing the site initially. We were going to wait until April 15th, but it grew and the challenges grew. Not any dissimilar from what we had at Noma, what we had at New Jersey and O Street. It's just that this time the park, the responsibility for the park rested with MPS, not the city.
I guess so again, though, and I apologize to Councilmember Pinto and Councilmember Parker, I know I'm over my time, but the lack of communication here is the thing that is kind of still rubbing me, right? Like, yes, there is an abundance of trust deficits, perhaps between advocacy communities, the executive, the legislative, whatever. But when you all felt that it became unsustainable, why didn't you let anyone know?
Because we don't run the park. We can't come out and say to the public, this park is unsustainable. We're gonna get it closed. We don't have that authority. So we had to wait until we communicated the request to NPS, and then they responded back to us as to what their decision would be. And as soon as they told us, I think as soon as I got the letter, I emailed it out to council members and to some staff, and I said, let's make sure that they get the notices up this day so the residents will know. So there was no daylight between when I was told that they would agree to our February 15th closure date, or the February 15th date that they set, not February 1, which is what I asked for. When they told us they would close it on February 15th, and I go back and look at my emails, I think I sent those things out right away.
Okay, I'm over my time. We'll have another round. Councilmember Parker.
Thank you. And it's good to see you again, Deputy Mayor. I'm gonna first start just with some general questions about the CARE pilot, and then I'm going to pick up on some questions about the McPherson Square encampment as well. Sure. So the CARE pilot, would you characterize it as a success?
Oh, absolutely. Almost unqualified, but I would say you have to qualify because we didn't engage with 100% and we didn't place 100%. That would be unqualified, but this was a success.
And going back and referencing the charts that you showed earlier, I forget the specific numbers that it showed. There is a residual amount of individuals that have not been put into housing for a variety of reasons. Outside of the care pilot, what supports are there for those individuals to get them into shelter or housing?
Yeah, and I'll let Jamal, who works on the ground, he and his team work on the ground with the outreach providers almost every day. So Jamal, can you explain to the council member what supports we give for people who reject our efforts to get them in housing? Will do. Thank you, Councilmember Parker. So in regards to how services are distributed to encamped residents of the district, the city is broken down into 3 outreach catchment areas. We have 3 contracted providers, Miriam's Kitchen, Pathways to Housing DC, and Community Connections, which provide the bulk of the hands-on outreach engagement, resource connection, and any other service engagement as needed or pertinent to that resident. For any resident who refuses any form of services, the no doesn't stop the attempts. There are continued weekly and at most times daily outreach engagements to the various encampment-related or encampment sites of the district to make attempts to, again, turn that no into a yes, to see if there are any ways to break through some of the barriers for those particular residents and how we can connect them accordingly to the services that they need.
Thank you for that. 2 other quick questions here. So after an encampment is cleared, how are you then tracking down where individuals are? Because the main criticism that we're hearing is you clear this encampment, they are relocating elsewhere, individuals are scattered across the city. So after an individual has rejected services, after an encampment has been cleared, what is the process to track that individual down to continue to get them into housing?
So there's a 4-team outreach engagement monitoring, 3 of which are from the 3 providers that I listed earlier. The 4th would be from the DMHHS encampment response team, which also conducts daily outreach and engagement. Because our engagement is one that is very intensive, we're able to know names of residents, identify certain barriers, and we're able to identify, since the encampment response team under DMHHS monitors the entire city, if a resident has crossed encampment or catchment areas, they will be able to identify, communicate with the outreach provider for the new catchment area, let them know that we have a resident that formerly resided at one location is now at this location, and how can we support them in their outreach engagement. If it's within the same catchment area, that same process would be enacted as well.
And do you track that data so that we can see the movement of individuals from one encampment to another, specifically after an encampment closes?
So that data is tracked. We do have a district-wide encampment data report that is constructed every month. For example, the February report would outline all of the various sites identified throughout the district from the January data collected. Now, the DMHHS encampment response team, we track the data based on the sites, not the specifics of the resident. That data is tracked by the outreach providers themselves.
Okay, I would be interested in seeing that if possible. And on my end, my camera is doing some weird things. I'm not sure if that's how it's showing up for you all. But one other question with the care pilot. So given that it's a success by your determination and we still have a significant need, what is the need as we're approaching this budget process to get more residents into housing? Put more simply, what extra finances, capacity does the pilot need? Does various agencies need for us to expedite the process of housing folk?
You know, I would, anything that I offer would be somewhat speculative, because the experts with full knowledge of the system, even the CARE project, they reside at DHS under the brilliant direction of Laura Zeilinger. So I think rather than me sort of go public with what I think would resolve this problem, I think it is probably, I probably should exercise some discretion and ask that, that question be put to DHS, because they have their hands on all of the levers for our housing system and our housing services. And they know better than I and anybody on my team what is needed from a resource, whether it be more staff, whether it be additional dollars, what is needed to sort of move the persons who are stuck with a voucher but no placement, and also reignite the care palette in conjunction with a similar set of services for persons who are living in low barrier shelters.
Thank you for that, Deputy Mayor. This is an invitation, and so I will follow up with DHS about that. We annually talk about encampments. We talk about encampment clearings. What I'm not hearing enough of is what is the district's plan to get more residents into housing? I know that is oversimplifying it, and I know that may come at the expense of the hard work that folk like yourself and the agencies are doing, but we have to do more. And so again, that is an invitation to work hand in hand for us to just be very clear. What is the money capacity that is needed in order for us to get more people into housing? So I will follow up on that. I do want to turn to the McPherson Square incident in particular. So the timeline that you shared, essentially the closure was originally scheduled for October. It was postponed to April at your request, or various agencies' request. That closure was expedited to February 15th. And we just saw the clearing of that encampment. It is my understanding that there were various agencies, caseworkers, et cetera, on the ground working with individuals, trying to get them into care, bridge housing, and the like. Can you detail what that process looked like? So we know that the encampment was scheduled to be cleared on February 15th. What does the accelerated engagement process look like? If I'm looking at your timeline, where I think on average it took 58 days in order to get someone into housing, can you just walk me through what that process looks like for someone in the encampment in, let's say, the last month?
Sure. I will let Jamal get into the details, but I want to say up front that even before the date was moved to February 15th, there are staff who are on the ground visiting encampments across the city, including McPherson, and working, trying to connect people to housing services. Once the date of closure was announced, I'll let Jamal talk about the activity that immediately followed amongst all of the district's partners.
Yes, so I definitely want to start by thanking Pathways to Housing DC, their leadership, their management, their boots on the ground staff for their exemplary work with this particular encampment location. From the time that the notice was communicated, once we received it from National Park Services, they immediately sprung into action. There was literally engagement attempts made every day at that particular site. DMHHS assisted in supporting their efforts with various distribution of supplies, inclusive of partnering with the Department of Parks and Recs to be able to secure large bus or vehicles to allow, one, for safe engagement with the case managers and the residents. The residents will be able to come onto those buses and receive engagement services. I would also like to thank City Block, which was another partnering organization that provided some medical engagement and mental health engagement as well for residents at that particular park. The bus engagements took place on the 1st, 8th, and 13th of February. Those were the more intensive dates of engagement and service providing on those particular days. All other days, the residents were engaged by Pathways to Housing. There was daily case conferencing on residents who chose to engage, completed SPDAT assessments, and were able to be deemed eligible for housing matching or housing resources per their eligibility.
And let me just jump in right here, just ask a quick follow-up. And is that happening on the site?
Yes, that was happening on the site at the park.
Got it. And so for the individuals that refused, as you put it, refused services, I would imagine there were ongoing attempts to engage those residents until the encampment clearing, or was there something else that I'm missing there?
No, that is correct. And to add additional clarity, there is still outreach engagements being attempted with those residents as we're still working to track where the residents who refuse engagements, where they have transitioned to throughout the district. If there are other public spaces, hopefully they would have accepted shelter. But if not, we'll continue our outreach engagement to try to find out where they have landed and how best we can continue to break through some of those barriers to engage them accordingly.
In terms of time, one of the subtexts from a lot of advocates is we shouldn't clear the encampment until people are in housing. And I agree with that in theory, although I'm not convinced that if we waited to April, we would have gotten X more people into housing. Can you give us a timeline of how, and I know this is a hypothetical, which might be unfair, but how long would it have taken to get all of the individuals there into housing?
That is a very difficult question to answer for a number of reasons. Are you asking is that if everything were lined up, there was no housing?
Let me ask it this way. At the date of the encampment clearing, how many people were housed and how many people still needed to be housed?
Why don't we answer this? But we have some very preliminary data from one of our from Pathways that addresses, I think will address your question. And I emphasize, and the reason I put in red that these numbers are preliminary, because we asked for this, because I figured this was going to be an issue. So I asked Jamal to get me the best data he had as of this morning. So this is their data, but they are continuing to work with the residents. As you can see, there were 74 total residents at McPherson Square. Of that 74, 54 accepted our outreach efforts. That means, and then about 34 accepted outreach, but then later refused to continue to work with us. Of that 74 residents, we determined that 47 were eligible for housing.
Okay, let me pause right there just to make sure I'm tracking. So 47 out of the 74 are eligible. Why might the remainder of the individuals there not be eligible for the rapid rehousing program or the care pilot?
Well, for the most part, we don't know, because those were primarily consisted of people who would not work with us.
Got it. So outside of the 47, I'm to assume that is largely individuals that refuse to even engage with you.
Predominantly, yes.
Okay.
And so then you go down to, of those who were eligible for housing, how many were matched to a housing resource? Those 42 of the 47 were matched to a housing resource. If you go to the next bar, 45 of the 47 persons who were eligible for housing were offered bridge housing or short-term housing, which includes hotels, which is a direct contradiction to the Hipson counselor who spent a good bit of your time basically accusing me of prevaricating. She said that there were no hotels offered and that my statements were incorrect. I don't make those statements without talking to DHS. And I understand that her information that she had down the line might not have the benefit of the most recent data. But clearly, if you look at this data, 45 of the 47 people who were eligible for housing were offered either bridge housing or short-term housing, which incorporates the Pep V hotel. Some of the confusion was the DHS has made the decision to close the front door on Pep V hotels because we have to scale down those operations by the end of the fiscal year. But because this was an emergency, they graciously agreed to open the door for the persons at McPherson, for those who were willing to come and who were eligible for housing. So that was
right there. I'm saying
that resource was in the benefit package.
And so out of the 45 that were offered, 20 were actually placed in the bridge housing. And so what happened to the other 25 individuals?
And I'll let Jamal talk in some detail about that. But part of it, again, is some people just rejected the housing offer.
And yes, that is precisely the case. Again, those residents that have been matched to a housing resource, the engagement efforts did not and will not continue as of yesterday when the site was closed and cleared. We will still try to work with breaking through those barriers and seeing if we can turn those refusals into acceptance of services. So that is the difference between the 20 that were effectively placed into bridge housing and the number of those that were effectively matched.
So a follow-up there, and Chairwoman Henderson, I can't see my clock, so I don't know how I'm doing on time, but
you are over your time, but I'm gonna let you finish.
Okay, well, if I could just ask this last question, my apologies about that. So we're to understand that out of the 45 that were offered housing, 20 were actually placed and the other 25 are still in process of being placed. Is that accurate?
Approximate numbers, yes.
Okay, I have more questions, but that is my time. Thank you.
Thank you. Councilmember Pinto?
Thank you so much, Chair Henderson. And good afternoon, everybody. Thank you so much to all of the public witnesses for sharing your stories and your continued advocacy today. And thank you, Deputy Mayor Turnage, to you and your team for all of your efforts and kind of continual, it feels like daily response. As I think all of the encampments, and it's possible I'm wrong on this, but all of the encampments I've heard talk about today are all in Ward 2. And this is a particularly acute challenge in Ward 2 and something that we owe a better resolution for our unhoused constituents and our housed constituents. So I wasn't going to start here, but I want to start with McPherson, kind of continuing the conversation you were just having with my colleague. So in terms of what happened the last several months in coordination with the National Park Service, one of the things that you have said, Deputy Mayor, was that in anticipation of these closures, intensive outreach will be provided to these residents. What does that mean in practice? And how is that monitored? For McPherson in particular, I see the numbers and I see some of the people who've been connected to housing and services, but my team and I were out at McPherson at least 3 times a day for the last 96 hours. And we did not see outreach going on, particularly in the mornings and the evenings. And that was something that we continued to hear from residents who were there, was that was when they were back on site. So what does intensive outreach look like, and how are you thinking about the particularized needs of the residents at an encampment and their differing schedules in making sure that outreach is effective?
Well, it is the responsibility of the outreach provider to get a sense for what are the best times to be at the site to especially reach those persons who have not been at that point or up to that point willing to engage. So it is very possible that you could go to a site and not see but a handful or a small number of outreach workers, but that does not mean that they have not been there before, that they're not working. For those who are not there, that they're still not working on cases. It's tough to draw any inference from point in time visits to a site. I think that at the end of the day, you have to look at the data to determine if the outreach was sufficient. Now, we all would have liked to have seen 100% engagement, but the fact that 54 of the 74 people there accepted outreach and 47 were determined to be eligible for housing, I think speaks to the effort that outreach workers put forth, despite the fact that they are under a staffing crunch for the same reasons that DHS is on the case manager side. And Jamal, I'll let you respond in more detail.
If I could get some quick clarification, Councilmember Pinto, you stated the last 96 hours or the past few days that your team was on site?
Yes.
So what I will say is that there has been continuous daily outreach. I've been on site the last 3 days as well, providing various levels of supports from our camera response team with pathways to housing. Monday, started the final 48-hour countdown going into the site closure, there was actually an interagency site walk that included the National Park Services and other partners. DHS was present as well. But both the DHS outreach efforts and the Pathways to Housing outreach efforts have been ongoing and consistent. Those efforts primarily would take, I would say, between 9 a.m. to about 3 to 4 p.m., normally on average, before there is an evening switch of their staff, which provides nighttime outreach or evening outreach for the entirety of their cluster. So what I will say is that ongoing outreach was intensive. It was in place. It will continue, again, for that catchment area and across the city, again, from all three of our assigned outreach providers.
Okay, thank you. And in part due to the reality of the staffing shortages for the upcoming site closures per the National Park Service's schedule, what is the plan and schedule for what those intensive outreach services will look like at those sites?
Well, the continuous outreach engagement never stops. I want to be clear in restating that. It's not something that dies down at some point, especially with the list of those sites where MPS had communicated last year, they would be looking to conduct any form of effective closing or engagement. There has not been any updates provided for the specific dates of closure for those locations, the ones that would follow McPherson Square. But as soon as that information is received, it will be communicated to the outreach cluster, DHS inclusive, and additional outreach engagement plans or strategies will be employed appropriately.
Is this something that you have considered or would consider pulling in other resources from other agencies to help with some of that outreach given this shortage?
Hold on a minute. One of the questions, I would assume, Councilmember, that the point of that approach would be to rapidly increase the persons who are living in encampments who then have access to housing, correct?
Correct.
Well, this is the challenge, and you know, and people don't want to wrestle with this reality. We cannot ignore the 1,400 or so people who are in the shelters. If we give everybody priority for housing who are living in encampments, that is certainly, in theory, that is the desirable thing to do because they're exposed to the elements. What message are you sending to the people who are in shelter, who've been waiting for housing for years? Also, we have to accept the reality that because of our porous borders, there will be people who will come to these to the district and live in an encampment with the expectation that they're going to be housed because of the publicity around the fact that the district is housing people in encampments. So think about it. We know there are people who arrived from Philadelphia. One met with the mayor in a short period of time, and they're living in the encampment. And so if that person gets housing, which we all want to see everybody have housing, what do we tell the person who's been in a low barrier shelter waiting for 2 years, who's been a resident, maybe a long-term district resident? The answers to those questions are not easy. And frankly, I don't have the answers. So we can't just blindly put pressure on the Department of Human Services to immediately house everybody who's living in encampments without attention to the massive need for housing that exists among our shelter residents.
Thank you for that point. And I think it's an important reminder of the many different people who are experiencing homelessness and the different forms that takes, some of which is not, visible. I guess I'm specifically trying to understand, though, the language from DMHHS was, we will be providing intensive services in preparation for the site closure. And so what I'm hearing, is it accurate that what I'm hearing is you always are providing intensive services And then that's kind of on an ongoing basis at different times at all the sites.
And Jamal can clean this up, but you can provide intensive services. But the SPDAT score may indicate that the person that benefited from those intensive services has a lower priority for housing than you would otherwise expect. And so that may not result in immediate housing placement.
Right.
And also, if I can add, Councilmember Pinto, the additional and intense engagement also included daily case conferencings, which is not the standard process where we're able to expedite the evaluation of each resident who has completed a SPDAT, their various barriers, whatever they may be, and how that ties into their eligibility for a housing match. Those case conferencings took place daily, which allowed for those 20 placements, which allowed for the 40+ residents who were effectively able to be approved and matched as eligible for a housing resource. When you couple those with the daily outreach and engagement at that one particular site, when you couple those with the additional resources, some supported by Department of Parks and Recs, as well as some other community providers, those would encompass the intense outreach engagement for McPherson Square.
Mm-hmm. Okay, thank you for that. And speaking of our borders being porous, can you respond to those who say part of the care pilot is good, but it shouldn't be accompanied by a closure date?
Yeah, I think that's, obviously I have a very different perspective. Closure dates are a function of a decision by the city that the encampment that is about to be closed is at odds with public safety and public health. So since I've been in this job, the two largest closures that we have executed was at Nomar and in New Jersey and O Street. And I can tell you that if there was not a closure at the end of the process, we probably would not have secured the high level of engagement that we got from the residents. If there's, but again, that's not we don't announce a closure to increase engagement. That is a positive byproduct of it. We announced the closure because the city cannot safely operate or allow those sites to safely operate. In Nomar, I watched a woman get stabbed to death on camera. I watched people walk up, step over her like she was a dog. She died right on camera as I was watching it. It's the most horrific thing that I've ever seen. And I saw somebody come up on a bicycle and check her body to see if she had anything valuable on her. She was bleeding to death. Meanwhile, the entire block was blocked. You couldn't get by without stepping into traffic. The city cannot let a site like that exist. It can't. And so at the risk of being called cold and heartless and cold, heartless bureaucrats, we have to close that site. New Jersey and O Street was a park that it was a site that was going to be redesigned as a park, but there were massive problems in that site. I don't know how many deaths, several deaths.
Yeah.
It's caught on fire, and the public health hazards were enormous. So you just can't let, if the city does not respond, we will have effectively abdicated, as I've stated earlier, our responsibility to govern the city. And you can't do that.
Thank you. And in terms of moving forward, we know what the National Park Service's position is this year, that they will not be permitting camping on federal land. What is the district's position on camping on district land?
Well, the mayor's position is that nobody should have to live outside. At the same time, she's not going to criminalize homelessness. So we're not going to just randomly go through the city, or non-randomly for that mean, and start writing meaningless tickets or arresting people who are living on public land. Nobody's going to do that. What we hope is we can get the resources to a point where we can make it a reality for everybody who is living on outside. Make it a reality that they have another place to go. So what does that mean? That means we got to figure out how to get rid of this 800-person housing bubble. We have to look at public housing, which has about 25% of its housing stock completely offline because it's in disrepair. Another 25% that nobody wants to live in. We have to figure out how we can help folks who are in shelters who won't be incented to come onto the street just to get housing because they've been waiting for a long time. It means all of those things. It is a very complex problem. I don't have the answers. I work with some very smart people who know more about, who have forgotten more about the homeless problem than I've ever known. And they struggle with these issues every day. So I'm not going to sit here and suggest that there's an easy answer. But I can tell you that the mayor has consistently said people should not have to live on the streets in the District of Columbia. And I agree with her, but she's also said she's not going to criminalize homelessness by locking people up who refuse to leave public property. We try to give people options that would make their consistent decision to live in outside something that becomes unpalatable to them.
Okay, well, thank you very much. And next round, we can talk more about the plan moving forward. Appreciate that, Deputy Mayor. Thank you to you and your team. Thank you, Chair Henderson.
Thank you, Deputy Mayor. I'm going to do my very best to get all of my DMHHS questions out in this last round.
No more encampments?
No, I am not saying that, but you also oversee a $3 billion agency that I'd like to get some questions on what's going on there. So on this though, what happens to those who are currently in bridge housing when PEP V expires, when the federal government is no longer reimbursing us?
DHS is working mightily because they're eligible for PSH. Yeah, no, I screwed up the acronym. So the goal is that that we constantly work between now and the end of the fiscal year to move as many of those folks who are in a resource that is about to expire into a more permanent resource. Now, I don't want to talk at length about that because I'm not involved in the on-the-ground planning. That is a DHS question.
Yes, but you, as a deputy mayor of the cluster, I would hope that you are engaged in sort of these ongoing conversations about the variety of transitions that we have coming up in the summer, that my fear is all of it is going to sort of come to a head at the same time.
So that's a real possibility. And I don't want to publicly get out in front of what DHS, I have knowledge of some of the things they're thinking about, but these are just things that they're planning.
Okay.
And I don't want to publicly get out in front of them. Certainly things change.
That's fair. But one of the biggest things that everyone has talked about is about the workforce challenge.
Yes.
And so are we having some interagency conversation about what we're doing? I spoke to some panelists earlier, sort of saying like it's in a little ways, it's sort of like whack-a-mole, right? Of it's staffing. Okay, no, we don't have enough licensed people. No, it's the exam is racist. No, it's the salary. It's the whatever. We need people. And so are we thinking creatively about what we're doing here to increase the number of case manager supervisors so that we can handle this backlog, right? Because they have a housing resource. Now, sure, it might be the casework piece, and I'm the lease up process from the description from the folks at DCHA and all of that stuff of what takes on that front. Like that's also, it's lengthy process they have to work through too. I guess the concern is that for the public, no one is seeing sort of an active community conversation about how we solve this very real challenge of we have solved the money problem. Why still can't we solve the housing problem?
Well, the staffing issue is of somewhat recent vintage, but discussions are underway to examine whether or not the qualifications that are imposed upon people who want to be case managers or social workers should be changed.
Okay.
And so those things are being actively considered. So I don't want to suggest that nothing is going on, but those things are in the hands of the experts. And if I wanted to venture a guess, I would say you would probably see some changes in the requirements to work as a case manager, certainly as a case manager, and maybe as a social worker to provide some relief to the dearth of staff that are available right now.
Okay. I have some ideas on that, and I've sort of been kicking around with DC Health, and we can sort of continue to collaborate on some of those pieces there. As a follow-up, when you all sent information to the committee in terms of the outcomes of what happened for the housing piece of the CARE pilot and the housing piece of the other encampment clearings, can you disaggregate the data by housing resource type? So for example, how many of those people are in rapid rehousing versus in permanent supportive housing? Because I think that helps to sort of tell the story of what we're doing here.
We will do that.
Okay. You guys do some other stuff. Let's talk about the hospital. In your responses, you said that the hospital will be largely completed in late 2024, but then it'll have to go through federal, state, and regulatory processes before opening in early of 2025. Do you anticipate that those regulatory and state processes will delay the opening?
No, I do not anticipate that. I think if anything delays the hospital's opening, it will be something that's unforeseen at this point and would be related to any residual supply side issues that are attached to the pandemic, which I think have been significantly mitigated. I think even in China, where a lot of supply comes from, they've gone back to work. So I don't think there's anything in the regulatory process that would block a timely opening of the hospital.
Okay.
And we hope that nothing pops up on the supply side that makes some resources that we need or some materials that we need, or suddenly creates a staffing shortage that delays the project. We have ways to speed up the project under the current resources, but hopefully we won't have to.
Okay. United Health Services in the district has decided to add an additional floor to the hospital so that it can provide 184 beds.
Yep.
Instead of the 136 that was planned. Do we feel like that will be a sufficient number to meet the need?
I do, but I'm not a hospital expert. I know a lot about them, but I don't fashion myself as an expert. What I've known about hospitals for years has been that there's been a drift towards outpatient care. And so I think the decision to add beds may have been UHS's, some of their concern about whether or not the initial projection for inpatient beds was sufficient.
Okay.
But I think, it will be sometime before they grow into a 184 bed facility. And I think we'll be in pretty good shape.
Okay. In the pre-hearing responses, we had asked for a detailed budget. Your response wasn't exactly detailed.
What did my response say? What do you?
It was a partial chart.
Oh.
I just said like construction.
Oh, I'll address that. I didn't see that in its haste. I'll get you a detail. But
Okay. Because the costs have risen. I understand why the cost would rise in terms of materials, inflation, et cetera. But we just want to keep track in terms of what we're doing in terms of the contracts. And I believe that would be DGS, excuse me. But we like to just get the information from you all as well.
Okay.
Okay. The Ward 8 Urgent Care Center opened in October of 22. And it's great. So far, they've served over 2,200 patients. But the Ward 7 Urgent Care has been delayed because they have struggled to find a location.
Yes.
What's going on here? And to what extent is the district helping them locate?
Ben Stutz is our, he works, it's kind of a weird arrangement. He's a hospital guy for the deputy mayor's office, but he's also the chief. Yes, he's here. He's also the chief operating officer for DHCF. I have asked that he sort of provide oversight to the entire development of this healthcare system, which includes the hospital and both urgent care centers. I know that they have been struggling on a site for Ward 7, but they've made some progress, and I'll let Ben tell you a little bit more about where they are.
Sure. Good afternoon, council member and chairman. Regarding the Ward 7 urgent care facility, UHS is engaging with ourselves and with DEMPED and with a few private developers on potential locations in Ward 7. We are hopeful that in the coming months, there can be a letter of intent between UHS and a private developer for a facility in Ward 7. It is important just to note that these two facilities in Ward 8 and Ward 7 were in the approved council development agreement, the responsibility of Universal Health Services from a funding standpoint. But the district certainly is doing everything we can to assist them in the process.
Okay, so now we should anticipate 2024?
Yeah, I think right now we are looking at late 24 for the opening of an urgent care or ambulatory facility in Ward 7. And we'll certainly keep you updated if there's any change in that timeline.
Okay, thank you. Thank you, Ben. Deputy Mayor, I want to talk to you a little bit about opioids in terms of what your office is doing to elevate Department of Behavioral Health, the DC Opioid Working Group, the information that we're getting from the Office of the Chief Medical Examiner around addressing the opioid crisis that we have here in the district. I went to the hearing for the Office of the Chief Medical Examiner, and I think you know this, right? While in other places in the country, they're dealing with a younger, wider population in terms of overdoses, and in the district, we are dealing with an older, mainly Black male population who is struggling here. You want to speak to sort of some of the work that you all are doing to coordinate and elevate this work?
Well, obviously, DBH is on the front line, and Kiana has, she works closely with Dr. Bazran on process issues, and certainly offers whatever assistance we can provide. And I'll let Kiana give you just a brief overview of where things are in that relationship.
Thank you, Deputy Mayor. Good afternoon, Council Member. One of the things that we do in our office is making sure that we're also liaisoning with the Office of the City Administrator. And I will say that the points that you just highlighted are ones that we're keenly aware of. I think particularly focusing on the data from 2020, where we saw over 400 fatalities and mostly among older Black men. And so our policy team participates in the Live Long DC meetings that we have with DBH. I will say that the other thing that we have been discussing with DBH is how can we better look at what practices are emerging in the research and figure out the gaps from the Live Long DC report to what we're actually doing, recognizing that even though we have seen significant investments, we're still seeing unfortunate numbers with fatalities.
We have the hearing already for DBH, and I think we just need to lean into this, whether it be from a public information standpoint. And some of this we're sort of breaking through, right? They got the MOA out for charter schools to now have access to Naxalone, and we're getting it out in terms of community centers, et cetera, doing the trainings and those pieces. But also, just sort of in general knowledge around how it's even changing in terms of what we're seeing in surrounding jurisdictions around fentanyl and those things as well. This issue isn't going away, even though no one in the press is really talking about it in the way that they once were. And so I feel like it's incumbent upon us in the district to lean in terms of what it takes to resolve that issue. Moving over a little bit, in your responses, you reported that DMHHS worked with CFSA to exit the LaShawn A versus Bowser lawsuit, resulting in federal courts no longer having oversight over CFSA. Can you provide a little bit more background on the implications of what this means for district children and families? I think you listed this as one of your accomplishments for the past fiscal year.
It's a huge issue, and it's a huge win for the district, not because we are per se just out from under the ruling of the oversight of the court monitor, but for what it says about the district's efforts to provide for the welfare of children. So basically, this gives the director of CFSA the flexibility he needs to continue to move the agency forward. He has this this grand plan to transform CFSA from a child welfare agency to a child and family well-being system. He can do that now without the oversight, which can be sometimes pressing, of a court monitor. And the reason he can avoid that pressing oversight is because they met the goals that the court monitor and the court applied to the agency. So it's more than symbolic in that it reflects the tremendous progress CFSA made under Brenda O'Donnell first, and now the current director, Mr. Matthews, and it speaks to the seriousness which she took and which he now takes the role as a director of CFSA.
Thank you. Interagency Council on Homelessness. When will the 2023 point in time data be released?
It generally is released in around April. Yeah, but we'll find out. We'll double check. I think it generally released around April.
Okay. There was a public witness who spoke earlier around the ICH internal audit and that DMHHS didn't participate.
Yeah, and if I stand convicted, I did not participate in the audit, and I need to learn more about it. Just was not something that was on my radar at the time.
Okay. I don't have enough time to really get off another question here, and I'm trying to lead by example. So, Councilmember Parker, another round for you.
Thank you. I'm going to come back to McPherson and then move on. Let me start here. For the number of permanent supportive housing vouchers that we have, how many, it's my understanding that there is a backlog. What role, if any, do you play, Deputy Mayor, in assisting us clear that backlog? And I'm going somewhere with this.
Yeah, okay. The role of my office in actually having hands-on work to clear a backlog is very, very minimal. We are sort of an oversight liaison entity for the agencies in this cluster. And for something as significant and important and programmatically narrow as a task to clear a backlog, that will rest entirely within the purview of the director of DHS and her staff. Now, if in the process of determining that clearing the backlog will require something that she does not have, then that's when she reaches out to me in my role as the deputy mayor to see if whatever she's asking for, whatever she might need, to see if I would support it in a communication to the city administrator and subsequently the mayor. But other than that, I constantly check with her because, I want the backlog to go away as much as anybody because I really want to see the CARE program reignited. But they are doing the heavy lifting on dealing with the backlog, identifying the reasons, and then trying to address those reasons.
Yeah, while I appreciate a division of responsibilities, I do think, again, here's another invitation for us to work together because it's not just on you, it's on all of us. We need to figure out a plan and have a plan to clear the backlog. And so, I mean that sincerely. I will follow up anything that this committee or I can do to assist there. I think we need to just have a greater level of urgency just for what we're seeing on the ground. Connected to that, how many of the vouchers do you know that there's money spent that is not being implemented or utilized right now?
Let me see. I'm trying to understand the question. So when a person is matched to a voucher, that means they have the authority. DHS has the authority to engage if it's a market rate apartment, a landlord to basically lease that individual up and pay for that lease. So I'm not sure if a voucher has not been converted to a leased apartment, I'm not sure any resources are spent until that.
I mean, put separately, we have the money for X number of vouchers that have not been connected to individuals to put them into housing. Is there a number there?
We can get that number. I don't want to, I've seen the number before, but I don't want to
If
recklessly
you
throw
could
one out.
please follow up with that number, because I believe that should be our North Star over this
Yeah.
next year.
Yeah.
If we say we have X number in February of 2023, by February 2024, our goal should be X. I think we just need to be more, and I don't mean that in a condescending way. I mean
No,
that genuinely, we need to just be a bit more urgent and deliberate
No,
about
I understand. I can tell you without citing a precise number that I've heard DHS and others say we have enough vouchers now to basically eliminate homelessness in the city.
And so that is the infuriating part, right? So
Right.
we know we have enough vouchers, and yet there are still people sleeping in encampments and on the streets and in shelters because we have not done our due diligence, whether that's at DHS, the council, you, Deputy Mayor, we haven't done what we're supposed to do to get people into housing.
Yeah, and because the problem is a bit more complex than
I do understand
than has been described. But that is it is a fair criticism that it does not look good when you have enough vouchers to eliminate homelessness. And you have a huge backup of people in shelters and, over 300 people on the street. Now, I will say this, if we were to clear the shelters and the encampments by putting people in combination of public housing, market rent apartments, and site-based housing, I don't think for a minute that that's going to end the problem of homelessness. You will see others coming from Virginia and Maryland and other states coming to the city because the word would get out that the district has cleared its problem of homelessness among its shelter residents and among those who were living on the street. And folks will say, that's the place for me, and they will come.
I do hear that. And I would argue that would be a good problem to have. And so I've been trying to get as many commitments out of these oversight hearings as possible. Can we commit to working together and setting a goal that we will identify how many of those vouchers are available now, and we'll set a numerical goal for where we want to be a year from now?
Absolutely. But I would also suggest that there would be a meeting with you and the head of DHS so that she can fully explicate some of the reasons that we have a problem of more vouchers than placements. And it would probably add to your understanding of how complicated this problem is.
I know I'm oversimplifying it, but yes. So I will take that commitment. I will take you up on that invitation to follow up with the director again. But I think we need to be more deliberate.
Sure.
Let me get to just a few more questions, then I do want to move on. Where is the funding coming from for the vouchers?
Well, the PSH vouchers is largely federal dollars. They're largely federal dollars. There's a local voucher system. I think it's called EVR, I believe. That escapes me. I think that's funded with local dollars. But the vast majority of the money for vouchers comes from the federal government. But again, that's a DHS question that they are much more equipped to answer.
Okay. I will follow up there. And the last thing on McPherson, and I want to give you an opportunity to respond. I was troubled. I read the Washington City Paper article that suggested, Deputy Mayor, that there was an offer from national entities, organizations to come work on the ground to house people. And it was framed in a way to suggest that they were turned away.
Mm-hmm.
I want to give you an opportunity to respond. What was the rationale for not accepting the help of national or even local advocates, entities that were trying to house people?
That is correct. They were turned away, but the offer was not condition free. They said, we will meet with you. Can you end the early closure, and we will meet to discuss how we can move forward. I did not think it was in the city's best interest for me to unilaterally suggest to MPS that they move the closure date back to April, while we met with the advocates on national and local to figure out a different approach. The concern, again, was public health and safety. It was not a closure for closure's sake. So had they said, hey, look, we don't like what you're doing. We think it's wrong-headed, but we're going to set that aside and we're going to meet with you to show you how we believe you can move forward in the future. We would have taken that meeting in a minute. But they said very clearly, and I can send you the emails, please stop the closure and let's meet about how we can move forward. I just was not, I didn't even take that position to the mayor, to be honest. I just assumed that I was operating with the authority that that had been imbued me, and I just decided that, you know, we unless something changes about the health and safety risk, it would not make sense to stop the closure.
Okay, thank you for that. I'm gonna move on from this, but I just want to close by saying we, like a lot of other things, we keep coming back to this tug of war back and forth around encampments and how we deal with them. And the root cause of this is we are not getting people into housing as fast as we can. So I just want to come back to that commitment. I sincerely am looking forward to working with you, DHS, Chairwoman Henderson, and many others to just work to get as many people into housing as possible. So we don't have to get back to these types of questions. I want to switch gear, and you were talking about it a little bit with Chairwoman Henderson, our approach to opioids in the district. Can you speak to any budgetary requests that you may have recommended to the mayor in terms of ramping up programs that are proven successful currently?
Yeah, I don't have the budget in front of me, but every request that we've made with respect to opioids, I don't recall any of them being turned down. I don't have the previous budgets in front of me, but I will certainly go back and check. You know, the struggle with abating the opioid crisis has not been so much about the availability of providers. It's been about the stubborn nature of the problem, particularly during the pandemic, when people who were using went inside to use, and in many cases, if they overdosed, they were overdosing alone, and they died alone. That was one of the problems. The other problem, obviously, is the massive infusion of fentanyl in the supply of opioids that the user doesn't even know is there. And so we had a massive expansion of Narcan policy. I can't tell you the numbers, but I mean, there's Narcan all over the city, and people have been trained to use it because people OD and right in front of your building. And if you have Narcan on, you can go out and save them. So we've had a massive public relations campaign, a massive expansion of purchasing Narcan and distributing it community-wide, an extensive funding of other harm reduction programs. But again, this is a stubborn problem that has so far resisted our efforts to resolve it.
And where do you think, what I'm getting at those budget requests is, where do you think we need to go to build out our ecosystem to meet head on the issues that we're seeing that you're describing? Is it doing more of the same, or is it some approach that we haven't yet tried?
Well, I think we certainly have to keep the policies that are in place. Because what we never know, and sometimes we try to estimate it, is based on what we are currently doing, how many lives did we save? That's a tough measure to identify. But clearly, if we didn't have any Narcan widely distributed, clearly, if the harm reduction programs that we funded through DBH, clearly, if we had not done the public relations campaign, the deaths would be a lot higher than they are now. But we just haven't been able to, we can't quantify that. So I said, whatever the experts believe we should do, and I'm not an expert in drug treatment policy, but whatever the experts believe we should do should be done in combination with what we're already doing. And I think that's an excellent conversation for you to have with Dr. Bazbaran, because she's pretty locked in on this issue because of the immediate effect that we see when there's an overdose of opioids in the community.
One of the things that we heard from a number of public witnesses was a request for 24-hour treatment or harm reduction facilities. providing safe spaces to support neighbors that may be in crisis and or may be using a variety of drugs. What is your response and or receptiveness to that request?
You know, I am one who says when you have a problem that appears stubbornly persistent and it's deadly, you know, I would be open to any proposals that would increase the number of operations that could address or help address that problem. Now, I'm not the mayor, I'm not the CA, so I will have to take any proposal that I find favorable to them. And then they have to deal with the budget realities that frankly, as a cluster, as somebody who heads up a cluster, I don't really have to think about. So
no,
yes,
no, of course,
if somebody brought me those kind of proposals, I would take a hard look at it and certainly run it through the experts at DBH and my folks in the deputy mayor's office, and would think more likely than not would advance a proposal to the city administrator.
I appreciate that. That is welcome news. And as many advocates pointed to the successful implementation in other jurisdictions, namely New York, that I believe they cited somewhere anywhere between 700 to 1,000 lives, which any life lost necessarily to drug use is one too many. So that is my time, Deputy Mayor, and I'm gonna turn it back over to you, Chairwoman Henderson.
Thank you, Councilmember Parker. I didn't lie and say that was my last on the, I'm gonna get to healthcare finance, don't worry. And it's gonna be a lead in, but you said something in
They
the.
managed you for flipping the meeting.
They know it's true. They know it. They know it's true. Okay, so here. The deputy mayors, who has DC Health, or no, DC Housing Authority in its cluster?
It's not us, it's
Well,
It's
they work
DEMPED.
closely with DEMPED, but I believe they also have slightly independent authority, but we can double check, but they're not in our cluster.
Okay, because so when I think of, or when I first came to DC and sort of understanding DC government, the role of the deputy mayors was supposed to be to provide some overreaching coordination on big initiatives and issues in terms of what's going on. Housing, homelessness is one of those big things that our city is facing right now, but for whatever reason, it's all intertwined, right? Behavioral health has to be at the table because we're talking about individuals, many of whom who are dealing with mental health issues who need services and support. We got challenges there in terms of providers, reimbursement rates, locations not being where folks need them, accessible, XYZ. We have DHS who's part of it. They do SNAP, they do the TANF, they do the housing, they do the shelters, they do all of those pieces, et cetera. But also we know that if we're gonna solve some of our affordable housing challenges, we have to have the housing authority at the table because they are managing some of the vouchers, they have the public housing with lots of spaces available. And I'm just trying to understand whose responsibility is to coordinate this. And I'm not trying to, if it's not you, tell me who, because right now I don't know.
right. And I think one of the things that I see on a regular, the directors of these agencies, they are working together to try to figure out, what is the best way to move forward with this jointly. When they have a problem, if there's a problem that somebody is not participating in that process, yeah, they will let the deputy mayors know, hey, your agency is not doing what we need to do to get this coordinated approach to solving this problem implemented. And then we get involved. But we basically trust the directors who tell us that they are looking at this from an interagency perspective. And they're trying to draw all of the necessary resources in to solve the problem.
I understand. And I understand that in many of management approaches, I hate micromanagers. I don't want that, right? Like
right.
We trust our directors to lead the agencies for which they have been confirmed and picked to do. However, when the problem is as big as it is, in the same manner that gun violence is a problem as big as it is, gun violence prevention is now in the CA's office. I'm not suggesting that perhaps this needs to be in the CA's office, but one of the overarching challenges I'm seeing is around communication to the public. You all could be having 15,000 meetings with each other during the day, but for us on this side, it looks like nobody's talking to each other. Because nobody is publicly with one voice speaking to the public and saying, okay, here are the challenges. This is this, this is this, this is this. To be honest, Deputy Mayor, the conversation that you had with Councilmember Parker about the prioritization, maybe it was Councilmember Pinto, in terms of 1,400 people in the shelter, what do we tell them? 800 people who have a voucher, what do we tell them? I think that was the first time I heard anyone from the Bowser administration publicly say out loud, if we continue to just prioritize one group, we are creating what appears to be an incentive for people to leave the shelter system, to never go into the shelter system because they believe they will never get housing. So I don't know if I didn't mean to give a monologue here, but I just feel like.
And get me in trouble in the process.
I'm not trying to get you in trouble. I'm just trying to be like there's so many different pieces here. This is a huge problem. And it is frankly embarrassing that we have the money and we can't seem to get out of our own way.
It's very, very complicated. And if it would, and look, I'm not making excuses, but the fact that we know it's not an easy solution, because if it were, then we wouldn't have this problem. This problem exists in every city, every large city. And in ways that are far worse than what you see in the district. I got about 500 emails, probably more than that, when it became publicly known that I asked that the closure date be moved up. And what struck me about, aside from the people who were just being vulgar, which I mostly dismissed, what struck me was they all had this notion that this problem, you all should have fixed this problem by now. So then I would ask them questions about, do you know how many resources or how much resources has been committed and how many affordable housing options have been made available to people in this city, just under this administration? This mayor has put $1 billion in the Housing Production Trust Fund. That's probably meant, and then if you look back, it's about 6,000 units. And as fast as the money goes in, it goes out. They are helping people stay in housing. And if that didn't exist, we wouldn't have enough shelters, and there would be encampments everywhere. You know, and then you look at the fact that last year, I think she put $200 million in the Housing Production Trust Fund, but generally it's $100 million annually. And then it's about $100 million on vouchers, and plus the work, the money that you all put in. So it's not like people aren't thinking about this and trying. It's just that we've hit some roadblocks, particularly in the Housing Authority on public housing, that make this a difficult challenge. And the other problem we have is, you know, they just opened a beautiful affordable housing apartment, and I went to the grand opening. It was beautiful, but you can't do that overnight.
I don't think anyone is suggesting that.
It is beautiful, and it was so comforting to recognize that this was being built entirely for people who need affordable housing, not for folks like me who will go in and try to get some cheap rent. This is for people who would probably be on the streets where they're not able to get this housing. But those things take time, so we got to figure out a combination of how do we get public housing stood up? How do we continue to progress in getting developers to build units like we saw yesterday or day before yesterday? How do we basically upgrade the shelters so that they're not routinely trashed, even when they don't deserve it, so that they are legitimately viewed as an emergency place for people to go who don't have housing? And then how do we better infuse people who need vouchers, who are eligible for vouchers, into the market rent apartment sector without creating the disruption that sometimes 3 or 4 residents will create and put a troubling mark on the entire brand. All those things they work on every day, and this is almost a perfect storm for homelessness, except the fact that it would be a lot worse if we hadn't done the things that have been done in the past.
Yeah. And I don't want to discount the fact of what Mayor Bowser and the administration has done a lot in terms of closing DC General, building the family shelters, redoing the individual, all of the various pieces. It just is, it feels like this problem that won't go away when in fact, though, in some cases, in many cases, the issues of homelessness is a policy failure. Not on you, not on us in particular, but just in the country, in the nation writ large, right? You sent, Jamal sent the update in terms of what was happening. We don't always send out press release and stuff, but we all have been in communication over the last few weeks in terms of leading up to the closure of McPherson Square. When you noted that 5 people were getting housing through Veteran Affairs, I was like, okay, here we go. All right, we know homeless folks in this city are veterans who probably have access to benefits, but for whatever reason, the federal government hasn't been able to get them the resources that they need. So it all pushes and pieces together. And this is me weaving in the two to sort of talk about elderly residents in our city and age-friendly DC. Because that is under the deputy mayor as well. How many staff work on the implementation of age-friendly DC?
I'm going to ask, first of all, to Gail come up and sit where Jamal is. She's our age-friendly DC coordinator. She works very closely with that project. And so I'll let Gail provide you with some of the information you need.
Okay. How you doing, Gail? Can you just introduce yourself for the record?
My name is Gail Cohn. I'm the age-friendly DC coordinator in the deputy mayor's office.
Okay. And how many do you have on your team helping on the implementation pieces of age-friendly DC?
So we have a team approach in the deputy mayor's office. So when I tell you that there's no one other than me working on age-friendly, that would be just wrong. The staff in the deputy mayor's office are always available to me for anything that needs to get done. So I do that. I use the staff that's available in the deputy mayor's office.
Okay.
They have other responsibilities, to be sure.
Yes.
But we're able to work together very effectively.
I'm glad that we have the age-friendly DC because in a similar vein that we were talking about, things come up in all different categories. I hear a lot from people about parking and transportation issues in terms of that. And right, how does us being an age-friendly city coincide with our other goals around transportation, bike lanes, and sustainability when we're putting in a permanent bike lane, but then we're further from the curb? And how does that work for residents and all of these different pieces? So I can appreciate some of the challenges, but I noticed in the FY22 responses that we didn't meet any of our key performance indicators related to the strategic plan that we have outlined. What are some of the challenges you all are running into in terms of the implementation of the strategic plan?
Strategic plan has definitely benefited from COVID. We have more participation in terms of people who are interested in attending virtual meetings. I think we're getting more involvement in our social participation, with the exception of the state of volunteerism, which we very much like to proceed with, but we have not been able to make that happen so far. But I would say that generally speaking, we're working with a lot of agencies. There are 26 agencies that are part of what goes on, and we are benefiting from what happens. You mentioned transportation issues, and I can't resist the temptation to head that direction, because that would be one of 3 things that I hear more about than anything else from residents. Transportation, and how can we make transportation even more effective?
What are the other 2 issues that you hear a lot about?
Housing and affordability with housing, and what will happen in terms of care coordination if something happens to me. Those are the 3.
Okay. Well, let's talk about care coordination. Deputy Mayor, well, let's see. None of my colleagues are here, so I'm gonna just keep going. I want to talk about the personal needs allowance, which we heard quite a bit of testimony from advocates around. So my understanding is that healthcare finance increased 1, that went from 70 to 100. per month. But for individuals who are living in assisted living facilities, we haven't raised that in several decades.
Okay.
Do we have a plan here?
Well, you mean a plan to raise it?
Yes, sir.
Well, I'm not saying we have a plan to raise it. I can tell you one of the assumptions made going in is that the services that assisted living facilities are supposed to provide are so inclusive that the things that people cite that they might need a personal living allowance increase for should be provided by the assisted living facility.
Certainly not a cell phone.
No, well, yeah, but no, cell phones will cost $100, $200.
Right.
Well.
But I might want to connect with my family
I understand.
and the world,
I understand.
Google, the internet,
Absolutely.
TikTok.
So we are, frankly, it was not on my radar until it came up as a question. It's not something that I get a lot of people come to my office asking about. I don't know, Keon, if you, do people come to see you about it?
No, but I will say somewhat connected in the Department of Disability Services. They're having similar conversations. I know their hearing was today, so we can include that in our update for follow-ups for you as well.
Yeah. And it's not, to be honest, it's not a huge, financial obligation to increase the personal needs allowance. So I think this is something when you get my team up from DHCF, they can give you some sense for, what the magnitude impact would be if they increased it by a certain amount.
We're happy to make that switch now.
Okay.
Because we're the only ones here. So
Okay.
thank you, DMHHS team. Don't go anywhere because they might come back.
Okay.
So how about this? Why don't we do this? Why don't we take, because we've been here for a minute, why don't we take a 5-minute break? We'll do a little switching and then we'll dive in deeper on some of these questions.
Okay.
All right, great. Okay, and we're back. And the table looks different. Hello. How about we start with this? Can everybody introduce themselves for the record? Who's sitting there now? Who's new to the table? We know you ain't.
Good evening. I'm Melissa Bird, Medicaid Director, Department of Healthcare Finance.
Hello, I'm Angelique Martin, Senior Deputy Director of Finance.
Newly minted senior.
Hello, I'm Darren Schaefer. I'm the Agency Fiscal Officer for the Department of Healthcare Finance.
Oh, the AFO, great to have some budget questions as well. Okay, so where we left off, we were talking about the personal needs allowance for assisted living facilities, and that while we increased one, we did not increase the one specifically for assisted living facilities. Is there a plan to do so?
What we have in place right now with the increase to the $100 P&A for the assisted living, for the nursing facilities, there is not a plan to directly raise it for the assisted living facilities at this time. However, with the overall P&A increase, one thing that's been built in is an annual COLA adjustment, of which the folks that do reside in assisted living residences will be able to take advantage of. But it's certainly something that we can look at the number of folks potentially impacted and see what the budget impact would be. Until just in the past year or two, we had very few beds that were affordable for Medicaid beneficiaries to reside in assisted living facilities. Medicaid does not pay the room and board. That has to come elsewhere. We can only pay for the service related cost. And so now we've had at least a couple hundred assisted living residence beds come online that are geared towards individuals with lower incomes are made to be affordable. So this is where we're seeing this issue kind of pop up now, if you will, and had not seen it before. It was not something that was anticipated, but certainly we appreciate from today's testimony from public witnesses, it's something for us to look at.
Okay, so I guess I wasn't necessarily aware that Medicaid doesn't cover the room and board costs. They only cover services, which I think goes to a little bit of some of the testimony from way back this morning from the Hospital Association around the challenges that they are having with discharging some patients who no longer need the acute care of the hospital setting, but can't go home in terms of doing that level of care safely. So what are the options that are on the table around this?
Sure. I would say just a general tenet of Medicaid is that we don't pay room and board, or we're precluded from paying room and board. And that's not unique to the district. That
Regardless of age. So if we're talking older, younger, so what about rehabilitation facilities? Does that count?
When you're in a nursing facility, that's different because you're there for the medical services.
Okay.
But so there are some real fine lines on room and board. What is, I would say, kind of new and an exciting kind of change in course, if you will, or openness from the federal government is a recent waiver approval for the state of Colorado, I believe it is, that is allowing up to 6 months of some kind of rental assistance for individuals coming out of institutions that might not otherwise be able to be discharged from those institutions. So that's something that we're looking at now. That's not something that will fix any of the issues you've heard earlier today within the next week, month, or few months. But it is something that we are seriously considering as we begin the discussions around the renewal of our 1115 Medicaid waiver. This is something that would be done through a Medicaid waiver, which just simply allows us to waive certain rules for Medicaid. So when we first heard about that, I can tell you that's something right away I directed my team that this is something that we need to look at. We know it's an issue our partners across the city have expressed and that we work on almost on a daily basis for those particularly complex cases where institutions cannot discharge as they are ready to do so.
Okay, is that something Deputy Mayor, well, Director, both hats, either hat, doesn't matter. But as we look to sort of build out affordable housing, it seems like this is I don't call it a niche area, it's not, but it's going to be a growing area of concern as our population is aging more, that for individuals who can't afford private assisted living facilities, that they will have no other place to go. Are you aware of any jurisdictions that cover assisted living housing via local dollars?
I am not aware of any localities. My team may well be because that there may be some that cover, but that can get pretty expensive pretty quickly for a local fund budget. Can get very expensive, particularly in large jurisdictions.
Well, yes, I imagine that it isn't, but it seems like this is going to be a missing piece of our housing continuum. And the result then are individuals who have been at Washington Hospital Center for over 300 days with no need to be there at the hospital, but they have no other place for them to discharge to.
Yes, now, I am, a lot of the challenges around that problem, we're trying to take a look at to see what we can do to make someplace available, because nobody should stay in a hospital for 300 and some days. That's ridiculous. But you're right, it's a function of them not having anywhere to go. It creates a challenge in the hospital system in their throughput because, things slow down tremendously. But it's something we have to look at. I had not thought of a particular funding mechanism or service design or service benefit design that would incorporate it. Frankly, some of the folks that end up in that situation are in the Alliance program. And there's not a long-term care benefit in the Alliance program. So that makes it even more difficult.
Should there be?
In a real world, in an ideal world, yes. They should have access to the same benefits that we pay for people who are similarly situated residents of the city. But it's not something, Alliance has a long history. It started out as a very narrow program. And we've chipped away at, not chipped away, but we sort of added benefits to the program over the years because it started out again, something, I think it was just a hospital benefit when it first started. And we've made it look almost like Medicaid over time, but we've not added long-term care. That is a significant expense. Long-term care in the Medicaid program, you're talking about a small proportion of people, but they represent a huge, huge dollar amount.
Yeah.
And that's with the federal subsidy. Imagine trying to do that with all local money. It'd be a big number.
Yeah, I think this is an area where perhaps we could get a little bit creative. So for instance, in the same way that the district contracts with the Psychiatric Institute of Washington for a certain number of beds, perhaps that is the approach with one of the private long-term assisted living facilities in terms of like, okay, we DC government are going to pay for 7 beds, whatever it is. Yeah. So like, obviously there's a much more of a larger expense if we were to operate a facility on our own, but I think we just have to think a little bit more creatively.
That's a good point. I hadn't thought about that. Because we couldn't do it under the Medicaid program because they're not Medicaid eligible.
Right.
And we couldn't just provide if they were Medicaid eligible, but somehow needed a benefit that we didn't have, we can't just provide a benefit that for a small, for on a case-by-case basis for one person that's not normally covered by Medicaid. The Attorney General is not going to approve it. And so the option of contracting with facilities for people who are stuck in hospitals, particularly if they're on the Alliance programs, it's something worth considering.
Okay, let's talk about that a little bit more offline. I would love to sort of explore, maybe even not just for that population, but just in general, as we're thinking about an aging DC, we probably need to think more creatively. But let's stick on in terms of talking about some of our seniors. Healthcare Finance had planned to implement a 16-hour day cap on personal care aid services for elderly persons with disabilities under EDP. But in your responses, you report that you removed this cap in your 2022 renewal of the EPD waiver program. In your responses, you reported that in FY22, 3% of EPD waiver beneficiaries or 290 seniors are currently receiving 24-hour care. Another 463 are receiving 17 to 18 hours of care. Why did you change your mind on the cap?
The federal government required that we remove the cap, even though it had been previously approved by them. It was never enacted because of the public health emergency, and we stayed any reductions and the implementation of that cap, and through discussions through like the waiver renewal and amendments, they asked us to withdraw that.
Okay.
Be obliged.
Are you planning Now, the public health emergency is coming to an end. So are you planning to implement a cap in the future? Or are we moving that off the table as a
At this
policy?
time, we haven't had that further discussion with CMS, our federal regulators, because they told us we couldn't do it.
Okay. In public testimony, we heard from, we heard that home health agencies sometimes will not allow a beneficiary to work with more than one agency to create the 24-hour day care plan, even though this is against DC healthcare finance policy. Is that the case? And if so, how are you working with home health agencies to make sure that they know what the policies are and aren't refusing care?
I'm going to ask our long-term care director, Catherine Rogers, to come up. But generally speaking, we do have beneficiaries that may work with aides through different agencies. Ultimately, it's beneficiary choice, but Catherine can, one, correct me if I'm wrong, and two, expand on what we engage and direct the providers.
Okay, if you could just introduce yourself first. You're on.
Hi, my name is Catherine Rogers. I'm the director of the Long-Term Care Administration at DHCF. And I apologize for my voice. I'm fighting everything that is blooming outside. So mostly, so there's nothing in policy that precludes this arrangement. It's generally operational concerns that we can usually work with the agencies to mitigate, but it's things like providing communication touch points between the agencies. So one aide is leaving and an aide from a different agency is coming on shift. How do they share information? Our clinical case management system, that's the backbone of information sharing in the long-term care system, only allows us to assign one home health agency. And that sounds really, I don't know. Yeah, that's it. That sounds unchangeable, but it is, it's on purpose to allow for good care coordination when there is only one home health agency assigned, but it means that second agency, or even if there were more than two agencies involved, that they don't all have access to that person's clinical case record. And so that presents additional operational challenges. None of these are like unable to be overcome, but they sometimes we find that it makes the coordination of care a little bit more difficult. And on a 24-hour case, coordination of care is already complex.
Yeah.
And so those are usually the points of feedback we get. I think we also find sometimes healthcare providers don't want to sort of be held accountable for some other agency's performance. And so there's a fear that if they're sharing care for a complex patient, that there's a risk, they're engaging in some risk there.
Okay, don't go away.
Okay.
So I wanted to ask about, I don't know if I'm gonna say it right, Liberty's InterRay algorithm tool that is used to determine a person's need for PCA care. My understanding is that during the public health emergency, it had been reported that there were reductions in hours because the assessment was suspended. Have we restarted using that tool?
We did not suspend assessments during the public health emergency. We moved to a virtual posture very quickly in March of 2020.
Okay.
Because we didn't want external folks going into people's homes when that was unnerving for everybody. But until last November, we continued doing virtual assessments on a routine. Generally, for most people, it's on an annual basis and upon any changing condition.
What's the average level of time it's taking for an assessment?
I think the average is somewhere between 60 and 90 minutes. Very long ones take a couple of hours, but usually I wouldn't say less than about 40 minutes.
So once the assessment is done, do I get a determination right then? I guess I'm talking about like, you do the assessment and then you tell me how many hours? How long does that take?
Generally speaking, you don't just get like a handout at the time. So there is a process, including a QA process internal to the vendor, including supervisory review of a sample of assessments to make sure that the assessment team is able to follow completion and quality processes as outlined by DHCF and Liberty policy. But then a formal notice is mailed to beneficiaries subsequent to the assessment. And A lot of those notices were not mailed during the PHE because if a reduction or termination of benefits was indicated, we stayed those adverse actions during the public health emergency.
Oh, I see. Okay.
I would also offer up, just for your awareness, that the assessment is kind of has two purposes. It can tell you how many hours of PCA or other services you may need, but it also sets whether you meet the level of care required to either be admitted into a nursing facility or to be eligible for our elderly and persons with disabilities waiver too. So it's twofold and not just for PCA hours.
Okay. In the responses, in the pre-hearing responses, DHCF reports that there are 11 adult day health programs currently operating in the district, serving on average over 200 Medicaid beneficiaries a month. Are there any wait lists for folks who want to participate in these programs?
No.
Okay. And what type of services do they provide at these programs?
I think adult day health programs are an unsung hero of our long-term service and support system. So I'm so glad that you asked. This is another area that, like assisted living programs, we've actually seen an increase in our provider capacity during the public health emergency, which is really great because I think at the outset of the public health emergency, we were a little worried for our adult day health programs since they were serving people in groups, and that posed a unique risk in 2020. But our ADHP program has expanded during the public health emergency. These are generally community-based locations where individuals can access an array of services, including personal care services like ADL supports, but also skilled nursing and therapies provided by staff on site. They're also, because they're typically providing services to more than one person at a time, it's an opportunity for recreation or socialization that folks might not have. This is another reason we were worried at the beginning of the public health emergency because, it's a concern that our seniors are isolated. And it was a great concern at the beginning of the public health emergency that people would be especially isolated. And during the PHE, we sought and received approval from CMS on certain flexibilities that allowed our ADHPs to conduct services remotely. And so they were an important touch point for some of these seniors that use ADHPs throughout the public health emergency, and they've continued to operate till now, and most of them are operating in a fully in-person.
Okay. Let me go back really quickly. Public witnesses testified that Liberty had a 60-day wait list for assessments. What is DHCF doing on that front?
So I mentioned that until November 1st, those assessments were being conducted remotely.
Yeah.
We restarted in-person assessments because we felt that it was safe to do so, and that gave us an important on-ramp in case there were any operational sort of bumps and bruises that we anticipated before we had to resume eligibility redeterminations. As Melissa mentioned, the inter-RAI is used for determining the nursing facility level of care. And so it's a key feature in our eligibility renewals, a complete renewal for a person in the EPD waiver or in a nursing facility. We have been doing these assessments virtually for a really long time. And while we, throughout the public health emergency, assess the comparative validity of remote assessments, and we believe that we generally we're doing a good job during the public health emergency. We see the value of conducting an assessment in person.
So the delay is just a result of the transition now where
yes,
before you could hop on a Zoom and do maybe 15 in a day, and now
there are a couple things. One, our vendor did staff up in advance of that November 1 date, but they lost more staff than they anticipated.
Interesting. Okay.
So there was some turnover. They've hired new folks, but as I mentioned, there's a QA process, and those new folks are subject to they're paired up. And so even though they have more staff, they're doing fewer assessments, but we've gotten, part of this runway period was to ensure that we got through some of these things before the timeline started to imperil our renewals.
Okay. So I want to check in on this when we come back for the budget to figure out like whether or not the wait list, if we've gotten through it or we're thinking of another avenue here so that folks aren't waiting 2 months. Or is 60 days not accurate?
So I think the average of the last week was about 26 days between request to assessment.
Okay.
I would like to note that some assessments are being scheduled far into the future, but that's to allow the vendor to triage urgent requests. So folks who are leaving the hospital, folks who have a certification date that's very close. We often get assessment requests that should have been submitted 60 days ago because that person's due for reassessment on their annual recertification timeline, but we got the assessment request, or we had multiple withdrawals because the requests were submitted in error. So there's a lot of things that feature into it. There are some being scheduled way in advance, but that's certainly not the norm. And that's in order to accommodate some flexibility on more pressing assessment.
Yeah. So let's talk about workforce, because your vendor is having workforce challenges. We're having workforce challenges. In your responses, DHCF reports that implementing the Direct Support Professional Payment Rate Amendment Act of 2022, which for those watching at home provide a supplemental payment to providers in FY23 and 24. And then we'll be implementing the new rates for direct support professionals by January 1 of 2025. Okay, in FY23, the rate will be 110% of the living wage before increasing to 117.6% in FY24. But as I discussed with public witnesses this morning, this is for the average wage, not for the minimum wage. And so I want to ask, why do you all believe that this is still sufficient in our workforce challenge environment?
First of all, I think the notion that the district needs to pay, I think somebody quoted a figure of over $24 an hour.
24 and 24.
Yeah, I just don't think that's feasible from the standpoint of a budget perspective. That's a lot of money.
Do you know how much we pay substitute teachers in this city?
That's not the point I'm trying to make. I'm trying to say to shoot the wage up to $24 an hour from its current level is a big number. And we believe the approach that Angelique and her team expertly devised, where you accomplish two things. You give home health agencies the ability to reward their longer term and more experienced workers with a substantially higher wage than the living wage. That by the end of 24, it's almost $23 an hour for a high level employee. That's a significant. I don't think there's any home care agency in any jurisdiction east of the Mississippi that pays that kind of wage. No, I haven't seen it.
I understand that, Director, but in the employment environment that we are in the district, in our region, I'm not even going to say the district, because as you say, our borders are, what do you say, porous? I love that word. That I think we have to take into account what are the entry level salaries, and if we actually want to recruit people into this work so that it is not a job of last resort.
Well, the living wage in the district, and we didn't come up with the calculation. It's been around for longer than this issue has. $1,650 effective this year. We will pay at least that or more than that start in 23, and you can make substantially more than that in 24. And I think one of the questions is, it's never been answered by the home care agencies. We asked them, if you think your employment shortage is a function of you not paying a higher wage, why don't you pay a higher wage?
But then they'll say the reimbursement rate is not high enough, or at least that's what they tell me.
And the reimbursement rate is not tailored to pay everybody. Say they wanted to pay them $24 an hour. The reimbursement wage is not set up to pay that. But if they decided that they needed to, in managing their own workforce, that's what they needed to pay, then we would have to look at on the cost side through their cost reports to determine if and how much we would need to adjust the rates that we paid them.
Mm-hmm.
But my guess is they don't want to get out in front and take that leap without a guarantee that they will immediately get reimbursement. But I think this approach, this tiered wage approach, is a very good approach. I mean, I've never been overly convinced that this issue was purely a wage issue. I just don't. I've not been convinced of that.
Okay.
But at the same time, I think DSP workers need to make more money, and I think certainly those who've been doing it for a while certainly need to make more money. And I think this structure does that.
So going from that, when's the last time that you all did a rate study for home health?
And so in two years ago, we tried to work with home health agencies to better understand their cost. We do request cost reports. Home health agencies' rates are based on living wage. We try to consider cost. However, because our home health agencies provide multiple services.
Can you just move the mic closer to you? So
provide multiple services to our residents, it's important that we look at cost reports. And when we do cost reports and request the cost reports from providers, we have not received a requisite sample. And so because of that, we go through the audit process, but if the providers aren't submitting the cost, we're not able to analyze across the industry, what are the costs that home health agencies are bearing.
okay, so they are not, or I guess 2 years ago, providers were not engaged enough in this process for you to have methodology, enough insights to actually make a determination.
We were able to make adjustments to their skilled nursing services.
Mhm.
We met with them on the regular basis to better understand what their concerns were. We addressed the skilled nursing concern while they still have concerns that the adjustments weren't sufficient and the annual increases aren't sufficient. Again, we asked for their cost reports, and we're currently undergoing auditing their cost reports now. In addition to that, we've put out a solicitation. We've recently pulled that solicitation back for the home health rate study, and we're expanding it to also include case management, because what we want to make sure is as we invest in doing a home health rate study, we want to make sure that we're ensuring that their care is coordinated as well. And so this is one of the many efforts that we're using through the HCBS ARPA funding.
Mhm.
And so the rate study will include the analysis of what services are being provided, what other states are doing. It will also look at rates and cost, what should be included. And then the contract will also include technical assistance support to our providers once we implement, because what we want to get away from is a unit-based rate where you just get paid more to provide more services,
Yep.
but more so whole person focused, and shifting to more value-based rates, bundled rates that will help us get to better outcomes and address what each individual needs. So it's an expansive project that we want to do, but I think it'll get us to the goal that we're trying to get. We'll also be able to get more cost information
Okay.
through the rate study.
Okay, so you pulled back the solicitation. When do you anticipate that going out?
So I'm working with contracts and procurement right now. I had to update the solicitation
Mhm.
to include the case management information.
I see. Okay, so
Yes.
does healthcare finance, do you have an independent procurement authority?
No.
No.
Okay, so we're talking about OCP when you say contract procurement.
Yes.
All right. Our good friends over at OCP.
Mhm.
Okay, great. All right, we'll check in terms of the progress there. I will say this, there were a number of, I met with some folks from for the Coalition of Long-Term Care, and they are, in terms of the direct service providers, they are trying to make a case that this is very similar to what we face in the childcare market. And so they're asking for what we did for childcare to do for direct service providers.
Mhm.
The difference, of course, well, there are lots of differences, but the largest difference is that there have been studies done. So we kind of knew what we were talking about here in terms of what people were making, what the real needs were. And then sort of going forward on that front, there was a very large sustained campaign around raising the wages for childcare workers for that to be an increase in the pay scale. I'm not saying that this is any different, but it seems as though I don't have the same information that I had when it came to childcare workers.
All right.
One thing that we did do through the enhanced wages and working with the associations and meeting with different community organizations and advocates and providers, we were able to kind of limit, what are your concerns? What are the main things that need to be addressed? And their concerns were having a person that's coming in entry level, knowing that they have a career path within that job, not that they have to gain another certification to be able to make more money. The other suggestion that Medicaid could focus on and try to help them determine how they would move forward is also coming up with a rate that aligned with what that workforce makes across this area. And one of the items that you'll notice that we put in Deputy Mayor Turnage written testimony, is you'll see a chart where the district pays more than anybody else, not only to our DSPs, where we're paying $16.50. You'll see that Montgomery County, you'll see Northern Virginia and the state of Maryland pay much less than that. You will also see that when it comes to paying providers for personal care aid services, again, the district pays more than our surrounding counties and states. We pay $24 an hour for PCA services. Maryland and Virginia pay $22.
But I think in this case, it's not just around what the comparing jurisdictions are paying, it's what comparative sectors are paying, right? If I can go be a barista at Starbucks and minus the hours of 7 to 9, where it's very chaotic, and if I'm in the business district, right? I don't have to lift people. I don't have to do the bed changing. I don't have to do all of these, the direct service provider work, this is very labor intensive.
Absolutely.
But if I can make the same amount, if not more, in another sector that doesn't require that. So I think we have to sort of think about it in a different paradigm, but I'm glad that you all are doing the solicitation so that we can continue to move this forward. You said that the supplemental payment to providers in FY23, when will they get that money?
And so we have said that we would give them the funding by the end of February. Part of the delay.
Okay.
Part of the delay. So we have to have a requisite sample from the providers. And again, just like the cost reports, we had 285 providers that would be determined eligible. That when we looked at the list of providers that qualified, we estimated that it would be 285. Of that, we've only gotten 114 responses. That's 40%. That's with meeting with the association. That's with sending emails and having conversations. And
so why aren't they responsive?
Well, that is part of our problem. And because we're trying to make sure that we have parity across all of the agencies, I could submit the request to make the payment for just, for example, DD waiver providers. But if they begin to pay more on the DD waiver side, then our DSP workers that work in home health settings or in other settings will begin to flock. So where I may be resolving a DD waiver problem, now I've created a worse workforce issue in home health agencies. And so what we're trying to do is make sure that we're able to issue the funding at the same time, but we need responses. So we continue to do the outreach, but 40%, and we started this in November.
So I have a note that says the long-term care folks said that the application was burdensome.
It's going to be burdensome because we need information. The information that we requested is that their financial people should have and should be a part of their cost report. And anytime they submit information to Medicare, or when we've asked for information to understand your cost. What we requested is a list of all of your workers how much you're paying them, when they started, how
Okay.
many hours do they work? That's all. The
So
rest
that's
of-
all stuff that should be part of payroll.
Yes, it is.
So
And I can show you the example.
some of these are small businesses. I understand back office perhaps, but in my head, I'm thinking this is a QuickBooks report.
Yes, it's a very, it's tedious. I would say that it's tedious because it's time consuming, but it's very important because that sets the base of how much the supplemental payment needs to be to a particular provider.
Okay, so I will say this, for all the long-term care, home health people who are listening, is it your intention? So basically, and what I'm hearing you say is that until we get the sample size up, we're not releasing the money.
No, what we've decided, we can't hold it off anymore. We've held it off. We started this process in November.
Yeah.
Our original goal was to give it to them before it was time to implement it, which would have meant giving them a payment by December 31st. We held off, and that's why they haven't received the payment thus far. But those that have submitted the information are becoming rightfully impatient.
Yes,
Because this goes back to January. And so the requirement to pay goes back to January 1.
Right.
So what we committed to them is that we would send out a transmittal and that we would begin the process to pay and process payments by the end of the month, at the end of February, which means they should get payments no later than the following Friday in March.
Okay, but anyone who hasn't submitted the information yet will not.
No, they will not get the supplemental payment because we don't have a basis to be able to determine what their supplemental payment should be.
Okay. I'm not as concerned in that we had a similar situation with childcare in that there were people who needed to see that the payment was real before they went and filled out their paperwork. When they saw people getting their checks, they were like, oh, okay, they are actually telling the truth. Let me go ahead and do my thing. But I will probably follow up with you all on that front.
And Madam Chairwoman,
Yes.
I would add that the chance of us, or the likelihood that we would advance a proposal that would be different from the tiered wage scale that is already in place is next to zero if we can't get legitimate cost reports from more than I would like to see 100% participation, to be honest, but it's not realistic probably. But I'm not going to personally try to advance a request for some wage increase of $24 an hour for every worker, regardless of their years in working in home health, without clear evidence that home health agencies cannot afford to make those payments under the wage structure that we currently, the payment rates that they currently receive.
Okay. Got it. Okay. In FY22, healthcare finance budgeted about $4 million for the Medicaid home and community-based services for individual and family support waiver. That's a lot. IFS. Okay. I got to say it out because everybody got acronyms and not everybody knows. But anyway, what this program does, it allows district residents with intellectual and developmental disabilities who live in independent environment to receive home and health and community-based services. You all ended up reallocating a majority of that funding, only spending $216,000. Can you explain the underspending here?
Go ahead. You can,
It's low.
go ahead.
There were far fewer people enrolled in that program than we anticipated when we formulated the budget. So the money was simply not needed for that program. So it was moved to other areas where there was need.
Okay, so there's no one who is like on a wait list somewhere or anything to that effect. It was just not enough people. Okay, I'm out of time and I see Councilmember Pinto here. If she's still here.
I'm here.
Okay, great. You have a 15-minute round. At the table now, I don't know if you can see, Deputy Mayor Turnage is still here, but there's some folks from healthcare finance who are at the table now, but his staff from the DMHHS is also still in the room if you had questions on that.
Great. Thank you so much. I appreciate that. I will kind of return back to your DMHHS hat, Deputy Mayor, if that's all right. And kind of want to pick up where we were just talking about in my last round with the district's policy on encampments and Mayor Bowser's position. You were talking about, to paraphrase, the kind of dual balance of not believing that people should live outside, should have to live outside, that we should be providing options for people to live inside, and also not criminalizing homelessness. And I want to just drill down on that a little bit more, to understand what the policy is for making a determination that an encampment should be closed, and what some of those factors that are considered around health and safety standards for the people living in the encampment and the surrounding neighborhood.
I'll start and then Jamal can finish. The health and safety standard basically amounts to my team headed by Jamal telling me that this encampment is no longer safe or creates significant public health hazards because of A, B, and C. And then based on that conversation, we huddle with our attorney and decide whether or not this is a justifiable reason for closure. Now, we've closed the first encampment that was closed when I was in my infancy as a deputy mayor was on K Street, and I sort of was a detached spectator because I didn't even understand all the policies at that time. That encampment was closed because there was no room on the sidewalk to accommodate passerbys without having to step down in traffic. And that encampment was closed. And then we had Jamal and his team, presented public, health and safety conditions at both Noma and New Jersey and O Street. So I can let Jamal talk in more detail about some of the things they consider when they assess whether or not an encampment has reached a point where the public health and safety concerns are sufficient to warrant an action of closure.
Thank you, Deputy Mayor. So first, I want to talk about the fact that the encampment response team during the past fiscal year conducted well over 250 bulk trash engagements. And while I reference that, their importance is we've sought to not just arbitrarily schedule sites for full cleanup engagements that could otherwise be mitigated by outreach engagement, being able to get the residents to buy into the fact that we are there not to disrupt their placement as an encamped resident at that location, but to remove the health and safety concerns. So if there's situations of bulk trash, bulk items, biohazards, whether they be human or rodent or otherwise, if there's a situation where we have a encampment site where the residents have chosen to partake in intravenous drug use and there are sharps that are present, those are some of the direct concerns that we try to address with our bulk trash engagements. We'll also have our biohazard team come out and engage those particular sites to remove a lot of those hazards without causing a full cleanup alarm or full cleanup removal of those items. Now, as we continue to work with our encampment residents throughout the district, should there be a situation where the continuous engagement of the bulk trash engagements or even full cleanup engagements, which do not close the site in and of themselves, if there's a situation where those health and safety concerns continue to be ongoing and or cause a situation for the community and the encamped resident that cannot otherwise be mitigated, then yes, we will have to close that particular site accordingly. Now, we'll continue to do that. We'll continue to address and assess whatever health and safety concerns on a site-by-site basis. Again, this is not a blanket approach, so we look at every site and the challenges that it presents, how we can work with the residents to address those, and how best to mitigate them from returning again.
Okay, thank you so much. So what I'm hearing is that accurate to say it's site dependent on the circumstances there?
Yes, that is correct.
Okay.
There's a general standard that we apply, and that is, are there unabated health and safety risks that have not responded to our cleanup efforts? And if so, then based on what we perceive at that site, we would institute a closure.
How are you, Deputy Mayor, working to coordinate with all of the agencies that are involved in the housing and lease up process? I heard you talk earlier about this bubble of delays with DHS, but what is the plan to mobilize the vouchers that are available and make sure that they are effectively handled with outreach, with matching, and ultimate lease up?
Well, they're pursuing several paths, but and DHS is much more adept at discussing this than I am. One is we're looking at the purchase of site-based housing units where there is a possibility of the district buying a building that's already constructed that we can use 100% for persons with a voucher. That process is well underway. Secondly, in addition to looking at site-based houses, we're looking at the prospect of using master leases, where we work with a landlord, and we become the leasee under a master lease, where the lease reflects the cost of not just a unit, but of some of the security and other things that are necessary when you make an apartment available to all persons who are on vouchers. And then we also maybe factor in the cost of having on-site case management and maybe clinicians on a regular basis, and use those master leases to more rapidly expand the availability of our units. And then we can still go to the private market for market rent apartments. That has been slowed a bit, obviously, by some challenges. And then the other is to work with the housing authority to help in any way that we can, help them expedite the rehabilitation of some of the public housing units. It's not because of the nature of the problem, it doesn't lend itself to an overnight solution, but we have several things in the works that we hope will help us get that 800 number down to a point where it is certainly more manageable. But again, this is something that I would recommend a more detailed and discussion with DHS.
Okay, and what is the basis of that 800 number?
I mean, when you said basis, what do you mean? That's the number that has been reported to me by the leadership at DHS. And that number,
Well, sorry, are those the people that are
those are folks
eligible for vouchers but awaiting housing?
These are folks who have been matched to a voucher, but they don't have a unit.
Okay, and where are those 800 now?
Well, I think they're all over the system. Some are in shelters, some are in tenant encampments, some are living outside but not in tenant encampments. Some may be living with family members. So yeah, they're in multiple places.
Okay. Let's talk a little bit about the current shelter options available for folks, because one of the other things that we hear often is, well, there may be beds available, but there may be other challenges associated with a particular shelter. Some of that's to do with being in a congregate setting with other people. Some of that's to do with safety or other challenges. What efforts are underway for improvements to our current shelter system? The
DHS is constantly evaluating its shelter operations, to look at ways to make them more attractive. We have, as we are in hypodermia season, we expanded the number of low barrier shelter beds to include maybe some rec centers or other places where we can put beds in a cost efficient manner. And the last data I looked at indicated that that capacity is 1,500 now. So we have 1,500. There are 1,500 slots made available through the shelter system. The last time I looked at the data, which was I think this morning, last night's report indicated that we have 100 vacancies. So on the one hand, I am not going to suggest that there are no problems in some of the low barrier shelters. But at the same time, you cannot dismiss the fact that you got almost 1,500 people who are staying there on a nightly basis. So it speaks to, the fact that whatever problems exist and they need to be addressed, it is not, they're not so prohibitive that people aren't staying there. And so the shelter system that the district has is one that they've invested almost $90 million in. And it behooves us to make sure that they are operated safely and under common sense rules. And I think it behooves others that once those determinations are made, that they sort of dial back to talk that shelters are not an option for emergency housing. It's not, it's not we have never stated that shelter is permanent housing, but it can help you in a pinch, especially during a pandemic. And so we can move on parallel tracks. We can try to make the shelter system the best that it can be. And at the same time, try to increase the permanent housing stock that's available to residents who live in shelters and also they're living on the street.
For those residents who are eligible for permanent supportive housing vouchers and are placed or have used those vouchers all over the city, how are you coordinating follow-up for additional services that voucher comes with?
The case manager for that placement is responsible for determining the needs of that particular resident and whether or not assessing whether or not the wraparound services that are currently in place are sufficient, need to be modified, expanded, and then they are supposed to manage that case as the term case manager applies. And that's, again, not to beat a dead horse, but that's one of the reasons placements have slowed, because we don't have case managers to assign to and work these cases. And it would be folly to put people in apartments, particularly folks who have some challenges with mental health or other issues, without adequate case management service, because that placement will collapse under its own weight.
Yeah. And I know you've talked a little bit about this today with the staffing challenges, but what is the plan to bring on more caseworkers and case managers?
It's a difficult it's a difficult tightrope walk. The obvious solution that would suggest itself is to lower the qualifications for people to become case managers. But Jamal warns me all the time, if those standards are there for a reason, and if you eliminate them or significantly modify them, you may impact the quality of the service. But I think that is the first line of action that the agencies are considering as a way to get more people to come to work as case managers.
I'm sorry, you cut out in your last sentence.
I said, I think that's the initial approach that's being considered by the agency, the relevant agencies, as a way to get more case managers into the pipeline.
Okay, and I know I'm about out of time, but very enthusiastic about this continued request and idea to purchase specific sites. And I think hotels are really well suited for this. And it's one of my top requests for Mayor Bowser for this budget cycle is to purchase up to 5 hotels to use for this purpose, especially with the PEPV reimbursement set to run out soon. And so we have to, as I know you know, work proactively to make sure that there are spaces available for folks. So looking forward to continue working with you and your team on all of this. And thank you very much.
Absolutely.
Thank you, Councilmember Pinto. I'm going to turn back again to healthcare finance. I have one more question in terms of our seniors. In FY22, you all budgeted $9.4 million for the programs for all inclusive care for the elderly, PACE, which provides comprehensive medical and social services to certain frail and community dwelling elderly individuals. However, it appears there were no expenditures in FY22 and the funds were swept. What happened here?
Yes, PACE is a new program for the Department of Healthcare Finance. It will launch on March 1st. So you did not see expenditures in the last fiscal year because we had delays in standing up the program, and we are moving forward.
So it will launch this March 23. Okay.
Couple weeks, fingers crossed.
Great. Okay, let's talk about DCAS. Director, DCAS serves 3 of our federal programs, correct? Medicaid, TANF, and SNAP.
Yeah, well, yeah, Medicaid, TANF, SNAP, federal programs, and then you have the Alliance. There's children's, but there's also in there a housing, in there another program, smaller program from HS in direct. Yeah.
Can you introduce yourself for the record?
I'm sorry.
No.
Hi, my name is Tamika Fitzgerald. I am the DCAS administration director.
Ah, okay. Everybody over here, a little hot seat chant. Don't worry, I'm gonna get to the rest of you. Okay, so because that system touches so many different federal agencies, are there any federal agencies, like who's responsible for reviewing the integrity, the functional integrity of the program to make sure that we're meeting federal standards?
So our oversight agencies are CMS, Centers of Medicare and Medicaid, as well as FNS. And
FNS.
Yeah.
The food, yes.
Nutritious services.
Okay. Has anyone raised concerns, either of those agencies raised concerns about our systems to date? Well, in the last fiscal year.
Yes, so we have had concerns raised about the system, mostly around the excess of the usability of the system now that we have.
For external.
Yes.
For beneficiaries, okay.
Yes. The number, how long it takes for, cases from the SNAP side, like the FNS side, how long it takes for caseworkers and or the public to submit to get an eligibility determination.
Okay.
CMS has not had any formal feedback that we have had other than some usability issues that we are working on as well.
Okay, so when you say we're working on those issues, who are we working with? Like, we contract out with a vendor, yes, for DCAS, or are we working?
No, we have an in-house team primarily.
Okay.
We do have some vendors that we do work with, but primarily we are right now in-house. We did have a system integration vendor that our contract ended last year when we did our final major implementation to add all the non-Magi programs into the system.
Okay. So when we are doing some updates, this came up when we were doing the original website for COVID vaccine. Y'all remember those, the good old days of 2021. But that perhaps in designing our websites, we needed to actually have some users test it out to figure out what was working, what isn't. Is that what is happening now?
So it is not currently happening.
Okay.
But as we have received a lot of feedback from our district residents, from our stakeholders, from our partners of the usability issues, we are partnering with with our partners at Department of Human Services. And we will be kicking off a project in which we are making updates to the system for usability issues. And we will be addressing those types of concerns that we have. And as a part of that, we are bringing in the public, some of beneficiaries, a lot more sooner than we did previously or anticipated with surveys. I know we did a survey. We partnered with DHS last year. We sent out a survey to see what they wanted, what they were looking for as far as, how long did they anticipate an application could take if they were applying for one benefit versus 3. So we have started to do some preliminary research to get that information. And now we, once we kick off what we're calling the harmonization project, we have done it internally. We are also partnering with a vendor who specializes in that type of usability and bringing in, they've worked in other states like Michigan and others in Massachusetts, and they have targeted on bringing in beneficiaries, getting that feedback so we can have a system that that beneficiaries can use more efficiently and effectively.
Okay. I'm glad to hear that we're going to address some of the usability concerns. I'm asking for a variety of reasons, but mainly because, did this bill give SNAP a raise? I hope y'all are going to give SNAP a raise, but that's a whole separate conversation we can have during the budget. Not y'all DHF, but y'all Deputy Mayor and the Bowser administration. I just want to make sure that the system can work. In FY23, DHS transferred $12 million to healthcare finance for the DCAS program, which was a significant increase from the $5.5 million that they sent in FY22. Can you guys explain a little bit of what happened here?
I believe that's just the ongoing operations of DCAS. The DCAS system is cost allocated across all of the federal programs. We have a cost allocation appendix as part of the APD that talks about how the DCAS is funded. So we have local funding, Medicaid administrative funding, and importantly for DHS, we have SNAP funding, food and nutrition service funding. And so as that cost allocation appendix changes, it's based on certain statistics, and the needs of the DCAS program changes, it affects how much money we need to get from DHS because our FNS funding flows through DHS. Okay.
All right. Thank you. I'm going to get into a round of budgetary type questions and it's just going to sort of hop around all the various places. So in FY22, you all allocated $10.7 million for permanent supportive housing, but had no expenditures. And around half of the funding was reprogrammed. What happened here?
Can start off if you want. So we launched the Housing Supportive Services Program last year. I think the effective date ended up being May, June, or July. And so by the time we launched the program, enrolled providers and started reimbursing for services, I think it was potentially just towards the end of the fiscal year or moved to the start of the current fiscal year. So it's really just reflective of where we were in the implementation process and when providers were able to bill for services.
Okay. I think we have a couple of these situations where we made some budgets, but then we didn't do everything that we thought we were going to do. So let's talk ARPA. In the original spend plan, healthcare finance had $2.48 million in FY22. Let's discuss a little bit of the things. So you had the transportation services for moms to care for Medicaid and Alliance enrollees for travel to and from prenatal and postnatal postpartum appointments. It appears that you all were able to spend all of that $480,000 in FY22. Is that correct?
Yeah.
Yes, it is.
Okay. So do we need to invest more money?
That the 480,000 actually supplements our MCO payments for Alliance, and it's currently a part of our budget that we submit annually.
Okay.
And the 480,000 assisted in getting that done.
I personally am very excited about that you spent all this money because that means that people are getting to their appointments, or at least we're spending down. Go ahead, Director.
Oh, I just wanted to add to Angela's comment that the mayor's budget was sufficient.
Okay. Okay. The third ARPA project that you had is practice transformations to support healthcare providers in delivering whole person care across the care continuum. That's a lot of words.
That's Melissa's personal project.
Yeah. Okay, so there was 1.5 million in the spend plan and about 811,000 spent. First off, what is this? Okay.
Okay, so it goes back several years ago, just in starting when we implemented the first health homes program. It was focused on behavioral health services. It did not have as much take up as we wanted among providers. It's a different way. It's like a team-based approach to care. Then we moved forward with a second health homes program focused on chronic diseases. Based on the lessons learned from the first one, we realized we really needed to provide technical assistance to providers on how to change how they deliver their care to actually become team-based approach versus just, one person physician goes in and doesn't talk to anyone else. So since then, what we've learned as we are trying to move towards more value versus volume is that our providers need technical assistance on how to make the changes to their practices to actually support team-based care. Look at population health data to support how they do their work. So the practice transformation is part of what helps us get there.
Okay. You all have about 1.5 million budgeted in FY22 and 24 for this project. Do you think you'll be able to spend that?
I believe so.
Okay. Now that you've done a little bit of work with the providers on that. All right. In FY23, DBH is budgeted to transfer 30 million to healthcare finance for Medicaid claims for mental health rehabilitation services, which is a significant increase from the 5.7 million they transferred in FY22. Can you explain this increase?
Part of the increase is dealing with the growth in the enrollment in the program overall, because MHRS services serve the entire enrolled population. And also it's in part that the 23 budget or 22 budget rather was too low. So
Okay.
23 is more of a correction.
Okay. For FY23, DDS will transfer 83.8 million to healthcare finance for the home and community-based services program. That's an increase from 68. Is that also a reflection of more people?
For DDS, I mean, I think it may be a few more people, but I don't think that's the main driver. I think DDS is more cost. I don't know if you want to add to that.
Yes, DDS is more cost-based. And making sure that we're able to support the additional costs that are related to any PHE costs that we have. When you look at the costs that we include in the budget, it's going to be sufficient to cover all of the enhanced wages that we've included, similar to the other waivers, to make sure that we have sufficient funding.
Okay.
And so that's why you'll see that increase, because we're continuing the PHE. So it's a combination of cost and utilization.
Okay. Now I see that DHS is transferring 14 million to you all for permanent supportive housing. But we just talked about how you didn't spend your money. So what is this piece?
And to add on to what Melissa said before, last year the program had not started, and therefore that's why there was no spending. It didn't start when we planned. However, we have been able to start the plan to support participants that are eligible for Medicaid that are in the program at DHS. And so we have planned based on the current enrollment that we have and based on the amounts that we pay the providers. We estimate that the cost will increase. And so that resulted in the amount that DHS is sending us this year.
Okay.
So it's a fully implemented program for 12 months this year.
Okay, let's talk about CHIP. In FY21, there was originally an approved budget of 102 million, but only 63 million was spent on various programs. And I think I know what that is. COVID and people who were going less on care. But in FY22, the approved budget was 91.6 million and only 53 million was spent. So what are the challenges associated with getting CHIP funds out the door?
Yeah, I'm not, the.
Your mic.
For CHIP are cap payments to the managed care plan. So that, as odd as it may seem, is sort of immune to shifts in utilization. They get a cap payment based on historical costs. And whether a person goes to the doctor or not, that cap payment doesn't change.
Okay, so what
good question.
accounts for the decrease? The decrease, is that MCO based?
Well, capitation is MCO based. It's largely been enrollment fluctuations. I believe.
It would have to be.
Well, not so much actual enrollment fluctuations as because you're comparing budget to budget, right? Not
Yeah, I'm
actual spending
comparing
to actual spend.
FY22 to FY21.
Right.
Or sorry,
to 21.
Budget versus expenditure? Yeah, FY21 budget versus expenditure. So you had budgeted 102, you spent 63. FY22, you budgeted 91. Well, 97 if we're going to round up, and only 53 was spent. Can you guys follow up with the committee
We'll
on
get
that?
back to you on that. I'm sorry.
Okay. We'll come back to that. Okay. So we looked at all of the service lines that contain FNS, which I believe in this case stands for Food and Nutrition Services, correct? Or is there another FNS acronym that could be in your budget?
I think that's food and nutrition.
Okay, so it appears that the bulk of FNS services are within information technology. Can you explain why that is?
Yes, and are you looking at FY23?
No, I think it was FY22.
Okay, so within DCAS, we have various projects. Various divisions. And within one of those divisions, it's the IT division that focuses, and Tamika could probably elaborate, but it focuses on the IT portion of it. And so that is, when you look in our budget and you look at how DCAS is allocated, that's how we allocate the SNAP money.
Okay, but so in FY22, it appears that spending on our FNS lines was only 6.3 million out of the 10 million we approved. I guess.
Our FNS funding is very much subject to the cost allocation for DCAS. And so keep in mind that we do the budget, or we formulate the budget almost 2 years in advance of the year actually occurring. And then we submit the advanced planning document the summer before the year, which has the cost allocation appendix. And so the cost allocation appendix is going to determine of the costs, of the allocable costs of the DCAS system, what portion is allocated to Medicaid, portion is allocated to local programs, what portion is allocated to SNAP, what portion is allocated to FNS. So that can, basically it becomes a timing difference of what we budgeted back, in, the previous September, and then where the cost allocation lands in the, August before the year begins.
Okay, but I guess I'm sort of thinking too, the bulk of FNS money on the actual programming piece would probably be sitting on DHS budget, and you all have the IT because of the DCAS piece. Is that okay?
That is correct.
Thank you. All right, this is it all is, I know this seems tedious, I'm sorry, but this will help us get faster through when we get to the budget hearing, sort of having a baseline here on some of this stuff. Okay, I have several questions about capital budget. There is a $10.6 million balance in the capital project for UMC improvements. Now, at UMC's hearing last week, they reported high maintenance costs to keep the older building operational, but I'm seeing that we've only spent about $7 million of what was budgeted. for UMC. So how are you all coordinating with UMC on the needed improvements of that facility until?
Well, they are supposed to submit their capital plans for approval. We won't approve plans that seem to have a life beyond the closure of the facility. We will focus on those approving those capital plans that are necessary to ensure the safe operation of the current facility. So if they came in and said, for example, we want to redesign all of our inpatient room, we'd say, no, you're not gonna do that because the place will be closing in a year and a half. But if they said, we have a serious flaw in our air conditioning system and that we've tried everything possible, we got to replace the whole system, then we'd have to approve it because you can't run a hospital without air conditioning.
Right.
So that's pretty much the way it operates.
Okay. There are two capital budget line items for GCAS release. Back to GCAS again. Sorry, Tamika. It has a total balance of about 51.8 million. Some of this is federal match. Some of this is release 3. Is this funding for the next phase of the project that we talked about earlier? Okay. All right. There's a $81.6 million balance for the MMIS upgrade, which is the technology you all use to process claims. So what's happening with MMIS?
MMIS, the contract for the new MMIS system has been sent to the provider who was selected some like years ago to start the rebuild. Now, it has to be approved by CMS. So I think it was sent to the provider and CMS at the same time. Once CMS approves it, then the initiation of the work or the work can be initiated. We are very we give extreme deference to CMS because they pay for 95% of the cost. But they also expect that we get this thing implemented within a certain time if they're going to live up to that match rate. So once they approve the plan and the vendor, then the clock starts ticking and we have to get rolling. So it's been a long process, but the delays were largely driven by procurement.
Okay. In your FY22 budget, you had about 24,000 for training and development for employees, but you didn't spend any of this money. Are we not doing professional?
Was it 24,000?
Yeah, we're not doing professional development.
Over the year?
So 21 and 22
Probably on Delaware. Probably didn't do much.
due to COVID.
That's my guess.
No, it is. So throughout the agency, when we budget travel, we base it on the previous year and we allocate it across the agency. The majority of the money is in our agency management program.
Okay.
To provide training across the board. And so people weren't able to do either during COVID.
Okay. So in both FY21 and 22, you all budgeted $10,000 for language access. But you had no expenditures for either year. But given that you manage 2 insurance programs targeted primarily to non-citizen residents, I'm surprised that no money was spent.
Yes, and so we did spend plenty of money on outreach. We have our outreach contracts and our language access contracts in 3 different places in our budget. So you have the language access line, then you have a line for Office of Human Rights MOU that every agency in the district provides $10,000 to $15,000. And then within our healthcare delivery management program, that is where all of our translation contracts are in the budget. We have 3 different contracts that we focus on to ensure that we're able to address all modalities. And that is where the majority of our spending is.
Okay, well, since we're talking about
access.
language access and those pieces, let's talk about the Alliance. So you all started recertifications in October of 22 after pausing during the pandemic. And from the data you all provided the committee, we've seen a significant drop in enrollment from approximately 25,000 to 17,000 for Alliance beneficiaries and 5,000 to 3,500 ICP beneficiaries. We heard testimony earlier today from some folks who said, number one, there was only one notification that was sent. It was only sent in English. and that many people didn't know. So I would love if you could just walk through what was the notification process?
I'm sure for the Alliance program, the first notice that goes out is 60 days in advance of the termination of coverage. So it's a notice that it's time to renew. The notice goes out in the language, the preferred language that's on record. And then at 30 days, a second notice goes out. That's a notice of termination.
So when you say a notice goes out, are we only doing this snail mail or?
It's mostly by mail. You'll see that based on Medicaid, like we have to send everything out on paper by mail. And so I would say that we model that on the Alliance side as well.
Okay.
So we do, the 30-day notice is the termination notice. You have 30 days until your coverage ends. Please renew. In addition to the paper notices though, our managed care plans that actually where the beneficiaries actually receive their services through, they did a lot of text messaging and direct outreach based on recertification dates. And so tried to augment the paper snail mail notice requirements that we have to fulfill.
Okay, so I mean, the feds require snail, but that doesn't mean that we couldn't do email if we had an address that was active.
And now with District Direct, once someone is online in District Direct, they can see all their notices and requirements available at any time that they log into their District Direct account. So we do have that option available to us now.
Okay, how long is it taking on average for someone who has submitted all of their paperwork to get a determination?
If it's submitted through District Direct and we have everything, it should be within the 30-day time frame. Everyone's shaking yes, thank you.
But the key point there is that any decision for a application that has been submitted and it doesn't land in DHS's queue, any decision is held in abeyance until that application is officially reviewed and a decision is made. So if you submitted your application through a portal and for some reason it took 3 months, your health insurance would not be affected. But if you walked it in and handed it to, or put it in a Dropbox, we have since learned that, those drop boxes were not regularly worked. And so we have statistics on the number of cases that have been delayed because nobody was minding the store with respect to the drop boxes.
Okay, so whose responsibility was it to check which agency?
We have it's called an ESA unit that resides in.
What does that stand for?
Economic Security Administration, resides in DHS. They handle the application process for Medicaid and Alliance along with their federal programs.
Mm-hmm.
When we went to District Direct, one of the reasons this was so useful is because it gave people multiple options to apply. We had hoped, because one of the complaints of the face-to-face recertification was that people stood in line 3 or 4 o'clock in the morning just to submit an application. So we had hoped that folks would rely on the telephone, an online portal, or an online portal to submit their application.
Some people are old school. They like to submit paper.
I understand that. So, and I'm not making excuses for, it's not acceptable that you have
How long were those boxes not checked?
Well, we have statistics. If Eugene is around to give you because we've begun to tackle this issue with ESA.
Okay.
Eugene has, he can give you the stats and we also did a sort of an operational review of their process. That was less than flattering in terms of the results. But Eugene, can you give her an update?
Sure. Eugene Sims. I'm the Director of the Healthcare Policy and Research Administration at DHCF. We're responsible for policy changes as well as overseeing eligibility policy in coordination with DHS. So we've been engaged in a community outreach process since July 22, our restart date. And we've been hearing anecdotally from stakeholders that, hey, I dropped off my application or I submitted my application and I haven't received a termination. We inquired with our partners at DHS, hey, is there a backlog? Can you give us an assessment? As on January 27th, DHS shared with us that there were about 1,400 case actions that were above the 30-day threshold, the time of this threshold that we like to set for processing of renewals and new applications. So DHS, in response to that backlog, has reallocated staffing They've, I think, dedicated about 40 SSRs, so those are folks who directly process the renewals and applications to Alliance processing. And they were able to decrease that backlog from about 1,400 as of January 27th to about 600 as it stands today. So 600, that is about 50 or so renewals and about 600 new applications. So those are the stats as of today.
Okay, but how many of those people in that 1,400 above? Okay, so let's go back. So Director, you said that if somebody had submitted their application, we did not terminate if we had not reviewed yet.
That's correct. Now that doesn't account though that they don't look at.
Correct, so I'm gonna get to that. So how many, this 1,400 doesn't account for those that were found in the Dropbox?
So it includes some of those numbers.
How many were in the Dropbox?
I don't think we can, well, I think we'd have to follow with DHS to get that disambiguation. But the outstanding case actions over 30 days, that's that 1,400 number. So it would be inclusive of cases that were submitted through District Direct and not processed, as well as paper applications that were dropped off, scanned into the system, but not fully processed.
I thought we calculated that. Oh, no, we did a breakout on whether or not the cases that were pending were either new applications or pending applications.
Right, I think you said 80 renewals.
Yeah, so I have the exact numbers. As of today, it's 86 renewals that are outstanding and 578 new applications that are outstanding.
I think it's a safe bet that the majority of the cases that are delayed were probably landed in the bin for somebody to pick up when they got a chance.
Okay, have we since resolved the bin issue?
So DHS has case ambassadors who are staffing kind of the front of the service centers.
Mhm.
So the process, and we're encouraging folks. So you drop off, someone is there at the drop box to review the completeness of your application or renewal. And then about 3 times a day or more, those applications and renewals are scanned into the system so that the action is generated for a caseworker to process that renewal application.
Okay. Okay, I'm gonna leave it there on that one. Because you guys identified the problem and you're working to reconcile, but still a 570 new applications that are already over the 30-day threshold. I know that DHS is having some staffing challenges, not just here, but with all of the situations. And so it's just, I don't know how we get more manpower around some of these processes that we need to get done. You all recently changed the eligibility for Alliance to better align with Medicaid income eligibility criteria. Have you seen an impact on who is qualifying now?
No, that's sort of marred by the caseload drops. So we haven't dug deep into those who are currently have recertified or are up for recertification to see if there's been a shift. We do know from previous data that the Alliance population, relative to where it was some years ago, is getting older and more expensive to care for. But we do not know if there's a change in the nature of the population based on the alignment with Medicaid.
Additionally, I mean, it's just going to be difficult to see the impact of the policy changes to alignment, not only on the alignment with MAGI, but the elimination of the 6-month and the in-person, simply because we've been in the pandemic for, we stayed those recertifications for so long that it's going to take some time to really see any impact or to be able to discern if there is an impact.
Okay. Let's talk about Medicaid a little bit. At the UMC performance oversight hearing, UMC leadership described a $4 million decrease in revenue due to a decrease in their DISH payment.
Right.
Can you describe a little bit of the process for determining DISH? And were any other hospitals, did any other hospitals also see a decrease in payment?
Well, our CFO is our DISH guru. He processes the DISH payments every year. I can tell you just in general that UMC's decline came from a change in federal policy. And that, we obviously had no control over it. They got a big bump a couple of years in a row, I believe, because of the federal government had to walk back a change that was made. We had already implemented the change, which reduced their payments. When they walked back, they gave us the money, and so they got a big payment bump. Then there was another change that Darren can talk in more detail that basically says you have to be, Medicaid has to be primary for you to, or for you to claim, I guess, on the cost side. And UMC probably had costs that were attributable to other insurance programs that they could no longer claim. I think Darren can be clearer than I was.
What the director said is basically accurate. There was a federal law change around how uncompensated care cost is defined. And as he said, it was limited then to patients who have Medicaid as their primary coverage. So previously, hospitals could count the costs associated not just with those who have Medicaid primary, but those who have Medicaid and other coverage types, dually eligibles. And so that limitation then limited, the costs. And so it resulted when you run it through the formula, because DISH is a reimbursement for uncompensated care costs, which is composed of the uninsured and unreimbursed Medicaid costs. It impacted UMC, and then it also impacted the largest DISH hospital in the district, Howard University Hospital.
Yeah.
So there was nothing UMC could do about it, to be honest.
Yeah. I recently met with the CEO of Howard and did a tour over there. So heard a little bit about that as well. Melissa, you talked a little bit about the 1115 Medicaid demonstration waiver. Do we have plans to, I think we have plans to renew our request. Do we have plans to add anything additional to our application?
Yes, we're just really starting the discussions both internally and in the next several months, probably summer to fall, we'll start engaging external stakeholders. The way the current waiver stands as is, we pretty much have just the coverage of IMD or Institute for Mental Disease stays covered in our waiver. CMS required that we shift most of the service to our state plan authority, which we have done this year. I think everything transitioned over by July 1st. So looking forward to the next iteration, it really is focused on some of those new opportunities that we've seen approved by CMS in just the past 2-3 months. One that we spoke on earlier, the kind of rental assistance for folks who really don't have a medical reason or medical necessity to be in an institution. A couple other things, just most recently approved by California, it was actually in our original waiver request, was the ability to reach into and cover individuals that were like 30, 69, 90 days pre-release from incarceration. So we can better coordinate services for individuals returning to the district. That is certainly on that list of things that I would like to see in the waiver. And then we'll be looking at other opportunities for now in the waiver world, we're calling them health-related social needs.
Yep.
So looking at some of those things, whether it's HRSN or social determinants of health, where we can better support folks here in the district. So,
Okay. I hope amongst those you will include evidence-based home visiting and medically tailored meals.
okay, understood.
Just something for consideration. Okay. Give me just a moment. I'm trying to determine how I can cut some of this because my staff was overly verbose. Hold on.
You can save some for the budget here. What you told me you couldn't.
Okay, I have 3 more areas to cover. My goal is that we are walking out of here by 7 o'clock. So that depends on how verbose you all are on your responses in terms we are able to finish this up. All right, let's talk about the MCOs. So all but one MCO reported declines in measures related to comprehensive diabetes care compared to their baseline. And that was struck me a little bit because I know from UMC that 40% of the patients who come into UMC have diabetes, even if they're not going in for that. So diabetes care seems like a big thing for us in the district. And I'm just curious in terms of, as you guys are reviewing the external quality review reports, when we see something like this, what is the action on our side to get our MCOs to do better?
I will make one just overarching note, which you'll see throughout the most recent quality report, is that you'll see a lot of notations, references to, declines or changes or not meeting standards. And we do largely believe they're related to the public health emergency and changes in utilization and so forth.
Okay.
Lisa can certainly talk about how we normally follow up with our managed care plans when we see performance not where we're hoping for it to be. Introduce yourself.
Good evening. I'm Lisa Truitt, Director of our Healthcare Delivery Management Administration. We have a quality division who really houses the work that we do with our external quality review organization. And when we see declines, there's often conversations with the health plans. They have a quality assurance and improvement committee. They have a team of staff who work with their medical director. We put them on a performance improvement plan, but it's a collaborative effort with community stakeholders. So if there are community organizations who can offer some assistance to the health plans with addressing these needs with their populations, we essentially collaborate for that purpose.
Right.
I will say that we have been lacking in our quality division with a lead staff person. So that's been going on for about a year, but just recently I have an interim program manager to get things up and running and get us back on track.
Okay. Is that vacancy posted?
It has been posted, but it's on hold. It's been posted many times, but it's on hold now since I have the interim staff person who works within quality.
Okay.
To kind of get us structured as we transition into our new managed care contracts.
Okay. Do you guys have independent hiring authority? You go through human resources too? Talked to Director Maxwell yesterday about some of the challenges there. Okay. So stick with me. I'm gonna talk a little bit more about, so all of the MCOs showed improvement in the timeliness of prenatal care, which is incredible. So that is measured by the percentage of deliveries of a live birth that receive prenatal care visit in the first trimester. And I think for you all, but for the public who is watching, that has been a challenge in the district where we do have quite a number of individuals, particularly Black and brown women, who don't seek prenatal care until their third trimester, which is not great in terms of our outcomes on the back end. Again, in terms of working to improve this outcome, we can always do better. So I think you sort of said it's an ongoing conversation that you all have. Okay, so we're gonna, I'm gonna check in on that from the quality reports. I find them to be very interesting in terms of talking about what we're doing here. And I think it goes to the heart of, I guess, the structural design of Medicaid managed care, where these MCOs should be the ones who have coordinators. Hey, we haven't seen you in a bit. What's going on? And doing all this work. So we just need to keep up the work with that. Speaking of our MCOs, the contracts. Will the readiness activities be completed for the April 1st implementation date?
Yes, we're in the process of readiness right now.
Okay.
We've completed the on-site visit with the Merit Group.
Okay.
There are some follow-up items that we're finalizing between tomorrow and next week. After that, the staff who participated in the readiness review have to write up their overall assessment of what was conducted, the interviews, the review of policies and procedures, just the conversations, review of systems. It was a two-part effort. So we received some initial administrative information documents, like I said, policies and procedures, workflows, and then that was evaluated. And then the on-site visit occurred this week, Monday, Tuesday, and Wednesday. And that's where we kind of follow up with the information that was submitted, the administrative work that was submitted to us. And then having those conversations to have some confidence that what you have on paper is what you're actually going to do, can do, have the capabilities of doing. So we're on track.
Okay. All right. That's good to hear. Now, I mentioned this earlier, but frankly, what we are about to embark on as a city and a health cluster between spring and summer is giving me a little bit of heartburn. So you have the bringing on a new MCO, transferring beneficiaries, bringing in behavioral health providers, ending the public health emergency, restarting Medicaid recertifications. Y'all look real calm for all of this that is going on. So I've asked every agency thus far who has a role in this in terms of the communication, right? Last week, Dr. Bazaran says, Melissa, that y'all speak multiple times a week to sort of get on the same page on that front. Mila Kaufman talked about the work that she's doing with you all to plan out for handing lists, right? So if someone is determined not, the first group, who's the folks who are no longer eligible for Medicaid, all right, we're going to give you to healthcare exchange so that they can get you signed up on that front. Is there a written down plan somewhere?
So we have put forward our first iteration of our operational unwinding plan. It went live on our website yesterday, went out to all staff, I think on Tuesday evening. So it's going to be a living document. This initial focus really is on the eligibility renewal restart. And we will have what we call part 2 issued by the end of the month, which will focus more on the unwinding of the PHE, like the official declaration. There are different authorities that impact Medicaid based on when the PHE ends. So that's kind of, that's our guiding document, if you will. We'll continue to update it and provide more information as we have it. As we presented in our January Medical Care Advisory Committee, or MCAC, kind of what folks should expect over the next couple months. Although we've been planning for the end of the PHEs, pretty much since it started, we didn't really have anything definite until the end of December and then the end of January. So everything kind of came pretty quickly through the omnibus and the end of the continuous eligibility enrollment, which is now March 31st, and then the end of the PHE declaration on May 11th. So with that, it's now we're kind of putting the pen to paper for final stuff. So coming up with our final numbers in terms of number of households we believe will go through the renewal process each month. We are also factoring in the new federal guidance that's coming out. So we've gotten 2 state health official letters in January. There are new requirements because of the congressional legislation through the omnibus at the end of December. So while it doesn't change any of the prior guidance from CMS, there's some additional requirements that we have to align to that we are working pretty consistently with CMS on how that works. So it's not just a district thing. In terms of kind of what to expect, January is really looking at trying to finalize plans as best we can. February is putting forward the operational unwinding plan for public consumption. We are finalizing our communications toolkit so that we have messaging that's available to all stakeholders so we can align messaging. That will be out hopefully within the next couple of weeks. But
do we have a communications budget?
Yes, well, we have communications funding, like we've had a vendor on board with us right now who's done the communications toolkit with us. We have funding set aside to do text messaging, much like we did in at our 2020 transition fee for service to managed care folks. And then we have, in addition to what we have, our managed care plans have their own communications and outreach budgeting.
Are you all hiring additional people to just support?
So our initial
review
right now, the initial additional staff that we are looking to bring on will focus on our call center.
Yeah.
So that's one thing that we're trying to.
So we're doing the call center in-house.
We already have a call center in place. There's
so you're just going to add.
Yes, we're looking to add, I think, up to 15 staff. We're hoping to have that in place before we release the communications toolkit.
Okay.
Because we hope everyone messages. But if we don't have the support at the call center, that messaging won't be helpful at that time. So we're looking forward to bringing on that staff first, and then the communications toolkit to go out and begin messaging. What I think is really important to remember, like that April date is important because our first notices will go out, but this is a 14-month-long process. Not everyone will receive a notice at the end of March. There's going to be a few thousand people every month that will receive a notice. So it's really important that, this will have to be more of a marathon in terms of getting the messaging out, getting people to update their contact information so we can actually reach them, and then making sure folks have what they need in order to complete the recertification timely.
Okay. As you all do updates to your plan, can you share that with the committee? Are the positions posted for the call center?
It's a contract modification for us.
Okay, contract modification. Okay. Okay. That is helpful. With PAHE is also the phase out of FMAP or the FMAP increase. So how will that impact?
Sure. The good news on the enhanced FMAP is that you'll recall it was originally tied to the Public Health Emergency Declaration through, I think it was the Families First Act, or maybe CARES at this point, one of them. But with the Consolidated Appropriations Act in December, the enhanced FMAP was decoupled as well from the PHE. And what Congress did instead, which we greatly appreciate, is we have a year-long phase out of the enhanced FMAP. So prior, it was going to end at the end of the quarter of the PHE. What's problematic with that is that you're carrying enrollment, that higher enrollment, for a much longer period of time. So we would have carried more folks on the program without the additional enhanced federal support. Now we have the 6.2 through the end of March, phases down to, I think, 5% from April to June. I think it's 2 or 2.5 from July through September, and then 1.5% from October through the end of December. And then the enhanced FMAP is completely phased out by the end of the calendar year.
Okay. All right. We're making really good time here. Oh, yes. Are there any particular COVID-related services under your purview that also go away with the PHE? I know I was planning to have a bit of this conversation with Dr. Lewis, DZ Health, because I know it will impact vaccinations and testing and all of those pieces that people they've been getting it for free for a while, and now they're going to have to start paying again.
So for the Medicaid program, testing, vaccine coverage is covered by Medicaid at no cost to beneficiaries. It will continue to be covered.
Okay.
I think we just got the final permanent approval, and we are actually reimbursing, I think, the vaccines at 100% of Medicare instead of our typical 80%, just to ensure that providers are incented to continue to provide the vaccine to Medicaid beneficiaries.
Okay. Okay. All right. Final topic, maternal health. I decided to end on a high note on things. So when we were working on the perinatal mental health task force last year, or working on the language for it, advocates asked us to put it at healthcare finance because they were so pleased with the work that was happening with the maternal health advisory group. And they really thought that you all were bought in and like have a really good conversation and do all of these different things. Why are you guys disbanding the advisory group?
Sure. When we established the advisory group, there are several other groups already in existence focusing on different facets of maternal health. And when we set up the advisory group, we thought we have 3 things to really focus on. We're bringing folks together to do that. And we did that. I heard the testimony earlier today. If there, certainly no issues with reconstituting or reconvening the maternal health advisory group and updating its focus and tying it into the the perinatal mental health task force, however. But it's great to hear that folks appreciated it so much. So if that's the desire.
When people when they look a good thing, you gotta keep the good thing going. I want to commend healthcare finance for some of your major accomplishments in this regard. So the state plan amendments for the extended postpartum coverage from 60 to 12 months, and then the authorization of doula services. I don't minimize, I'm sure, what it took for you all to put that work together and work with CMS to get that done. And so thank you for that. On the doula services piece, are we working with MCOs to make sure that beneficiaries know that this is an option to them? I recognize we have not a high number of doulas who've signed up just yet, but still wanting them to know that this is an option that's available.
Sure. I mean, we've had the managed care plans on board with us throughout the maternal health advisory group. I think they're fully aware that it's a required benefit and working to have doulas in their program. Fortunately for us, most of the managed care plans had doula services available as a value add service. So they have some relationships or connections, but we're happy. I believe we're continuing the discussion, and if not, we can move forward with it as well. But I do want to just note, we are running into the same issue as other states with implementing the doula services and getting doulas actually enrolled. And that's something I do think if we reconstitute the advisory group that we can have a little bit more discussion on, because we had a lot of doula representation. I think what we determined from the benefit and the services and the number of services and the rates were generally supported by folks that were involved. And it would be helpful to see kind of what are those issues that are still, making it difficult or not desirable for doulas to enroll.
And the responses you all sent to the committee, you said that you believe more doulas will register once DC Health rolls out its certification process for doulas. Are you finding that there's a holdup on that end, or are you all having any conversations with DC Health on?
I don't have an update on that one. I can get back to you.
Okay. It's fresh of mind because I just talked to DC Health yesterday about licensing certifications. So we'll get back into that. Let's see. In your responses, you all reported that 87 midwives are now enrolled in DC Medicaid, which I think is great. Of those, 38 billed for reimbursement in FY22. Do you expect this number to grow more?
I really don't know. I don't think it would decline. I think we're seeing more and more midwives come into the district. And I think we see more families thinking of midwives or being aware that they're an option as well. So, but I can't tell you one, there's not a particular policy change that would make me think one way or the other.
Okay. Do you all have information about the geographic spread of the midwives who have enrolled? Obviously, midwives can go anywhere, but I'm just sort of thinking
kind of where they're located.
Yeah.
Not top of mind, but we should be able to pull from our provider enrollment information, like where they're located. They have to provide where they're located. So we can certainly, we can look at where they are.
Okay. Give me just a minute. Okay, Deputy Mayor, I've exhausted my questions on this, and there's no one on the Zoom, so we're going to wrap this up. There's some things I have to say, and then I just want to go over the follow-ups, and then who we should follow up with, or like send the list to, so we can reconcile the list. Oh yeah, I saw that on the org chart. Okay. Okay, so here's what I have. Data on the 100 people who were housed through the Kairos pilot in terms of an update. Are they still in housing? And then also a breakdown of the housing types or housing source payment information. Data on the 10 people in the encampments who were not yet paired with housing yet. I think that might have been McPherson Square.
No, it was like in the people in district sites who.
Oh, sorry, from already cleared sites who were paired with a housing source but had not yet been paired with housing. More detailed budget on the Cedar Hill construction. Councilmember Parker requested information on the number of people deemed eligible who have vouchers but have not yet been matched with housing. You get back to us on the DC Health certification for doulas and what's the holdup there, and then the geographic spread around midwives. And then we'll go to, you said it's on the website, the plan, the unwind plan.
Yes, but we'll send it to you.
Okay, great. All right. Well, this concludes my questioning, Deputy Mayor. Thank you so much to you and your team who have been here. If we have any additional questions, we'll reach out, but I just went through the follow-up list. For anyone who was unable to testify and speak today, we will accept public testimony until March 2nd, 2023 at 5 p.m. You may submit written testimony statements to Ashley Strange at astrange@dccouncil.gov, or you may leave a voicemail at 202-430-6046. If you leave a voicemail, please remember to speak slowly and spell your name for the record. I will also just mention that the Committee on Hospitals and Health Equity is also having a hearing tomorrow and then next week on this. But this concludes the hearing for today. The next performance oversight for our committee will be a special one. So we will have the boards of medicine, nursing, social work, psychology, and pharmacy before us on February 28th at 2 p.m. If anyone is interested in signing up to testify for those, we have that information on my website. The time is now 6:52 and this hearing is adjourned. Thank you.